Good morning, everyone. So we've had 2 days of very enriching scientific sessions in this Gofcon 2026, and here we are on the third day, Sunday morning. To begin the proceedings, I would like to call upon the chairpersons for this session, Brigadier Chetan Sood sir, Dr. Rajiv Raman, Dr. Sanjay Yadav, Dr. Khurshid Alam, Dr. Vikram Veer. Please come on the desk. Over to you all.
वेरी गुड मॉर्निंग टू द एवरी पर्सन। और आज अमूल्या बॉस को बहुत मुबारकबाद देते हैं कि 3 दिन की इस महफिल को आज भी सुबह 8 बजे से इतने लोग मौजूद यहाँ पर हैं। तो इरादे बुलंद हों तो राहें आसान हो जाती। तो आई सैल्यूट यू फ्रॉम माय कोर ऑफ हार्ट। एंड नाउ आई इनवाइट डॉक्टर शमशुल हुदा फॉर Ilizarov technique in upper limb non-union bone transport and deformity correction.
Good morning all for such a vibrant morning. We had very good discussions about trauma, arthroplasty, spine and all other parts. So now it's time for the rings. For the lack of time, I'll be focusing on forearm only. So let's discuss and see a few cases of and indications of Ilizarov forearm deformity, infections, limb lengthening. So before we start putting any Ilizarov, we must have the basic knowledge of the anatomy and the safe zones of the upper limb, the bony anatomy, the neurovascular anatomy. These are the safe zones where we can apply the rings, the wires, the pins. So we can start with the proximal ring, like the first wire. The first thing can go from the radial asteroid. It's a 2-wire assembly. The first proximal part goes in the radioulnar, the distal part goes in the ulnar radial, and the mid part we can apply 1 wires in the radius, 1 wires in the ulnar respectively. So this is the demo ideal ring where we can have a half ring in the proximal part, full ring in the distal part, and 2 full rings in the mid part. So the proximal wire goes from the at the level of radial asteroid to the ulnar. The distal part goes from the ulnar to the radius. Rest we can have cross pins from either radius or ulnar, so that we avoid the neurovascular bundle for any configuration. If you have to correct deformity, you can apply hinges. So these are the different configurations clinically for non-union, for fracture, for deformity correction and lengthening. These are the basic diagrams for the same. For the upper part, the lower part, and even the wrist, we can apply for the wrist also. For the surgical technique, so this is the ideal demo frame for in the entire upper limb. So this is in the upper limb, the elbow part, medial to lateral, lateral to medial, the proximal radial, and the distal ulnar part. Similarly, in the proximal ulnar, we just apply oblique wires, distal radius we can apply middle part, and the hand part we just apply all the metacarpal necks. This way we can use for the tractions of the upper limb in the humerus and the forearm and the wrist. We can use rings. We can use rings and the wires for the same. So we get a good direction. We can apply freely see the C-arm from this. So let's see for indication the fractures. So we can starting from a similar the regular fracture, we have a comminuted fracture, compound lacerated wound. Usually we'll apply a plate or nail over here, but if we can't apply simply a plate, we can simply apply 2 nails and 1 ring and 2 ring distally and proximally, so that we just avoid rotation. So this is a very basic construct in a forearm fracture, and we can have complete range of motion. We can just remove the rings in 6 weeks only. And similarly, if you have a mangled extremity like this or a compartment, we can just put guide wires or rings and apply forearm rings, and then we can apply hinges for the wrist. And if needed, we can skin graft is very friendly in these cases. So starting from here to here, this a very important part is the range of motion activities of daily life has to be promoted in all the cases. Patient can take watch also. Similarly in the wrist and hand, suppose you have a volar button fracture, you can just apply the principle of ligamentotaxis. One rig above, one rig below with the hinges, we can see a beautiful reduction and it heals very well in 6 weeks only. And if you have a displaced fracture like this, we can also apply just olive oil to reduce this volar part. So as needed, we can just use ligamentotaxis, or we can use olive oil for the reduction and just remove the rings and another 6 weeks. It gives a very, very clean reduction and range of motion. Similar case, olive oil is applied in the wrist. Let's see a case of forearm non-unions. This is a case of post-plating osteomyelitis. You can see a very bad wound. So thorough debridement was done. We just applied, after the reaming, applied guide wire, and the syringe was applied to hold the fracture. And the activities of daily life was started. And just applying Ilizarov and debridement and guide wire, the wound heals very well. We can get complete range of motion. You cannot delineate which arm was healed. So Ilizarov in these cases have a very good role after debridement, and a guide wire and stability is very important in these cases. We can apply the guide wire or not. This is not necessary. So another case of forearm case of non-union. So you can say this is a case of simple tense was applied in a distal radius fracture. It went in non-union and deformity. You can see the free range of motion, it was in deformity. So we could apply a bone graft here also. Instead of applying bone graft, we just corrected removed this part, the sclerous part. We just corrected the forearm part, and we started bone transport from proximal to distal over nail. So this simple case of bone transport, deformity correction, and you can see the final union is very good. We applied the rings in 3 months only. So instead of applying bone graft, you can simply do bone transport over nail with Ilizarov in these cases of non-union, and having a very good results clinically in all these cases. So another case of wrist deformity and limb length discrepancy. You can see a childhood deformity of distal radius. You can see the distal radius deformity and radial shortening also was there. So in this case, you can simply apply a ring and do a gradual correction over hinges in these cases. So the gradual correction was done, and after the correction was done, we just simply converted the frame for the lengthening. So lengthening of the radius was done, and finally from here we can get a case like this. After limb lengthening correction, there was some subluxation of the radial ulnar joint. She applied a loop and no button over here, so getting a final results. So this was the case pre-op and post-op. This was the deformity frame. So gradual deformity correction followed by limb lengthening in these cases gives an optimal result in these cases. The similar case of in the C-arm, you can see the deformity cut was given in this case, and gradual correction was done here, and after correction, lengthening was done. And the case of deformity with LLD, in the pediatric cases, you can see there is a case of brachial achalasia. Differential deformity was done, radial bowing and ulnar shortening was done. So differential lengthening and deformity correction on the both bones was done in this case, in this pediatric case, and finally optimal, you can get a lengthening. You can see the shortening over here, and also the patient couldn't flex the elbow. So we did a osteotomy in the distal humerus also, so that patient can do optimal range of motion, and finally correction was done. So lengthening has been done over here, and the movements has been achieved. So various deformity cases can be done in forearm. And the last case of recurrent GCT in this case. Earlier fibular head was applied in this case. The case relapsed. We just removed the distal radius tumor, and then we did transport over guide wire in this case over Ilizarov. So this was the gap, and finally the transport has been done. The transport has been achieved. This ring is yet to be achieved. You can see a solid callus in this case. So these are various indications of fracture, infection, non-union. I'll go short with this because timing is short. So the take-home message here is Ilizarov and upper limb is an excellent device in complex fracture, deformity, non-union, osteomyelitis, tumor rejection. If proper fixation and follow-up is done, it is a wonderful fixation device. But a very good and training and experience is very important. You should do fellowships, you can do mentorship, and some modular implant, soft tissue, flap, graft is not a problem. It is bloodless. Early activities of daily life can be done in all the cases. So handle the Ilizarov with care. It can be fire or flower. So handling is very important. Thank you.
Thank you, Dr. Shamshul. I think we all will agree these are very complex cases, and you have shown it so many of them, and it's really surprising. One quick question: can you ask the question or the question at the end? Okay. We'll ask the question.
Thank you, sir.
Next one. Can we have the next speaker, Dr. Anand Shankar? Dr. Anand Shankar is here, please. Okay, we can go, if he's not there, we can go on to the next speaker, that is Dr. Vishal Kumar.
We can take the discussion at present.
Okay, so Dr. Shamshul, we can just talk to you. Okay, so we have time. I can definitely compliment you. You're a very brave surgeon. So there are two things I wanted to know. One is about the last case that you showed, that there was a tumor,
yes.
GCT recurrence,
Right,
and then so later on you did a stabilization procedure later on with that.
Exactly, sir. You can see we have applied I can apply either a guide wire or a nail. So we have applied a square nail. It gives a very good stability. Instead of a slab, we are applying a Ilizarov. So the deformity correction has been there. So after once the because we're doing with guide wire, the guide wire is from the second ray and the fourth ray. So once it approaches the drift point, and we see a very good regenerate. After that, we have two options. We can either apply a long plate or simply leave the Ilizarov till the regenerate comes, and gives a very good stability on the cases. So both options are there, sir.
And secondly, I saw most of the cases were those metal frames that you had,
Right.
especially in children, girls, and osteoporotic bone. You had any kind of experience that they've had fracture of the humerus, or because of the weight of the lever arm that the upper limb has? Anything of that sort you came across? You can tell us?
Not yet, sir, because in the upper limb we especially use aluminum rings. Aluminum rings are very light, sir. And we apply just half rings over here, so the range of motion is very good in all the cases. So light rings are very good in these cases. So we can use aluminum or carbon rings. Elbow stiffness in a few cases can be seen. Yeah. Yes.
Thank you very much.
Thanks, sir.
Vishal is having fever, just give me a call. So Johnson, we have got some time. If you have any case presentation, we have got some time. You can pre-phone my wife if you want.
अमूल्य बॉस, ये सर चाह रहे थे प्रीपोन करके इनका उमर बॉस का. Yes, sir. To save the time. Dr. Umair Asrar, how children's children's bones are different.
Good morning. Well, it should have been just before the pediatric session, but yes, it's got pre-pon. So just I'm going to talk about the basic things, which is about the pediatric bone. So how children bones are different. So they are more flexible. Why? Because they are more collagen and thick periosteum, and their modulus of elasticity or Young's modulus are low. The result for that is they go in very big irreversible plastic deformity before the break point. And that's the reason you can miss easily with these important injuries where you see that it's a montagia, it's not just the plastic deformity of the forearm bone. So you can easily miss those, so it's very important. Now the other thing is they have immense modeling, remodeling capacity depending on the age, maturity, proximity to the physis and the plane of deformity. Also, the healing speed is double that of the adults. And importantly, they have the growth plate at the end, which is different from the adult growth plate. And the growth plate is basically cartilage. So they are more flexible and soft. And that makes them susceptible to injury. Basically, there are 4 zones, and which one is there from the epiphysis to metaphysis are the reserve zone, zone of proliferation, zone of hypertrophy, and the maturation. And the weakest one is the zone of hypertrophy, where the fracture traverses from. The reason for that is cells are bigger and the matrix are low. Now, Salter and Harris defined 5 patterns of injury to the children physis. Type 1, which is a physeal shear, but they don't go to the bone, no metaphyseal involvement. Type 2 is a partial physeal shear associated with largely vertical metaphyseal bony fracture. 3 are partial physeal shear and the epiphysis that goes through the physis, metaphysis, physis, and epiphysis. And type 5 is the physeal and metaphyseal crush, and they are mostly not seen primarily. So sometimes just a bulk there, and then after that, they are seen in retrospect. So there exist also complex multiplanar injuries into the physis, epiphysis, and metaphysis, which are not categorized by Salter and Harris. So you can see these multiple injuries, which is in 3 planes. So it's triplanar. Now, Gomes and Walpen in 1993, they investigated the microevolution of physeal bar in Salter-Harris 4 injuries at histological level. And what did they see? That if they don't watertight fix it, then there is a development of bone bar there. So they fuse. So this is more important point. So this one, but if they are watertight, fixed and reduced, then the vascular ingrowth into the fracture plane is prevented by physeal function, and they re-establishes the whole thing, okay, and they proceed normally. So now the attendance is very low. So how many of you are going to treat in a gallows splint or a Thomas splint or a hip spica cast in this? Just raise the hand. So you're going to treat in a splint? Maybe spica? Well, maybe or yes? Yes. Yeah, okay, very good. So it's very, so modeling capacity is very high. So just put it in the spica. We don't put in any splint nowadays, no splint, no gallows, no Thomas, just for 12-hour or 24-hour, and then go into the space, 2-year-old only. So, well, then after that it causes the pressure effect and all those. So almost just for the pain relief for overnight, so that we can get the patient in theater early in the morning. They are first on the list usually. So then that's at the 8 weeks. So 8 weeks, that's the healing. We took it off. It's one of my patient, 6 months, and this is the 2-year follow-up, final. So no limb length and anything. So talking about the other things, the triplanar injuries. So this you can see on the X-rays that you suspect that there is something in epiphysis and something in the metaphysis and so through the physis. For these fractures, you need to go for more investigation. You need to see the scans. to know more about the morphology of the fractures. So this involving everything. So truly an typical triplanar fracture. So what's the next then? So this is just for open reduction internal fixation. There's nothing else. We cannot do anything else in this. So that taken to theater and fixed with open reduction internal fixation. I don't hesitate to open it from the front. So that's a 6 months post-op healing. It's just 6 months this patient. There's many things are very age specific. Like this fracture. This is a typical telo fracture. So fusion of the growth plate in distal tibia is from posteromedial to anterolateral. So in those years, 14 years, 15 years, when it's getting fused, they fuse first to the posteromedial and then go to the anterolateral. And the ligaments are there, they pull it out. The weak point of physis, they pull it out. This is also injury of type 3, so you have to go for the open reduction internal fixation. And then for the scan. So this you can see more morphology in the CT scan. So this fixed by open reduction internal fixation, anterolateral approach to this, and that's 1 year follow-up. There's more stories about the pediatric bones are like this is a 12-year-old who presented with a knee pain, X-ray of the knee done and discharged with analgesics and physio. Anything missing here? X-ray of the knee is completely all right. Knee pain and limping on 12-year-old. Hip, yes. So look at the hip after 2 weeks. Patient comes in A&E after 2 weeks. And then I was called, okay, what is this? So SCFE. So this was just before I came here, so I took to theater and we have to fix it. So they are very commonly missed in pediatric. Now, this is the other, I get a lot of SCFEs there and I fix them. So this 13-year-old boy with a left hip pain, and he got this, you can see, it's just grade 1 on the left side. So I took to theater, I fixed it. So that's one thing. After 6 months, this is the X-ray. After a year, this is the X-ray. Well, I didn't fix it on the right side because there wasn't any pre-existing condition to the patient. So I was happy, okay, he's not having any complaint in that. So that's 1 year. So after a year, he goes to States and he went to one of the A&E there. And his parents both are GPs, both are doctors. One is from India, one Irish. So they went there to the States and they went with a pain in the knee. This time pain in the knee, not in the hip. And they didn't do the hip X-ray. You can see something wrong is happening. Then he comes back to me after 3 months. And you can see with the right side is something wrong is happening. So 16 months post left hip fixation, he went on holidays abroad, presented with painful right knee, hip was not X-rayed again. And parents were knowing that his son has this problem, and they were GPs, they were doctors. So then he comes to me and this. So he got fixed again. So children are not the small adults, they are special, they need a special care. And timely intervention is very important. You don't have the time. Get it right first time. There's no time to play with. So get it right first time. Thank you very much.
Sir, what is the expected time of the maturation of the scaphoid if you are fixing it in situ in the displaced position? So what is the time duration for the becoming the natural?
It becomes fused.
No, not fused. But as you have fixed in the in situ fixation of the scaphoid,
Yes.
so what is the remodeling time for that scaphoid displaced?
Well, I don't think there is any time for that remodeling. But they fuse by their time, 15 years, 16 years. usually 16-year time. And then after, but in the process of that, you get some remodeling, yes. Sometimes they fuse earlier. So there is two reasons for doing the in situ fixation. One is to get it fused as soon as possible, and then to prevent the further slip. So you do one to prevent the further slip and one to get it fused. So that's the reason for doing. So you can get it in the meantime, but yes, fusion complete is at the time, 16 years or 15
skeletal
years.
maturity.
Yes.
Thank you.
And after that, either you can take it out or just leave it. I don't take it out. But yes, there is an option because this child, and in future, he may going to get something to be done with the hip.
So his, in the first side, there was quite a bit of displacement.
Yes.
Now, the problem with fixing it in situ is the problems of impingement later.
Yes, yes.
So what do you do for that? Do you do
No,
osteo?
whatever it is cerebedentary, I took it on theater, put it on there, and whatever comes after. Sometime, yes, if it's a very high grade 3, they can come a bit grade 2, but I do not attempt to manipulate it or reduce it.
So you don't believe in the reduction or the...
No, well, it's if it's unstable grade 3, then that's a different story. Then you can go, and it's a few weeks, and you can do the Duns or modified Duns procedure,
Yeah.
yes, but not for primarily if it's grade 3 even, and very acute, I go with only cerebedentary. And you believe me, I mean, most of the cases I get, if you
Yeah,
get a grade 3
so-
and they go to grade 2.
So for years we did this, and then we had this from GAN switch where they said you have to do the osteotomy to get it back and things like that. So where do we stand at the moment?
For the grade 3, yes, if you don't get in cerebedentary and if it's very, very high, like more than 50% or something like that, you can absolutely go for open reduction, Duns procedure, and fix it back. And we do get often maybe in a year or two, but not quite. I mean, most of them they go go a little bit better. What you do, you get a lot of SCFEs here.
We don't get a lot, I wouldn't say that, but we do get probably 2 or 3 a year. That's about...
Well, because we are specifically pediatric, so we get more. Because
Yeah,
there,
so I get referred cases from various places. So
Yeah.
I get a few, but it's not a very common problem here. But yes, certainly in the children who are hypothyroid, etc., there's a large incidence of that.
the reason for asking is a big population here. We don't have a big population, but I think they are well addressed. So we do get. I see we have 2 pediatric orthopedic there, and almost I get 1 in a month or 2 in a month.
Yeah, but you also similarly you get all the pediatric cases referred to you. So
Yes, yes.
it's
that's
similar.
it. But here the population is big, and you don't have that many. So that's the thing. Okay.
But तेरे को नहीं आता है because I think you are not a pediatric surgeon only. You are doing everything. सब अंदर का व्यापारी है तू.
Okay. Thank you. Sir.
Thank you, sir. Thank you very much.
Thanks.
Now I request Dr. Amalya Kumar Singh, sir, for presenting AC joint dislocation cases. It is very challenging thing how he is making very easy.
Thank you so much. Actually, there was a gap in between, so I put up. I've always learned from Dr. John that whenever there is a gap, don't leave it unattended as such. There should be something. It may not be very interesting for some, but a basic thing which I am going to talk. Respected Chairperson, sir, this AC joint dislocation, how to manage in this affordable and acceptable. This is the big question. Grade 5 injury. This is the case which the patient presents to me. Dr. Khurshid, sir, what will be your management in this? Acute injury, young.
Acute injury, it should be reduced and fixed with the endo button or the hook plate.
Hook plate. Right. Most of the people believe will like to do this because nobody wants this type of deformity. There are lots of problems later on. So surgical treatment is always necessity. When the AC joint is completely dislocated, it causes a highly visible bump at the end of the collarbone or the clavicle. and then AC joint reconstruction surgery is required to stabilize the AC joint. So not going in different parts, we all know about this. What was there in this case, that both the coracoclavicular ligament and acromioclavicular ligament were damaged. That's why there was so much displacement. So repair of CCL and ACL both is mandatory. Unless we don't do it, it is very difficult to have a good function, and maybe there will be chances of later on lots of problem. So the question is whether to go for arthroscopic repair, the best in the present scenario, but cost is a limitation and technical skill. Nobody is very well versed with the technicality of doing the arthroscopic repair. And second is the open surgery, which is a slightly cheaper option, better visualization of everything, and as we can have a very strong construct. So several conservative and surgical techniques have been previously described for the treatment of all AC joint injuries. However, there is a lack of consensus regarding the best treatment option. So our study is on use of a non-absorbable suture fixation between the coracoid process and the clavicle and repair of the acromioclavicular ligament by ethibond. Patient is placed in supine or beach chair position. Surgical exposure of AC joint dislocation in the beach chair position. Line is drawn from the coracoid process to the clavicle. Incision starting at the coracoid process and extending to the superior border of the clavicle. You are going from the inferior to the superior aspect. This because then only you are able to localize it properly. This is the way you want to proceed. The deltotrapezoidal fascia is incised in line with the skin incision. The superior anterior aspect of the clavicle is exposed, and after this exposure of the coracoclavicular ligament is completed. Release of the cal from the acromion insertion has to be done. The lateral border of the ligament is then prepared initially. You prepared it initially using a number 5 ethibond suture, which will be used later on to repair lateral in the clavicle to the acromion. Just tie it there and leave it. Proper exposure is mandatory. This is the way the exposure is done. Initially, you stabilize it with wire, K-wire, so that it doesn't go on playing. The clavicle is in contact with the acromion process now. Prior stabilization of clavicle into acromion was done by K-wire. Now the tunnel preparation, the most important thing. Surgical ruler is used to measure 3 centimeter distance from the lateral end of the clavicle on the superior aspect of the clavicle. The clavicle is secured to create tunnel in a superior to inferior direction. Guide wire and drill is used to make this tunnel. This is the way I start. 3 centimeter distance from the lateral end of the clavicle. Positioning of the guide wire and tunnel preparation for making CC ligament has to be started like this. And how you hold it, how you drill it. You finally drill it. Yes, you have reached the final destination underneath the coracoid process. Keep monitoring through the C-arm. This is very important. If you are not properly monitoring it, there are chances that you will be deviating your straight line as such. Drill slowly over the guide wire. Guide wire is 2.5 millimeter. Drill very slowly, because if you drill it very fast, or if you are using a thicker drill, there is chances of fracture of clavicle. While preparing tunnel, be sure that you do not fracture the clavicle. Now in the market, Arthrex Endobeton is available. Very good. I'm not against this. Really good. You just put it, just release it, and you get a very good hold. But price is this. And now Indian companies are coming forward to help us. Yes, this is also available, but again the price factor on MRP is 36,000, something like that. So Endobeton fiber wire, what you can design yourself. Long chain polyesters or fiber wire, we design and make our own tightrope. They are much cheaper, good strength and quality at par. Just make it, keep it 2 or 3 ready always. This is the way you make it. Cost is around 2,000 rupees as compared to rupees 35,000 of Arthrex, and problem is also of availability. Most of the bigger town you will get it, in the periphery you will never get it. Suture passage underneath the coracoid process. Coracoid suture passage is used to deliver the suture directly under the coracoid process. catch hold of the endo button from the inferior aspect and make it horizontal. This is the horizontal, what you see in this cursor, that you make it horizontal. Then you can easily pull it from the top. Then you can pull the other end from the superior aspect of the clavicle and reduce the AC joint dislocation like this. Make the top button also horizontal so that it rests on the superior aspect of the clavicle. Reduce the dislocation and fix the endo button and fiber wire. Never tie that knot in a very tight position because it will make the joint very stiff and chances of stiffness and pain will be more later. So don't make it a very stiff joint. Before tightening, remove the K-wire. This is also mandatory. You have to remove the K-wire. And now this picture is like this, properly reduced. Now the last, what I told you before, repair the AC ligament with the Ethibond, what you had already prepared in figure of 8 fashion. And your surgery is done. Close the wound in layers. Pre and post operative, the same patient. X-ray, the wound healing after 1 month. After 1 month, the movement functional result after 1 month. This is after 1 month. I'm still taking lots of precautions. X-ray after 2 months. After 2 months, this is the result. So advantage is low cost and reproducible, no need for extra hardware fixation, less complication. Satisfactory reduction of the joint is achievable regardless of the severity of the AC joint instability. No arthroscopic proficiency is required, no donor side morbidity, but disadvantage is that open procedure with more exposure and damage to the surrounding soft tissue as well as greater risk of infection. Non-anatomical reconstruction. We are not using any biological thing as such. There's non-anatomical reconstruction of the joint. Finally, to conclude, there is lack of consensus regarding the best treatment option or the AC joint management. Our technique has several advantages which include low cost, satisfactory reduction of the AC joint, no need of arthroscopic proficiency, and no donor side morbidity. Thank you so much.
Thank you, sir. Are there any questions from the audience? So there is one question I have, sir. At this stage, do you prefer to do a lateral end excision of the clavicle or because the arthritis of the AC joint is a later complication at many
So
years?
my follow-up result is maximum of 2.5 years of 3 years now. Up till now, no problem is there. Patients are doing well, but I do expect that some chances of arthritis will be there at AC joint especially.
Yes, sir. Anybody would like to comment on this lateral end excision, sir? Tana, sir?
If you left alone, what will happen?
The main thing was this deformity. Big bulge is there outside the lateral end of the clavicle, lateral in the shoulder, and naturally there is.
So do you decide whether the two ligaments are torn or only one is torn? If only one is torn acromioclavicular, you don't need anything to be done. If it also.
Yeah, when both ligaments torn, I'm talking about the both ligaments. When both are torn.
So how do you decide that? That's what I'm asking. Because in a grade 1 or 2, you don't need anything to be done.
Nothing. I'm talking about the grade 5 only, sir, at present. Grade 5, where both are torn.
So I've been doing it for many years, and we generally have a look at the articular disc that is there in the AC joint, and if that disc is usually damaged in a type 5 access, at that time we do a lateral end excision because they come back about 4 or 5 years later with pain. So
but lateral end excision is more for late cases, not for fresh cases. When they come late and they have problems, then you would do that, and there's various procedures described for that.
Yeah, so if you leave it, because it doesn't really stabilize the thing, because the AC joint has a capsule on top also which is torn. So we look at the disc.
So, but in type 1 and type 2, you don't do anything anyway.
No, we don't do that. This type 5 I'm talking about.
Yeah, but type 5, once you've reduced it, it becomes a type 2, doesn't it?
Yes, sir, but the articular disc, articular cartilage is gone. So that cartilage got destroyed.
I just want to say, yesterday I had shown a similar case with fracture lateral end of clavicle and disruption. I was forced to leave it alone. And after 27 years, I saw him full function. Though there was some lateral and clavicle prominence and it was jetting out. But 27 years, he worked normally. and he doesn't want anything done now, and full function movement of shoulder rotations, everything 100%. So we learn how that is what Dr. Tanna I told you.
So I see more, I mean, complications of fixation than problems of not doing anything. That is, I have to say that.
Well, that small bump which you feel it at the outer end, that's all you are left with. Except there is already something has happened to the glenoid and everything. That's a different thing. You're talking about the grade 5. It is
Grade 5.
It is an injury which is also to the glenoid and everything which goes. That's a different ball game at all. So to me, very few acromoclavicular need surgery.
Right, sir. Thank you, sir. Can we go for a group photograph? I'll request the moderator, please come here. And the next moderator, please come here. Dr. Akhil, you have to start.
Good morning, everyone. May I call upon chairpersons, Dr. S.K. Malik sir, Dr. M.P. Singh sir, Dr. Shailendra Kumar Singh sir, Dr. Vishal Kumar sir. Okay. May I call upon N.K. Agarwal sir for his talk on a case of polytrauma, focus on pilon fracture.
Good morning, and once again thanks to Dr. Amulya and the organizing team for calling me here and allowing me to share this case. I'm going to talk on a case of polytrauma, very severe polytrauma, but my focus will be on the ankle fracture. Friends, 16 years back, this young man, 25-year-old boy, fell from 30 feet height. And he sustained multiple injuries, head injuries with loss of consciousness, fracture head of radius, fracture chest, multiple rib fractures with pneumothorax, fracture lumbar spine L3 and L5, and pelvic injury, sacroiliac injury, pubic symphysis disruption, and sacrococcygeal fracture dislocation. I had never seen this injury before, and a very bad perennial injury, swollen perineum, punctured wounds, grade 2 open fracture, left leg and right side was fracture dislocation of the ankle, and that is what we are going to talk about. Now he presented to us, now in the x-ray we got of this was in A&E, they tried to reduce the ankle, and after reduction they did a CT, and it is still dislocated, and you can see top of talus and distal articular surface of tibia both are having chip fractures. He came to us 7 days after this injury. From the ICU he was shifted to our center. In a semi-conscious center, hemoglobin of 6, very high fever, in septicemic shock, badly swollen, bruised, perennial with bleeding abrasions. Only thing done was the tibia was nailed, but the wound was still open, needing coverage. And they put a transcalcaneal pin across these are the two fractures, L3 and L5. They had put a nail here, but it still needed coverage. And see, sacrococcygeal dislocation, how bad it is. And there was pubic symphysis disruption. This was the ankle condition. Now, my scope of presentation is primarily on ankle. Now, when the patient came to us, he is hoping that some miracle can happen. And first thing we have to counsel them, the general condition of the patient is so bad, huge pyothorax with chest injuries. And general outlook, septicemia with hemoglobin of 6 and all blood parameters grossly deranged. Spine fracture, 2 levels, sacrococcygeal injury, open leg fracture and ankle injury. So we told him, we'll try to save his life, but as far as ankle is concerned, it will never be normal. He's always going to have limp and might require fusion eventually, or maybe joint replacement. So how to manage? We decided our priorities. First priority was the life, stabilize general condition, look at the chest injury, take care of the septicemia, drain the pyothorax, and then the perineal, very bad swollen perineum and open. These are the priorities, open injuries, infected areas. So luckily, in about 7 to 10 days, we were able to stabilize him, gave a lot of blood, aspirated the pyothorax, chest physicians were with us. And then after this, we thought the spine will take priority because we need to turn the patient. And then only the turn of ankle would come. So then in 10 days, we fixed the spine. It was all right. We were able to now turn the patient, and then comes the turn of ankle. Now you see, this is the injury, and what should we do for this injury? This is a fracture dislocation, chip fracture, both articular surface of talus and tibia, and there were some chip fractures from the calcaneum also. The small fragments, articular surface, they were floating around in the ankle. What should we do? Now, if we look at the literature, our objective here is that we have to prevent infection at any cost in this patient, in this scenario. And whatever fixation we do, we should be able to turn the patient around for his general care and perineal care and hygiene. And at the same time, we have to keep talus and tibia distracted, because both top surfaces and bottom surface of tibia, they are raw. And if we let them hit each other, they will fuse, they will never move. So we need to keep them distracted for some time. What are the options? In literature, it is either staged procedure or do open reduction plate fixation, which we ruled out in this because of skin condition and risk of infection. External fixation, again, it is a bulky frame, and turning around the patient would become very difficult. We would be able to distract with minimal internal fixation and put an external fixation, but that was also ruled out because that will not allow us to turn the patient easily and move him around. So what we did, we followed those principles. We did minimal internal fixation. So that put all the fragments that was possible and put them with minimal internal fixation, so that minimum metal inside, chance of infection would be less. Now to distract this, external fixator was not possible. That what we put pin and plaster. We put a pin in calcaneum and we put a pin top of tibia and we distracted it. For 6 weeks we kept it distracted. And intermittent mobilization we would do by bivalving the plaster. And then we did bone grafting for the tibia also. It got united. Now after 2 years we kept on follow-up. He started moving around in 3 weeks. Fracture united. This was also removed after 2 years. See the sacrococcygeal fully united. How well it did just with conservative treatment and how bad the original injury was. And this is the ankle after 2 years, full function. There is, we expect with such bad articular surface damage on both sides, arthritis, and this is at 16 years. Patient has no pain. He has good function, and he doesn't come anymore for follow-up. I had to call him that please show. He said, I have no problem. What next? I've told him he might need fusion or replacement, but I have now offered him, now that I'm doing orthobiologics, I have offered him orthobiologics to delay his further surgery. Friends, my message here is that life should always take priority. And if we follow the principles, even if the method is not there in literature, you will devise your own method, individualizing the treatment plan. Thank you. It is a pilon type 3. It's a pilon type 3. Actually, this had a talar fracture, this had a calcaneal fracture. So this was really, he fell from height. There, it doesn't follow the set pattern of classification. You have to manage what you get.
Hello. Dr. Bharat Raju, for thanks for clavicle fracture.
morning, everybody. Tanna sir is here, and yesterday he said that this is one surgery he stopped doing. And disclaimer, sir, even I don't do it unless the patient comes to me with a demand for surgery. So whatever I'm presenting is which has been done earlier. Sometimes the patient, no, I'm in an institute, sir. I get paid even if I don't operate. Okay, so clavicle fractures are quite common injuries. The commonest site is the middle third. So they inherently have a good prognosis and most of the time treated conservatively, but the chances of malunion are there. Objective of the treatment is to obtain an adequate reduction, to maintain the reduction, and also preserve the biology and start early range of motion. So management options, historically close reduction strapping has always been there, but there are chances of redisplacement. Hence fixation has been a trend. So ideal fixation modality should maintain the alignment, should be minimally invasive and have least complications. Various fixation modalities are open reduction with plates, close reduction with intramedullary nailing, or close reduction or minimal open reduction with TENS. So as we all know, TENS is a minimally invasive procedure which gives 3-point fixation, and hence mostly it does not require any immobilization and allows for early mobilization. It is also cost effective and involves a simple procedure with minimal soft tissue dissection, which this also allows repeated micro motion at the fracture site. It acts as an internal splint, and you can pre-bend the TENS to get 3-point fixation. So this is about TENS, comes in various diameters from 1.5 to 4 millimeters. So the selected nail size should be about 60% of the isthmus of the diameter of the bone. TENS within the medullary canal, it creates a bending moment with that is not rigid. It's also stable enough to reduce and fix the fracture. In long bone, biomechanical principle is symmetrical bracing of the elastic nail in the medullary canal acting on 3-point fixation. One is at the point of entry and one is at the point of maximum curvature, and the other one is at the tip of the nail. So as I already told, it should be about 2/3 of the diameter of the isthmus. So minimal instruments required. Surgical technique, the entry point is about 1 to 2 centimeter lateral to the sternoclavicular joint in the anterior quadrant, as this is the lowest cortical thickness. So under C-arm guidance, you make an entry point with the awl, then appropriate size TENS is inserted. If you are not able to achieve reduction by closed methods, then open about 1 centimeter at the fracture site. You can reduce the fracture easily, and you can insert the nail into the lateral end. Post-operatively, no immobilization. Active motion is started as soon as the patient tolerates the very next day. Usually TENS removal is done around 4 to 6 months later, and it depends, the fixation the removal depends on the remodeling of the fracture callus. So these are some of the illustrations. So TENS is a ideal fixation method. It involves small incision, minimal periosteal stripping, and load sharing device properties. Its relative stability, it allows for abundant callus formation. One of the frequent complications is irritation of the nail at the entry point. So it might require a trimming of the nail or a premature removal. So these are few studies which has compared plate fixation versus intramedullary fixation. States that plate fixation is associated with an increased risk of complications. Elastic nailing system is minimally invasive with good patient satisfaction and cosmetic appearance. Another study which states that TENS is a promising surgery with excellent functional outcomes. So in conclusion, TENS is an effective management of clavicle fractures with reduced surgical time, minimally invasive, excellent results in terms of bone union and functional outcome, minimal complications, less cumbersome with implant removal, less chances of refracture after implant removal, cost effective and also cosmetically superior. With this, once again I seek your blessings for my candidature as Secretary of IOA. Thank you so much.
Thank you, sir.
Thank you, sir.
I can suggest, quite often, if it is badly displaced, you don't get a reduction there. So you try to do it, because otherwise if you go in and out, you may damage the soft tissues. So you may need, as you had mentioned already, an open reduction. Open reduction with the transverse incision is the one which gives you a bad scar. So I think go at the fracture site and make a vertical incision. So if you make a vertical incision, you will be able to reduce it, just a little thing here, and that scar is far better than the transverse incision.
Hello. Next speaker, Dr. Rohan Singh Parhar. Top.
I'm very fan of doing the open reduction internal fixation. Usually I think it's 10 to 12 I do in a year because my set of patients are very demanding, and they come with a literature and explanation. I say that more than 2 centimeters shortening, what's going to happen for the long term shoulder function? It's a shortened lever and all those kind of things. So then I have to go and say, oh yeah, this, and I mean, there's particularly the young ones and the sporty ones. Well, we don't do these tens nailings or any kind of these things, because I think it's there's not much difference between not doing and doing the nail in the non-union rate. What's about this here? So do you find
As I said, I don't know whether you were there yesterday. I traveled the whole thing. I've earned a lot of money in operating upon clavicle. Now I don't need the money, I don't operate anymore.
So our primary treatment is non-operative, but we do get patients who end up with non-unions which have problems. So you have asymptomatic non-unions, and you also have some patients who have problems with their non-unions. The first non-union I operated on was actually a tabla player who could not play the tabla with his non-union. And that was the first time I ever operated. We used to be totally nihilistic about it at one time. And if you saw the older literature, it said don't do anything because the risks of non-union increase with operative treatment. If you saw the literature by Neer, etc.
There's another big problem in my part of the world. There was just a health professional, and they come. So my clavicle not healed in 9 months or 12 months, and now they say I won't be able to work. Give me a cert that I am not fit for working. So that's the thing they come with, and there's a big problem. Then whole you have to certify that this patient is unable to continue as a health professional, 26 year or 30 year or 35 year, and that's a different.
That's a work compensation issue.
And you know, there was a 32-year-old. I fixed non-union at 9 months, didn't heal up. 1.5 year, didn't heal up. 2 year, bone grafting, didn't heal up. Still, that's there.
Not healed. But large majority of the non-union don't give you a problem. Yes. As John mentioned, very small percentage who gives you a problem, you need something to be done. Large majority, they'll just be perfectly all right.
I have a friend who is a surgeon in Saudi, general surgeon. He broke his clavicle when in medical school and didn't heal, and he's good, no problem.
Yeah, I know. Okay, carry on, sorry.
Carry on.
Yeah. So good morning, everybody. I'll be talking about talus injuries, how they are presented in certain cases to us, and as we all know that talus fracture is very uncommon, less than 1% of all the fractures, and the presentations are really rare. So once they come to you, once they are really fed up. And how do we treat? Obviously we need a 3D CT scan, and there are multiple approaches, the anteromedial, the anterolateral, posteromedial, but for me the gold standard with the presentation that I'm getting in the patients is a dual approach, a combined osteotomies for the complex injuries to accurately visualize and fix it. So we know all the treatment options. There are cast, K-wire, screws, mini plates, and X-fix. So the timing of presentation of the patient is very important. I'll just shift quickly to the cases. So this is a 48-year-old male with an 18-day-old injury. A bone-setted treatment has been taken, presented to me at 3 weeks. So this is a fracture of the talus. We can all understand that this is there. And These kind of injuries, you have to do medial malleus osteotomy and visualize it completely, as you can see over here in the clinical picture. You have to visualize it under your vision, and then you have to do it. And this medial malleus osteotomy, the only one tip is that the wires of your osteotomy fragment are there, and the cuff, slight cuff of tissue is there attached, the deltoid cuff is there, because that is where the vascular supply is. So you cannot just strip off the medial malleus osteotomy, and you cannot take it off on the table. So these kind of fractures need a accurate joint reduction, visualization and fixation. So this is our intra-op reduction pictures. We held it with the clamps and we put the wires and replace them with the screws. And this is the final fixation and closure of the osteotomy from the medial malleus side. And this is the post-op X-ray. So the dual approach is basically that you go on the lateral side to see the lateral process also. If you want to see, visualize your joint, whether you have been able to mobilize a 3-week-old fracture or not. It is very important to go and have a look accurately to reduce these fractures with a good joint line. So this is a post-op X-ray, this is a 2-year follow-up, and this is a 4-year follow-up of the patient. This is a 4-year healed scar on the medial and the lateral side. These are surgical healed scars. There's a good painless ROM to the patient. And this is him walking comfortably. He's a heavy manual laborer and a worker, and he can sit down and do everything. The idea was, because he's a 3 weeks old, you have to go in, you have to go dual side and fix it up nicely. And this is a long follow-up of the patient. Another case, primary failed talus surgery, a 33-year-old male with a 4.5-month-old injury, operated outside with K wires, and it's come with this kind of an X-ray. It's a crushed talus. It's already collapsed. Everything is gone. So though he's young, but in this kind of a presentation in 6 months, kind of an old injury, what to do at delayed presentation? The 3D CT shows multi-fragments. I've not put up all the pictures because of paucity of time. So after explaining about the guarded prognosis, and the patient is in severe pain, not walking for the last 6 months, and it's a young patient though, but we planned for a tibiotalo-calcaneal arthrodesis, a TTC arthrodesis, and we use a transfibular approach with massive grafts and a TTC nail plus additional screws. So you can see we have done the lateral malleus osteotomy. This time we can take it off the table because you can morselize this graft also from the lateral malleus side. And this is, you can see the bed of the wound is so red, it's good blood supply. But my ronger has the crushed talus which I removed from there. So it's already avascular and it's already necrosed. So there is no point of trying to fix up this fracture at 6 months. So what we remove all these pieces, morselize them, and use a fresh graft and pack it at the fracture site. And we fix it up with a TTC nail. This is the post-op X-ray. This is the post-op at 6 weeks, as you can see. And I have put additional screws from the medial to the lateral process of the talus. And the lateral malleus osteotomy is fixed with the wires, but it also has a screw, a fully length-stable screw from the lateral malleus osteotomy fragment into the talus to the medial side. So additional fixation, making it something like a nail and a screws. So this is 12 weeks post-op. There's 6 months follow-up, 3-year follow-up of the patient. And this is a clinical videos at 3 years. I have a 7-year follow-up of this patient. I'm trying hard to contact him, but he's not in the country anymore. He stays outside. Another case, 50-year-old male, 12-year-old distal tibia injury, 1.5-year-old ankle injury, progressive varus and recurvatum, a painful ROM. This is the ankle fracture, 1.5-year-old ankle injury, but a tibial injury which is 10 to 12 years old. We discussed this case at TraumaCon. Tanna sir really took my case on. I remember if he remembers this case or not. So this is the clinical picture of the ankle. The deformity is there. He's not able to bear weight because the progressive deformity of the ankle, because that non-union is causing him the problem and the deformity. He's really, really in pain. So this is like a forcible video we have done. Again, dual approach. Go on the medial side, medial malleus osteotomy, see everything from the medial side. Go on the lateral side, see everything on the lateral side. You have to be able to see these deformities because they don't budge. You have to break them both sides. You have to visualize through and through, and you have to realign your ankle. This is very important. So same thing, dual approach, medial malleus osteotomy, lateral malleus osteotomy, realignment. These are intra fixation pictures. I always put a transarticular tibiotalo-calcaneal thick 5 mm statement pin to realign my fracture, and we put all the screws, everything. Just kept these, the pin and the screws over there. And you can see the correction, both side suture lines are there. It's a totally corrected ankle because it is dual approach. You have to go both side and correct it. 1 year follow-up with the heel scars, a good correction at the 1 year follow-up of the deformity. You can see the ankle, it's a 2-year follow-up. And this is the 4.5 years follow-up now. And he's an obese man, obviously he has some varus at the ankle and everything. But if you look at the ankle, the deformity is corrected. He's able to sit, he's able to do everything. He can sit down also. Another case, 46-year-old male, 2-year-old injury on the proximal tibia and distal tibia plated and ankle was casted. He's a post-polio patient and he's bedridden with discomfort. The proximal tibia plating has been done. The ankle is gone in arthritis. There is arthritis at the talus, you can see. Again, We have taken the approaches and we have done a transfibular approach, taken out the lateral malleus, fixed up everything with a TTC nail, overlapped the TTC nail with the plate, and this is a 1-year follow-up of the patient. As a polio kind of a limb, and obviously has a equinus which is long-standing. As a 2-year follow-up, and it's a 4.5-year follow-up of this patient. The 5th year is running. Clinical pictures of the patient is a polio limb case. Similarly, another case, 50-year-old female, known case of RA, 10-year-old ankle fracture, talus fracture, injury casted, KVARS was done, inability to bear weight. So these are the pre-op X's. As you can see, again the talus is gone, the subtalar joint is gone, the ankle is gone. So these kind of fractures, when they present late to you with pain and discomfort, I agree with Sir. Agarwal sir, he has rightly mentioned that some of the patients don't come back for 15 years, but these kind of patients, when they are in pain, they come to you. So the thing that we were talking yesterday, sir, Tanna sir was saying in the proximal femur that you have to do dual implants. So now for early mobilization of these fractures and these patients, we have started using something like an absolutive kind of a thing. We have a central pillar with the nail, the TTC nail is there, and on the lateral column, there's a lateral stability with a plate. So it's a nail and plate combination. And most of the surgeons have been following, and they have very good results. And they used to take out this whole lateral malleus, use it as a graft, and just fix it up with a nail. So, but I try to maintain the lateral column also now. So to give a very plantigrade, very stable foot from day one, and the patients can start mobilizing because it's a nail and plate combination. So this is a 3-month follow-up of the clinical video of the patient. She's walking, she's a case of rheumatoid arthritis, and she's got bad ONE both sides. And this is a 1-year follow-up with a nail and plate combination for these kind of talar injuries when they present to you. And it's a 2-year follow-up of the patient, totally united with a nail and a plate combination, a central pillar inside and a lateral pillar on the other side. Another case, similar kind of thing has been done, a nail and a plate combination, and it's again a long follow-up of the patient with a complete nail, fusing everything right from the ankle, the subtalar joint, and taking care of the lateral column. The good grafts is there, a nail and plate combination. The patient has done well. A last case, just going to take 10-15 seconds, 59-year-old lady with compound grade 3B extruded talus injury, presented to me within 2 hours of the injury. She's an agriculture worker, a very bad injury as you can see, a compound grade 3B, the talus, everything, all the pieces are out. These are the presenting x-rays with a dislocation. And this is the clinical picture. She was wrapped around, just 30 seconds, just wrapped around. And we just went ahead, did the debridement, everything, reduction. No screws, no plates, nothing was used. Obviously, it's a compound grade 3B. We used an external fixator and wires. We didn't touch the lateral side because that was from where the dislocation was. We were able to get a primary closure. And we applied a uniplanar kind of a one-sided triangular kind of a frame for this patient. These are the intra-op pictures after reducing and getting everything done like a ligamentotaxis. And fixed it up like this. And this is 6 weeks follow-up, 12 weeks follow-up, 6 months, 1.5-year follow-up. And I have a 6-year follow-up of this lady. She's okay, she's a manual worker and she can do almost everything. So the take-home message that talar injuries are difficult scenarios. The patient needs to be counseled for long recovery periods, and you have to have thorough understanding of the injury. And I think dual approach is very important for deformity correction and fixation, and dual implants are coming big way in these scenarios also. And like always, I always dedicate my talk to my mentors, Dr. G.S. Kulkarni sir and Dr. Sunil Kulkarni sir. Thank you so much.
Thank you, sir. Hello. Next speaker, Gadgarne sir. The topic is revision of failed humerus nailing.
Good morning. The causes of failure: mechanical failure, biological failure, technical failure, but the failures are usually multifactorial. So preoperative clinical and radiological evaluation important to know whether the non-union is atrophic, oligotropic, hypertrophic or infective, or it is a surgical error. That will determine the surgical strategy. This is a proximal humerus fracture in a 55-year female, presented after 6 months of nailing, breakage of distal screw with atrophic type of non-union. Nail failure with non-union, most common scenario. Limitations: humerus has poor rotational stability with nail, less reliable than the femur and tibia nailing. First option is exchange nailing, limited role in humerus, and therefore exchange nailing does not work in the non-union of the humerus fracture. Option 2, nail failure with non-union, a plate augmentation if there is a stable fixation and if it is a hypertrophic type of a non-union, then you can exchange the nail and do a standard plate augmentation. But we have to achieve compression across the fracture site and also the autologous bone graft after freshening of the bone ends. The plate augmentation without nail removal, that also can be done, and this is one of the case where nail intact in a good position, rotational instability and hypertrophic non-union, retain the nail and use a adjuvant plate, and probably if you correct the biomechanics, it will heal. Bone grafting principle is essential in most revision options. Iliac crest cancellous graft, a gold standard. Fibular stud graft in osteoporotic and segmental loss. And bone graft substitute adjuvant only. And this is the patient, same patient. I removed the nail by anterolateral incision fracture exposed, debridement, osteoperiosteal decortication, distal plate fixation, and a bone grafting. And then you can see here a radiological and functional outcome after 1 year of follow-up. There is some restriction of the overhead movement. Another example, a treated by nail, resorption at the fracture site, distal third fracture. Though people are propagating for a distal third fracture nailing, but I don't think it's an ideal indication, and probably it should not be done. So there is a resorption, bending and breakage of the nail, a technical error, posterior approach to distal humerus, removal of nail, isolation of radial nerve, excision of a fibrous tissue, and shingling as taught by the Dr. Tannasar. And then the radial nerve, a danger zone, the nerve is often encased in a scar tissue from the previous surgery. Direct visualization always identify and neuralize the radial nerve before applying the plate. Anterolateral or posterior depending on the previous incision and fracture location. And you must get a consent from the patient that you may get a neurofraxia of radial nerve during a surgery. So this is the same plate fixation, bone grafting, follow-up X-ray showed a good fixation, 2 years follow-up, a full function after a posterior plating with a bone grafting. Another example, as I said, the distal third fracture, nailing in distraction with a short nail, unstable construct non-union. Medullary canal at lower third shaft and a supracondyle region of humerus, unsuitable for nailing. Nailing and subsequent follow-up, triangular canal, canal flattening, and it's not suitable for nailing. So revise with a plating and bone grafting, and you can see here how we can identify the radial nerve, and then 18 months follow-up, radiological and functional outcome. 45-year male treated with a rust nail presented after 9 months of surgery. This type of a surgery should be discouraged, and I think multiple rust nails, though they are very good in some of the cases, but I don't think they serve purpose in the distal third and the mid-diastasis fractures. So again, removal of the nails, twisted plate, and then osteoporotic decortication, bone graft, and you can see here functional and radiological outcome after 2 years of follow-up. Another example, a 59-year male female presented after 6 months, and you can see this is osteoporotic bone, medullary canal is wide, there is a displacement and translation of a proximal fragment and loosening of the screws because there is no adequate fixation distally. Loose screw was removed and subsequent follow-up after 1 year, pain and loss of function of the arm. Anterolateral approach, removal of nail, freshening of non-union, compression plating and bone grafting, 1 year follow-up, functional and radiological outcome. A fracture neck humerus treated by rush nail, 1 month and 3 months follow-up. There is a bursa at the end of the entry site. After 12 weeks, neglected non-union after removal of the nail, fibular augmentation and bone graft and plate, deficient lateral wall, no signs of infection. Fibular graft with fixation, 2 years of follow-up. Lateral wall is augmented by fibular graft, radiological and functional outcome. Another a multiple rush nails operated, rush nail in situ with wide medullary proximal humerus with translation of a proximal fragment and butterfly fragment, superior migration of a rush nails. Rush nail removed and plate osteosynthesis was done by some other surgeon. The surgical principles were not followed of a plate, no adequate length plate and compression, 18 months of the failures. And you can see a removal of the plate, isolation of the radial nerve, preparation of the non-union site, and exchange plate and bone grafting after isolation of radial nerve. 1 year non-union, stability achieved by 2 plates with bone grafting. We have to see the stability on table whether a single plate is adequate. You may improve the biology as well as the biomechanics by putting 2 plates and then bone grafting. When bony union is delayed, cyclical loading stress on the nail beyond its limitation of endurance may lead to a fatigue failure. Loose nail in the cavity and distraction is the recipe for the failure. So to avoid rotational instability, if you want to do a nailing, use a multi-lock nail. Rimming to fit thicker nail increases contact and also stronger biomechanically, locking at both ends, and you must have at least 2 locking screws distally and 3 to 4 locking screws proximally. If you want to do a surgery and get a good result, this is my article in a Scott journal, result of keyhole interlock nailing for humeral diaphyseal fracture in adult. And I do number of cases of interlocking nailing in humerus fracture, but I do it in a very different way. Rimming, fit, press fit, and no distraction at the fracture site. So infected nail is a different ball game, so I will not touch that fracture. So take home message, get it right for the first time. Revision strategy based on the optimization of mechanical and biological environment. Thank you very much.
Thank you, sir. May I request Dr. Tanna, sir? Topic is
my guess or a prediction is nailing of the humerus is going to be replaced by ABP nail. ABP plate. And I think Dr. John mentioned to me that ABP, the major issue is the scar which in a woman with this, you see it anteriorly is not very good. Beautifully, he had shown me the article which can be done from the back. See the radial nerve and do the same surgery which we do it anteriorly, do it posteriorly. Probably I feel there's going to be the surgery of the future. That is my prediction.
May I request Tanna sir, topic is knee fusion.
These days, in days of TKR, knee fusion is not so common. Major reasons knee fusion is these days is irreparable joint in a very young, economic reasons, or a multiple failed TKR, and bones not suitable for a revision TKR. One of the very few indications are there for the, but still you will get it again and again. This was a standard case, very small fracture, treated with Ilizarov, ended up in infection, not willing to have a TKR, so I had to do a nailing and fusion of the knee. This is how the knee was fused, everything is perfectly all right. How I do the knee fusion? With the TKR instrument, I take a minimal distal cut of the tibia and minimal distal cut of the femur and a small cut of the tibia. Now once that is done so that your axis is well aligned, perfect axis alignment, 5-degree knee flexion, and then pass a nail. First you have to ream the femur, and you can't ream the femur from only above. So ream the femur from above and ream the femur from below and get these two canals matching. And then ream the tibia. Now, as we know, you will have to compress the fracture ends ultimately. So now you pass a nail, first in the femur, then bend the knee, enter into the tibia and extend the knee, and you will be able to pass the nail from tibia to the femur, femur to the tibia. Pass a long nail. Now having passed the nail, compress it with the Charnley device or any of the device which you have of the ankle, and compress the knee first, and then put in a locking screws. This nail has a design that 2 locking screws here, 2 locking screws there, and 1 locking screw here and there. So 2 locking screws near the device, near the knee joint, and the nail is devised. I remember I had manufactured this nail. Femur is a thicker nail, about 10 millimeter, and the tibia is a thinner nail, about 8 to 9 millimeter, and it is slightly bent. Locking screw here, locking screws there, and locking screws here. This is the thin tibia is straight, and this is slightly bent because of the anterior curvature. It's available, it has been manufactured, it is available. Now here is another case, badly deformed knee. As you can see it here, for a long time there was a non-union and the knee is gone. So I felt it was not even suitable for a TKR at that time, and obviously the economic reasons. So went down, did the same surgery which I was talking about, and in 3 years' time you can see that everything has been marvelously fused, and patient walks about and moves about for life with this knee fusion. Now this was the fracture. Somebody had done the thing there. 40-year-old compound fracture, 4 surgeries, no sinus, knee is stiff. At this stage again, in a younger patient, I decided to do the fusion, so I went ahead, took it out and did the fusion. Now I did the fusion initially with all these gaps, which is a big bone graft I put it. I use an allograft which is available to me. But this nail broke down again here. Nail broke down again, so I went down, changed the nail, put a massive bone graft there, and this is the one which ultimately it held up completely. So massive bone graft, if you need it, autograft is not practical. And to me, fortunately, nowadays more and more I have been using allograft in a massive ones, but the main thing is the decortication, and once you do the decortication, the allograft will be also be able to use the same way. Now here, these are the available available knee fusion implants. Knee fusion implants. I don't use it, though it is available to me, it is expensive, but that's not the issue with me in my South Bombay practice. But if the nail breaks, like what happened in the other case, you are stuck. You will not be able to remove this hardware. So I avoided using this, except I used it only once and then I have given it up, because I feel that this is the one which in our setup, if there is a fracture, there will be a problem. I'll show you. So I use it, proved tuberculosis on 2 months anti-TB, offered TKR, money constraint, and past bad TKR experience in the family. So I did the nailing. Nowadays I do the nailing and I supplement with the plate after compression and everything, and a massive bone graft there. And I have been very happy with that. So today, nail and a plate for a knee fusion is the one which I do it all the time. You can see there is a giant cell tumor. Operated upon, failed every time. So again went down, did the fibula. I had to excise the giant cell, excise it completely, put in the fibula, and ultimately you can see the fibula, the nailing, and this is the one which ultimately it heals up very well. So knee fusion has a role into some of those special situations where the total knee cannot be done. Now, this is the infected knee, twice, thrice operated upon. There is a big bone gap. So again, double plating and the compression screws, this is what is done. Nowadays, what I do is, this bone is not required on the side when you do the knee fusion. So you remove this bone, so it is easier to put in a plate on the lateral side, first and foremost. And you have the availability of this bone graft all the time. This is what I have done it here. Remove that bone and put in the plate. Sorry. You can see remove the plate, so it is easier to put in a plate if you are doing with the plate osteosynthesis, so that the tibia and the femur becomes in one line and you will be able to do that. Now here was the fracture, may be ideal here, but in these situations I don't do it, because this is the one which, as I said, I use at this double plating, and the way I do this with this compression and all, I have never regretted this. This was the fracture, compound fracture. 2-3-4 debridement, X-fix. Ultimately, the lower end of the femur had to be removed because of the infection. She came to me for a amputation. Infection, 3 debridement, ultimately had to excise lower end of the femur. Once she came for an amputation, I asked her that if in case you give me a chance, I would like to preserve it, because the foot and ankle was very good. So Dr. Vikas Jain for Vapi is expert in 3D printing implants. He got turned on, cost ko maro goli, because by that time it comes, he had already exhausted everything. So this is the, after the radiological assessment, he made this implant. So this is the one which goes in the tibia spots. So I went ahead, I did this, put in the graft insert here. This is the trabecular metal. We put in the graft here, plenty of graft. And you can see ultimately the whole thing, just it needed a plastic surgery to close down. So this is the plastic surgeon took a longer time than what probably I had taken to do the closer, because he had to do 2-3 muscle transplants, and then did the plastic surgery. Everything fortunately held up. And here it is, after 8 months, he is walking with some amount of shortening which is there. But this I felt was excellent. Immediately patient could be mobilized, you didn't have to do anything. And this is the one I felt. The knee fusion for this patient was the ideal situation, and I could get away with it. Conclusion. Nailing is safer way of a knee fusion. Indian price nails are dependable and they are available the way I described. Of late started adding plate, side plate to increase the stability, and I feel that knee fusion has a role sometime into the armamentarium of a surgeon. Thank you very much. Any questions? Nowadays I don't use the charnless, but I do the compression with the compression plate. Yeah, after that, after compression, I do the interlocking of the nail. So first a nail, do a compression plate. Once it compressed it fully, you either you use a charnlet or you use a Muller device or a Weber device, compress it, and then put an interlocking nail.
Knee joint required, or it's a straight knee only?
5-degree flexion is already inbuilt into the nail.
Then if there is a flexion at the nail, how does the nail enter the tibia? I've also done it, but it was difficult. I put a straight nail, long nail.
No, I think it's a 5-degree, which hardly you really make it out. So it doesn't go into hyperextension.
Okay.
Sir, actually it's a wonderful procedure. I have a more than 25 years of follow-up of 21 cases. Not a single patient complained about the pain and the disability. They are very happy.
They get used to, they play cricket, they do everything. I had a fortune of changing a knee arthrodesis once I started doing the knee replacement. I was very enthusiastic, young, and started doing the arthrodesis knee to the replacement. And I regretted it. All the muscles are gone for years together. You change it to do it. Technically, you can do it. Patient can't walk about that comfortably. And ultimately, with the gap, I did the knee arthrodesis again. So a wonderful arthrodesis, I changed it to a bad knee replacement and did the really inferior arthrodesis afterwards.
Sir, in a infected knee, when there's a spacer, there's a lot of bone loss in the tibia and the femur. So I had this case. So what I did was I removed the fibula and put it intra in the femur and tibia, and then put plates over it.
But if there is a big gap, there will be a hell of a shortening if you compress it.
Yeah.
So that's the time when this sort of a 3D printed things and all which will be useful.
That is important.
Because otherwise, particularly in a total knee which is infected, which has been debrided, 2, 3, 4 inches of gap, I feel is not wise to do only arthrodesis by that with the 3, 4 inches of shortening.
Sir, in such cases, we may go for the turnoplasty procedure and then do the plating.
So
what?
Turnoplasty.
We have to go for turnoplasty and do the plating to fill the gap.
To take the femur down.
Yeah, femur down or the tibia up.
Up, yeah, maybe. I have not done it.
So we've also used cages.
Yeah.
Titanium cages in the gap.
True.
And
but this, what I told you, the device is like a cage only, but it has been,
but
it has
a
been there.
simple,
What you say is true.
So
you can
to
do the
maintain
cage,
the
put
length,
it with the bone graft, and probably it will
So
help.
that's the interesting thing. We don't actually put in graft into the cage. We put it around the cage, because if you look at the spine cases that they've been done over the years where the arms cage was used and whatever, actually bone doesn't form inside the cage, it forms around the cage.
It's impossible to find it out.
No, because they've done it and they found that no bone, where they had to revise it, no bone grows within the cage, it grows around the cage. So we actually don't put in graft into the cage, we just put it around the cage.
For the security sake, I put it inside and outside and everywhere. Because you have a allograft, so there is no shortage of graft.
So when there is a hollow cylinder, bone cannot grow because there is no
there are pores all the way.
But what you have done, sir, in that the porosity of that lattice matches porosity of a normal bone. So bone will grow inside what you have done. It will not grow inside the cage.
Pardon?
So abhi next time you use
cages, but I put the graft outside. Yeah.
Just osteoconduction. So osteoconduction is also over. It's not going inside. So
in a 3D printed things, they have been able to show. You take the X-ray immediately afterwards. You can see the pores. I took the X-ray after 9 months. Those pores were held up, and initially I thought it's the X-ray which is taken in a different rotation. So I saw it on a C-arm in a few rotations, but I couldn't see the pores. That's all I can say.
Well, that's on the surface then. It's not, we are talking
Maybe,
about the tunnel inside.
Maybe.
So, but that.
Ilizarov is too long a procedure.
Just over the nail you can apply.
Fully aware of Ilizarov, which was the only option which was there in the past. Today I feel, at least once I did this whole replacement in the 3D printing, patient was walking
or
So though it is a trabeculometal and bone is going to form around it, so do you feel that we should add a long plate to supplement till it is not very solid, the construct? No, even with this cage kind of a system attached to it.
With the implant there is a plate attached and there was a nail which with the screws which were there with the plate and the screws were matching on the interlocking plate.
Okay. Yes. Composite. So it's a interdiction.
Good morning. Coming to the last presentation for myself, I thank the organizers and particularly Dr. Amulya for this opportunity.
Without you, he cannot hold you.
So, we've had some discussion about pilon fractures, one case that Dr. Agarwal showed. So we'll just go through the entire gamut of injuries that we have. So pilon fractures is a very wide spectrum, from the simple to the most horrendous type of fractures that you have. And being in a place where people fall off coconut trees, we get to see a lot of these injuries. And what determines what you do and how you do it and when you do it is the soft tissues. So these are just like the proximal tibia, the soft tissue takes precedence here. And all of us know that these are very challenging for even the best of the trauma surgeons. And there is not much of a consensus regarding optimal treatment. Of course, all articular fractures, you need to restore the congruity, get stable fixation and mobilize early. That's the principle, of course. But then when you have complexities in these fractures, there are some issues, okay? So considering the comminution that there is of the articular cartilage and the loss of cartilage in some instances, the excellent results are rarely achieved, and you need to caution the patients that the outcomes may be compromised. So soft tissues we've talked about. We need to evaluate the x-rays. I think yesterday Samarth briefly mentioned about x-rays, and then CT is mandatory like in any articular fractures. This tells you helps you decide where is the comminution, where is the impaction, and what approaches to undertake. So you can have various ways to approach these fractures. And then the so-called open fractures and what we get, some of the farmyard type of injuries when they fall off trees, those are a major issue that determine the outcome. We have bone loss also, and like I said, cartilage damage. So you need to be prepared with all the armamentarium, spanning fixators, all the gadgetry, sometimes bone grafts, not always, but you need to have bone grafts also in certain instances. So how to decide which way to go once the soft tissues are all right? You have done your scan, plan, or whatever way you do it. Then the CT scan, mainly the axial cuts tell you which are the major fragments and which may be the best incision for you to place. So you have the medial, the anterolateral, and the posterior fragments. In these, of course, there are variations as you can go along, as you can see, but these are the main fragments, and then you have to decide, just like in the proximal tibia, which way would be best, whether to go posteromedial, anterolateral, posterior and anterolateral, or whatever it is. So similarly, you need to have that. Serkin's paper way back in 2007, again it was mentioned yesterday, when there is a varus, you need a medial plate. When there is a valgus, an anterolateral plate. And when there is a pure axial loading, you need to look at the cartilage status. So this has been well mentioned. So I'll rush through in the given time some cases. So you can see here, right, there is a medial, anterior, and of course, some impaction there. So you need to decide with the fibula intact. So anterolateral approach. What is important is your preliminary reduction and fixation, and check under C-arm, make sure that you restore the articular surfaces and then fix it with fairly stable fixation, a rigid type of fixation. Here's one which we could get away with percutaneous sort of fixation. This was not a very complex sort of thing, but you can get away with minimal fixation in some instances. But most often what we get is fractures like this, where there is impaction and where there is comminution, where there is displacement. You see the void that has gone up over the anterior part there, anteromedial part, anterolateral, sorry. Massive impaction. So here is a need for bone grafting. You need to be prepared. Many a times you're not, if you're not prepared, you can get from the iliac crest, or nowadays we take from the proximal tibia as well. So just to go there, yeah, just rush through this. Most important is preliminary reduction and fixation. So you need to work from back to front, just like we talk about the terrible triad. You approach from lateral but work from medial to lateral. Something similar, you need to restore the congruity and then hold it with your K-wires, make sure that the articular congruity is fine, and then go ahead with your fixation. This was a patient who came about 8 weeks after being in an X-fix elsewhere. He was in a polytrauma situation in another town, and then he comes with this sort of situation. So sometimes you need to be prepared with distractors, otherwise it may be difficult. Or if you have a resident who will hold on to the calcaneal pin and pull all the way through, that's also okay. But see the comminution that there is, and this is after 8 weeks, so it's all the more trickier to get the reduction. But you have to work patiently, make sure that you get all the fragments in place, open the door just like you do with your distal radius, reduce, hold, I think I'll just rush through, and put some bone substitutes or bone graft, and then close the fragments, and then temporarily hold, make sure that the C-arm pictures are good, and then you go ahead with your fixation, right? So sometimes you need more than 2 incisions, right? So yeah, so this is what was done initially from the back, and then went anterolateral and a medial screw as well. So that's the outcome, range of movement. But there will be persistent swelling, like in all calcaneal fractures that we see. The swelling persists for a long time. In fact, it may never come back to normal. This was a guy who had a bilateral pilon fracture, falling off trees. This is what happens, including spinal injuries and paraplegias, what we come across. So this was the right side, and that's him walking all right, able to squat. Okay. So now coming to variable angle, in many situations it is a help because you can redirect your screws about 15 degrees in all directions. But there are papers that say that it will not hold all the fragments. Your variable angle will not be able to address corners like that. So you need more than a single implant, and some of the simpler implants are preferable compared to the more expensive ones, like Dr. Tanna was alluding in his talk as well. Okay, so yeah, none of the available plates can substitute for an understanding of the fracture planes and the fragments typically seen in complex intra-articular tibia fractures, and the addition of a second plate or even more maybe is necessary for adequate stability. So the take-home message is these are very difficult injuries. Soft tissue is the key, and you need to understand the fracture pattern. You have to study the CT scan well, plan, and you need to have combined approaches, and maybe more than one, preferably something like a fragment-specific fixation in most cases. Thank you very much for your attention.
Thank you, sir. Any questions from
There was a
audience?
nice observation. Why the pilon fractures we are seeing it so frequently nowadays?
One is the vehicles, I mean the motorcycles, the way they go zooming across, and they have those impacts. Even our cars also, many of our patients have been car drivers. With that impact that they get, they do come back. But many are these fall from rooftops and fall from trees.
Very lovely. I went through the Google at that time. He said, after the safety belts have come in the car and those bags have come, people don't die with the severe injuries.
That's true.
They survive, and that the injury to the leg is not avoided. That's the reason we see more pilon fractures, because they don't die. Otherwise, they all died, and we didn't see as many piloid.
Yeah, the brunt of injury goes there rather than the
The
Yes.
pilon exactly named first before when they were falling down from helicopters, and the strutters were onto the foot. And it's an excellent presentation, Ajit, and for this complex injury. What we say in our part to the patients with a complex pilon, one word, that your ankle is never going to be the same again.
Yep.
Otherwise, you are in trouble. But they will go for medical legal after. So we say in the beginning for the complex, your ankle is never going to be the same again.
I think whether it's the ankle, the talus, or the calcaneum, that is the die is cast. That's what the word is.
But hardly ever they need a primary fusion. They all
Well,
carry
how-
on for a fairly long time, whatever is the ankle
you have to give. Do you give any option in complex injury for the primary fusion?
Yeah, that is really everything is bad. If you can reconstruct it, they go on for a fairly long time with a reasonable range of movement in the ankle joint.
Yeah.
Thank you, sir. Thanks.
Thank you, sir. It is time for group discussion.
Group photo, sir. Gadigone, sir, Tanna, sir, Agrawal, sir, Rohan, please. Our Akhil, please.
I think while they are all coming up, I make a humble request for seeking your support for my candidature as IOA Vice President for this year, sir. Thank you.
May I request Dr. Taral Nagda, sir? This is your session.
Okay, so this session is Gofcon reel session. We are having 5-minute videos or PPTs of commonly done fractures, and we are going to show it. So I'm going to start with a very simple video of a supracondylar fracture. So first of all, stable reduction is required, column to column reduction. And these are some of the common fixations, cross fixations. The medial pin goes from anterior to posterior. This is one of the fixations. We also pass 2 lateral pins which are at least 8 mm apart. So that again medial and lateral both columns are fixed very well. This is my favorite fixation, 1 medial pin and divergent 2 lateral pins. And sometimes people use the medial fixation from the lateral side. So this is known as Dorgan's fixation. You avoid injury to the ulnar nerve, but sometimes you can get radial nerve in this. So I don't prefer it. So my favorite thing is 2 divergent pins. On lateral you should see if it's a transverse fracture, it's a stable fracture. And here the wire in lateral should go from anterior to posterior. However, on lateral if you get an oblique fracture, then anterior to posterior wire will not work. This is an unstable fracture and the wire should go from posterior to anterior. So small little tips into your wire direction. Again, supracondylar fractures are not just transverse, they come in various size, shapes. So this is a medial oblique fracture and only medial pinning will work. This is lateral fracture and only lateral pins will work. Cross pinning will not work here. So this is a real life patient. You see a supracondylar fracture. You take an X-ray with traction. On table, no blocks, give only GA. And before doing that, always assess nerve. And you can see here radial nerve is affected in this child. That does not change the management. You don't explore the nerve, just do close reduction and pinning. I use this simple plywood board as my OT table. Always mark your elbow with a pen so that radiologist finds it easier. I use a folded sheet so that your drill does not come in the way of your K-wire fixation. So small little tips on this video. Then you take a traction view. You give traction and first take a traction view, because that will tell you what is the geometry of the fracture. The second step is translation. This was a medially translated, so you give pressure from the medial side and correct the translation. And then third step is in hyperpronation, you do hyperflexion and reduce this fracture and stabilize it. And then you take an AP view. This is Jones view. Doesn't give much information because you can't see columns here. So we take oblique views. So there is external rotation view which shows medial column. We call it as max view, medial column with external rotation. And then you take internal rotation, so you see lateral column in internal rotation, Lin view. So you must see good column to column contact in internal rotation view and external rotation view. And now is the time to take a lateral view, and that is where all the trouble starts. You lose your reductions. So rather than moving the arm, you should move the C-arm. And this becomes very easy by using this plywood arm bolt as a fracture table. So we use the plywood arm bolt, and using that as a fulcrum, now you get reduction in lateral. Once you get a reduction, you have to pass your pins. So plan your pins before you pass the pins. The first pin goes at 60 degrees. This goes through the lateral column. And the second pin I pass, it is at 45 degrees. And that is a 4 cortex pin. This is how exactly it goes. It goes through the coronoid fossa and goes through 4 cortices. Now some more tips here. If you pass wire parallel to the humerus shaft, it cannot engage the distal humerus, because distal humerus is 45 degree anteriorly bent. So your wires have to go from anterior to posterior. But if it's an oblique fracture, you will go from posterior to anterior. Don't drill, first penetrate and then drill. And then confirm your wire position on AP and lateral, and then on max view and Lin views. So this is internal rotation view, showing you wire positions in internal rotation. This is external rotation view, max medial column, showing you wire position. And here we were not very happy just with lateral fixation, so we go ahead with medial fixation. The problem with medial fixation is that if you do it in flexion, the ulnar nerve will subluxate and then you will catch the ulnar nerve. So always medial fixation has to be done in extension. And because you pass lateral pins, now you are free to extend the elbow and do the medial fixation. Many times if there is a lot of swelling, I will make a small incision, put a wire sleeve, and I'll pass the medial pin so that you don't entangle the ulnar nerve. You don't have to feel the ulnar nerve, you don't have to expose the ulnar nerve. You just directly go over the medial epicondyle, but that protects the ulnar nerve. So once your wiring is done, the radial pulse is checked. You do pin side tracing. This is very important because pins come out when tracings are done many times. This is exactly how I put my Gamgee tracing so that it's very comfortable. Small little tips, the way we do it. Prepare a slab, and this slab has a cotton on it, so it's easy to remove and put it back. And always give this slab in 70 degree flexion, not in 90 degree flexion. I remove the wires at 3 weeks or 4 weeks and then mobilize, and never send this child for physiotherapy. So this was a technique on supracondylar fracture. If there are any questions, I will take. Otherwise, I want to invite Ritesh for his technique on titanium elastic nail to treat fracture shaft femur in children. All right. Yeah. Right. Yeah. So if fragments are rotated, there are 2 ways to do it. You can pass 2 wires, 1 in each fragment, and then undo the rotation, get it in good rotation, and then pass your cross pin. So that is a good way to do it. There are many other ways, but this is one of the ways.
And Taral, how often you need an open reduction?
So this question was asked to me in Jaipur IOCON in 2006, and I said no, and next week I had to do an open reduction. So very rarely, I have not done it for many years, but once in a year, we will get a case where we are stuck. And most of the time, these are cases where nerve and the vessels both are entrapped in the fracture site. And there is no option but to do open reduction in these cases.
Yeah.
So wherever there is spike, you open it. So if it's a medial spike, you open on the medial side. So median nerve involvement will be medial spike, you open on the medial side. The radial nerve involvement will be a lateral spike, and you open on the lateral side. So you undo, you open, you disentangle that fragment. You get a close reduction with your fingers, and then do close wiring. You don't have to open them like other open reduction of fractures.
So basically, if you can't get an open closed reduction,
reduction.
don't hesitate to open it, because getting a bad reduction is the biggest
So
disaster.
typical posterior approach
Very
open reductions are out now.
Yeah.
We don't do those.
We don't have to, but there are various ways you can do it.
If I can say, if it is the spikes which are there, which go through the muscles,
yes, sir,
and then you will not be able to reduce it
Right,
if they are
right,
already
sir,
inside
right.
the muscle. So any one with the big spike, they are the ones which will probably need an open reduction.
Absolutely.
If it is not been.
Yeah, and the incision has to be on the spike. It's very simple.
Yeah, open. So when
Once in a while, in fact, the intercondylar fractures and the supracondylar like fracture, what we call for the distal humerus, is pretty rare in children. And I have had a case which came to me of a bounce from an orthopedic surgeon. He was not able to reduce the supracondylar fracture like. So I went into it, took a look, and I was really zapped. Like, एक तरफ से जाला हो तो दूसरी तरफ से निकल रहा है, दूसरी तरफ वाला condyle.
Unstable, yeah.
It was very unstable, and it turned out to be intercondylar. वो view पे देखा, पूरा कुछ करा. Then I had to fix one condyle at a time. Medial को fix किया, and then went to the lateral wala, and then like you do a lateral condyle, I did it that way. Turned it around.
So
and
we used to
put it
believe
back.
that intercondylar fractures in children are rare. Does not happen. We have shown yesterday in the session that they do happen, and you have to have very high index of suspicion.
Yeah, I just get stuck on that once.
For the open reduction, there is only one way to go anterior.
Right.
And you can approach everywhere there.
Yes, sir.
One in a year, as you told, I get a case as well. I do about 100 in a year. So always anterior. I don't go lateral, medial, posterior, anywhere. Anterior, open, everything is in front of you.
Yeah.
And you fix.
Yeah.
Second thing is very simple thing. What size K-wire you are using across the edge?
So I use two K-wires which are of different sizes. One will be 1.8 and second will be 2.2 or 2.5. The reason is if you use two different size K-wires, on a lateral it is easy to identify which wire has gone there.
The wire direction in the BOST guidelines and American Academy is 2 mm.
Yeah.
So always 2
Yeah,
mm
so
for
up-
all wires.
Yeah, so if you take 2 mm as median, you go up and down. But
It also depends on the age of the child.
Age of
With
the
very
child.
small children, 2 millimeters may be too much.
so anyways,
I don't think even for the transcondylar thing is 2, but yes, rarely 1.6.
Yeah, since we have only half
2
an hour
is
for this
okay.
session.
2 mm is all right for.
Yeah, please. The request is, Amulya, you promise that next year you will have 1 hour session just on supracondylar. And we'll discuss that. Thank
The
you.
next time I will be coming.
Yes, sir.
We talked about the anterior approach.
Yes.
The anterior approach, once I've done it, but it has resulted in the contracture anteriorly and a very bad scars anteriorly. These children have.
So with these fresh fractures, usually your dissection is done for you. Okay, so you're just using it to reduce the fracture.
Yeah.
So it's slightly different from an open approach to reduce to anterior open approach going
If the
across.
spike is anterior, it's fine.
Yeah.
But if it's lateral, medial, to.
Let's get on with the next.
So good morning everyone. I will be going through the surgical technique of tense nailing for pediatric femur fractures, and this is what I follow in the guidelines from Synthase, and I have also used the guidance from the technique described by Dr. Sandeep Patwardhan. So TENS stands for titanium elastic nail system, and we all know the aim is to have a minimally invasive fixation of pediatric femur fractures. And this nail comes in various sizes ranging from 2 mm to 4.5 mm, and this is how it looks once the fixation is done. So the principle is based on symmetrical bracing of the fracture with 2 elastic nails through 3 bony point contact, and it provides stability in all the planes including flexural, axial, translational and rotational stability. And the ideal candidate is a child between 5 to 10 years of age with a diaphyseal or metaphyseal fracture of the femur, and usually a length stable fracture, that is transverse or short oblique types. The contraindications are intra-articular fractures, the length unstable fractures which includes comminuted or long oblique or spiral fractures, and obesity or overweight is also a relative contraindication. So coming to position of the patient is laid supine on a radiolucent table, and one can use a fracture table for older children. Now before starting the procedure, we need to determine the diameter of the nail, and this is based on the diameter of the medullary canal at the level of isthmus. So you can calculate the diameter of the medullary canal by taking radiographs, which includes a radiographic marker, so that the actual diameter of the canal can be calculated, and the total space occupied by both the nails should not be more than 80%. That is, each nail will occupy around 40% of the canal diameter, and both the nails should be of identical diameter to have a balanced effect. And intraoperatively, this is how we can calculate the diameter of our nails. So two nails or a single nail is placed on the anterior aspect of the thigh, and then CM images are taken, and as we can see, this gives us an idea about the ideal nail diameter which is to be used. So you can adjust the position of the nail, overlap it with the canal diameter, so that the diameter of the nail to be used can be decided. Then we make the nail entry point, and this is located 1 to 2 centimeters above the distal femur physis. Clinically, it lies around 1 finger breadth above the upper pole of patella, and again the entry point should be at the identical levels on both medial and lateral sides. Then we come to opening of the medullary cavity with a bone awl. So initially the awl is placed perpendicular to the cortex, and once you are in the medullary canal, it is tilted downwards to make an angle of around 45 degrees. And once the entry point is made, we prepare our nail. So pre-bending of the nail is important. The apex should lie at the level of the fracture, so start bending it from the apex, so that the diameter of the arch is around 3 times the diameter of the medullary canal, and again both the nails should have identical bending. So here in this video we can see this is how it looks after an ideal bending, and both the nails have identical bending, and this is how it will look in the bone inside. Then insert the first nail, advance till the fracture site. So first keep the tip of the nail perpendicular to the cortex, go inside the canal, and then rotate it 180 degrees so that the tip is aligned with the canal, and by gentle rotatory movements we need to advance the nail till it reaches the fracture site. Carry out the same procedure on the medial side and advance the other nail up to the fracture site. Then we need to reduce the fracture, and you can do it with closed manipulation on table, or can use this F tool as recommended by the AO people. And once the fracture is reduced, advance the nail in the proximal fragment. Now the important thing here is to avoid rotating the nail more than 180 degrees to prevent the corkscrew effect. So this is how it looks when both the nails are in the proximal segment. And then we need to decide the level of cut for the nail. So this is again based on the distance between the trochanteric physis and tip of your nail. So calculate that distance and add 1 centimeter to the length of the nail. So our idea is to leave around 1 centimeter of the nail outside the cortex. And after having the position achieved, ensure for adequate compression, so you can give gentle taps on the anterior aspect of the knee and check for any rotational deformity here. Now I won't be going into detail of this technique. This is basically the descending technique where the nails are applied from proximal to distal directions. It is based on the same principles with some differences in how to execute it. So just a couple of cases. This was a 4-year-old boy with fracture in the proximal femur managed by tense nail. This was another 9-year-old girl with bilateral femur fractures, and she had some metabolic abnormality also, and tense nailing was done for this child on both the sides, and this is after the removal of the implant. Thank you.
Yeah, thanks, Ritesh. We see another technique of femur shaft fracture, which is submuscular plating, and we do it very commonly for comminuted fractures and those the adolescent fractures. So Jaswinder will talk to us about the technique of submuscular plating for femur shaft fractures in children. Over to you.
Good morning. So I'll be talking about submuscular plating for the pediatric femur fracture. The indications for the submuscular pediatric femur plating are same as probably the contraindications for the femur tense nailing. So the age is actually 5 to 12 years. If the patient is overweight, we cannot put only tense nail, or we, for the overweight, we have to choose a submuscular plating. If the pattern of the fracture is there is comminution or there is a long oblique fracture as seen here in the X-ray, the tense nail will not hold it. So, or otherwise we have to put a tense nail and add an external fixator for sometimes, or do a submuscular plating. The location of the fracture, mostly for the shaft fractures, it can be metaphyseal fractures, the distal and the proximal 1/3 fracture of the femur. The advantages of the submuscular plating are because it is a there is a biological healing. There is not much of soft tissue stripping, so the healing is quite fast. There is less scarring, less pain, and early return to function. The technique we mostly use 4.5 narrow LCP. The recommended plate sizes are not less than 12 holes actually, and it should go from the greater trochanter apophysis up to the distal femoral metaphysis. The patient has to be put on a normal table, not a fracture table, because one can put on a fracture table also, but most of the time with a gentle traction by your assistant, the fracture will get aligned, and that is what we need actually. A bolster can be put below the hip and the knee. Coming to the steps, so if the fracture is in the proximal third, we can start proximally. We do put an incision there, and with a gentle like cob elevator or with the plate itself, we can manipulate just submuscular above the periosteum without periosteal stripping and push the plate distally. Similarly, if the fracture is in the distal third, we can do the same procedure starting from distally. Once the plate is put provisionally, we can hold the plates with 2K wires, one proximally and one distally, just to keep it in aligned, seeing the AP and the lateral views. And if there is some problem like the fracture is away from the plate, one can put a cortical screw just to pull the fracture, just a reduction screw. And then most of the screws after that will be holding it like a locking screws. So an example, this is a 12-year-old male patient. There should be a knee X-ray also. That was the only I had available that time. So this was a comminuted fracture. There's no other injuries. So putting a bolster below the hip and the knee, I have marked. And so in between, this is the fracture site where the butterfly is there, comminution. That is my proximal incision. That would be somewhere my distal incision. That is the greater trochanter. And that is somewhere is my physis. I would not be going below that. And that is how my incisions are. So in this case, I had slit the plate from proximally to distally, and fix with couple of screws proximally and distally. So this looks good in AP and also in the lateral view. Of course, I'm not worried about the 100% alignment and the sticking of this, because that will just unite. So that is 1 month post-op of the same patient, 2 months post-op of the same patient, and that is 4 months post-op. He's still under observation, I mean just ongoing healing, and he's able to do most of the activities at 4 months. I would be keeping them non-weight bearing for 3 to 4 weeks and maybe starting toe touch after that. And once the callus starts there, I'll put some partial to complete weight bearing as tolerated. And of course, from the beginning, there will be hip and knee range of motion exercises going on. Another patient, 8 years old with a comminution, similar, same procedure, same steps, and that is a healing at 6 weeks and 6 months post-op. Coming to the complication, so if the movements are not done well, the physiotherapy, there can be knee stiffness. Theoretically, if the plate is too distal, that is 2 centimeter near the distal femoral physis, it can tether the periosteum and it can cause a valgus at the knee. So I didn't have any experience in with my cases. The most important thing is the plate has to be longer. We should not be using shorter plates, and there are a couple of articles now available. So a minimum recommendation, as this paper from Jammu, is that they use a minimum of 13 plates. Earlier, 13 hole plate. Earlier they were using 10 hole plate, because otherwise the plate breaks or there is non-union. So for example, we had one of our cases. This is a 14-year-old male patient with 7-month-old fracture. So this has gone to plate failure. There is bending of the plate, non-union at 7 months. So we revised it. We used a longer plate, molded it without any bone graft, and that is how it went to heal in 2 months and 3 months. That's it. Thank you.
Jaswinder. So any questions on this? I just want to add a couple of points that bending the plate is very important when you are doing submuscular plate, both at proximal and distal end, and go from trochanter to condyle levels. You don't use short plates. Now Synthes imported plates are not long available. The Indian plates, long plates are available. So you know, this is the, in Bombay nahi milta hai. So we use Eosis or any other Indian plates because they really are available in long forms, and the first screws are cortical screws. Now one more modification I do is I do combi fix. So I will put 1 or 2 elastic nails, get the fracture aligned, and then pass submuscular plate, because then the alignment in lateral is much easier that way. It prevents a lot of CM shoots and makes the procedure much easier.
So you put first couple of screws and then plate over that?
No, first elastic nail just to align it, and then I put submuscular plate. Yeah, Amit. Pardon? No, I keep it inside. Because of this problem of valgus in children, we tend to remove the plates early, but keep the nails inside because we don't want to have stress the fractures with the plate removed. Yeah, but these are patients which are comminuted, so just nails are not sufficient.
But even
so you additional plate. But if you are putting nail and then doing a submuscular plate, just 2 screws above below are sufficient. You don't need so many. Agreed. Yeah.
In the adult practice, we do it very commonly for the polio patients. We put this titanium elastic nails and add a plate to it. But sir, for pediatric patients also, if it's a heavy patient, you should do it.
We do it.
50.
In heavy patients, submuscular plating is not easy.
Combination.
Because, but once you have nail in place, it becomes easy.
Yeah, so in
adult
I think polio patients,
I would just say that you need a nail only if you can't get a closed reduction.
Possible.
So if you can get a closed reduction without a nail, then you don't have to put in a nail. Okay, so it's simple as that. So if you
get a closed reduction, is still mobile when you're putting a plate.
Yeah.
So if you put in the enders earlier, which we do it in the humerus, the whole thing has been fairly stabilized. All what you need is a traction to, if there is an overlap, to overpass that.
Absolutely right, sir. But it's not necessary.
Yeah.
Okay.
If you're John, it's easier. But some of us.
No, we've used it. We've used it in the past, but I think in fact I presented on submuscular plating way back in pediatric patients.
Lateral entry, because आपका plate भी lateral entry से
lateral plate होता है ना,
medial नहीं डालते फिर nail. Both दोनों भी डाल सकते हैं, end of plating. So we come to the last technique of
medial
this
nail. Not a plate, yeah. Plate is a lateral plate always, almost always.
So Amulya, I think we were right in initially keeping 1 hour for this session, but we had to wind up in half an hour. So what I'm going to do is we have the last technique of this session, but as the bonus for our Gofcon viewers, the last talk which I have, which is valgus osteotomy for non-union neck femur, I'm going to pass on to you, and you can just share that video for all the delegates, and that's going to be a weekend watching back home for everybody. John, over to you.
Okay, so we'll just go to this patient who's a 6-year-old boy who actually presented to us 6 months after the injury. Okay, this was treated non-operatively in an initial cast, mobilization exercises. So he had mild pain and restriction of motion, but a totally displaced lateral condyle fracture. So from Ireland, Dr. Amur, so what would you do for this? Dr. Omer in Ireland, what would you do for this?
Oh, sorry.
6 months old, lateral condyle.
Non-union.
No, it's come in to you at 6 months, okay? So.
I usually don't get it. Actually, very rare. I haven't had any case like that. But yes, still, if it's not new, I will do a CT scan first to see what's the status of healing. And yes, I will go for open reduction and fixation.
So John, I will use this Dr. Tanna's terminology. So he asked us to talk on this at one of the trauma cons, and he called this a repairable non-union, which means you can still get the fragment back.
So this is what I'm trying to say is that if you look at the literature, they'll tell you after, initially it was 3 weeks, then it was 6 weeks. And if it's a completely displaced fracture, after 6 weeks, you don't touch them. You deal with them later. And with this guy, see, he's got a fairly good range of motion. And it's very tempting not to do anything at this stage and deal with the complications later, like a valgus or whatever you have, or an ulnar nerve palsy. But you know that this is going to happen over time. So we decided we'll do something. Okay, so that was the approach we use, is a lateral approach. There are some people who prefer a posterior approach. But I think the most important thing when you're doing these old is to avoid any damage to the cartilage. Okay, so your incision has to be very careful. Then your dissection again. So you go down to the periosteum. You elevate the periosteum. Okay, so don't try to be extra periosteal in these late cases. You elevate the periosteum so that you have got a good approach to the joint. Okay, and then this is the difficult part, is actually dissecting out the cartilage without damaging the cartilage. Okay, I think you have to be really careful in this stage where you are very careful with the knife. You can see the glistening cartilage there, and it's very easy to nick that with your knife. So be very careful when you're doing the dissection of this part. And as you do it, you can see we are going down to the radial head there. So if you can see, as we do that part, you can see some fluid coming out, and that's the radial head appearing in there, okay? So again, just be very careful with your dissection. So you know that this area, the lateral condyle is totally flipped in these cases. Okay, so although what you see looks like it's in position, you know that it's flipped because you can see it on the x-rays and you can see it on your position. So again, be very careful when you're dissecting out the plate, and then you have to find out the level of the fracture. Okay, so the area of the fracture needs to be dissected out also very carefully. So you've got that, that's the whole piece, and that's where the fracture was, okay, where I'm marking it out with the knife. And then you have to mobilize this fragment, okay. So there we start mobilizing the fragment. You make your incision into that area, and then you get that fragment out of your way, okay. So gradually with an osteotome, you try to gently manipulate that out of the way, because by then there's a lot of fibrous tissue there, and you have to really be careful that you don't damage the condyle when you're doing this part. Okay, so then you go on to the medial side. Okay, so you have to get the medial side dissected out so that when you do your open reduction, you get a perfect reduction of the cartilage to that part of the medial part of the joint. Okay, so what happens in these old cases is the attachment to the extensor muscles which are attached to this fragment tend to get very fibrotic and sclerose, and you can't actually get this piece rotated back into place unless you very carefully dissect it out and you actually lengthen or release the muscles so that they get long enough so that the fragment can be flipped back. So if you look at that fragment, that's the part which articulates with the medial part. Okay, so you have to get that back, get all this tissue out. So that's the medial part we're clearing out. And it's interesting that we never have to bone graft these, because in fact it's difficult to find place to put this fragment back. Okay, now you can see how this fragment has gone back. You've got a perfect reduction, and once you've got the perfect reduction, then you go ahead, you make sure that you release enough of this muscle so that you can get this without any tension on it. So again, you get the perfect reduction, you put your clamps across, you put in your screws. Here what we use is 2.4 millimeter screws. Okay, so nowadays those are available. So instead of K-wires, we tend to use screws in these late cases. So you can see how we are putting in the screws. So we put in one screw across the joint and two into the metaphyseal parts. Okay, so that's the metaphyseal part.
That's the screws there. You make sure you've got a reasonably good range of motion on the table. So try to make sure that once you've done your fixation, you're not restricting the range of motion. Those are the immediate post-op x-rays. We keep them in a cast for 3 to 4 weeks. That's him 5 months post-op. You can see he's already got back a fairly good range of motion. This is him at 9 months, and this is at 2 years down the line. Okay, that's when he came back for removal of his implants. And so that was his x-ray at that stage. And we removed the implants, but while removing the implants, you can only remove one of them. The other two, the head broke. So that's what he's left with. But I think he's got a good range of motion. The late presentations remain a challenge. I think displaced rotated fractures presenting late is a bigger problem than anything else. I think all the other things nowadays you've got good solutions for. But these displaced fractures which present late, and especially 6 months down the line, are a real problem. You need to assess these very carefully and counsel the patients, because you are a patient who's already got a reasonable range of motion. You don't want to make it worse. Okay, so I really have good guidelines for dealing with these late presentations. Thank you very much.
John, but they cannot have the guidelines, John, because they do not see this at all. You and me see it day in and day out.
We also know, but we don't see it day in and day out. So 6 months down the line, we've seen 3 in all these years.
So John, the guidelines, you and me will have to write these guidelines.
Yes.
That was John, one thing I am surprised. Those broken screws, you left it there.
Yeah.
Somebody like you within a child, then afterwards it will be impossible to remove.
So it doesn't matter, sir.
They will go inside.
So it doesn't matter.
You didn't have the instrument to take it out.
No, I can take it out.
Or you were too big a list at that time.
No, sir. It's that you have to make big holes in the bone to remove those. And then they become stress risers, and I don't want him to fracture through any of those.
So John, convince the parent that these were his signature marks.
John, do you scan them? Do you do the CT scan?
No, we don't. John, do you do CT? Because we know that.
No,
not going to change the management.
Not for these 6-month-old, 3-month-old, we don't do CT scans. If it's something unusual, yes, definitely. So like yesterday I showed that case where the patient came with almost like a terrible triad. There I would get a CT scan or even an MRI, ideally an MRI, because they are, but only problem with MRI is that they need a general anesthetic or some kind of sedation before you can do an MRI.
I have a similar patient in follow-up actually. That's
so we don't bother with CT scans for these routine cases.
When I fixed it and got in say 4 months, I was not looking right. After removing the K-wires, I got the K-wire fixed, and so there was some displacement. And when I got a CT, it's well healing up. So then I decided, okay, there's some malunion I can say. So okay, we will deal it later. But if it's going in non-union, within that period, 6 months or 8 months, I'm going to do the same.
So you're looking for a non-union or a malunion. That's a different situation. Here we know that this is not uniting, okay, because the fragment is totally rotated.
How you are sure about that with X-ray?
Because it's totally rotated.
Yeah, well, okay.
So this situation comes very often where you use only K-wires. Because you need to remove the K-wires in time. You can't keep them indefinitely.
How long you keep it for lateral condyle?
So normally
if
for
it's outside, you will keep it. You can keep it maximum 5 weeks or 6 weeks, not more than.
Almost invariably for the lateral condyle, I bury it and I take it out at 8 weeks time, not before that.
Yeah, but if the fracture is not healed, then it's a problem. So we use screws nowadays and not.
That's an option here.
I think last comment before we end. So every time Amulya stands here, we know that we are. So he's still sitting. We can still have time for.
Sir, I had to face still worse situation. I had fixed with 2 K-wires, and after 6 months, I found that the whole of the fragment is absorbed, and the K-wires are still in position. Yes. Open reduction.
Yeah, so I think when you're doing open reduction, you really have to be careful about the dissection. I think that's the key to success.
So because of EVN, so excellent session. So thanks to Ritesh, Jaswinder, John and Taral and Amulya for allowing this session. We'll come up with a supracondylar session in next Gofcon for 2 hours. All right.
Next moderator, Dr. Niladri Vishwas, please.
Good morning, everyone. I'm Dr. Niladri Vishwas, your moderator for this session. And I'd like to call the panelists on stage. Dr. H.N. Divakar, sir, Dr. Arun Kumar, sir, Dr. Sudhir Kumar Singh, sir, Dr. G.H. Jha, sir, and Dr. Amardeep Narayan, sir. Please come on stage, sir. I would like to call Dr. Arnab Sinha, sir, for to start this session.
Good morning, everybody. With the permission of the chair, this is the photograph of Dr. Ponseti in the management of clubfoot. He is famous everywhere. So this is the photograph we are accustomed to look at him. He looks like this. The oldest orthopedic surgeon for the youngest patient. That is how he has been described. Now what happens if I change it to the youngest orthopods for the youngest patients? What do I mean? I wanted to find out the problems faced by the PGTs. That is the postgraduate trainees of orthopedics. That is the youngest orthopods I could get in the management of clubfoot by the Ponseti method. A questionnaire for the PGTs was made of the possible problem areas faced by them. It contained 11 questions to identify the problem areas. The responses were either yes or no. Yes meant a training or discussion is needed on that particular topic, and no, that they were pretty conversant with that. 10 PGTs were chosen, 42 was the total number of feet. Inclusion criteria of PGTs were PGTs having the experience of less than 10 club feet managed. Inclusion criteria for the club feet patients, either idiopathic cases were taken or those with an age of less than 9 months at presentation. Exclusion criteria secondary club foot and those pre-treated by other methods. These are the results. You can see that there are 11 questions and these are the responses by the PGTs where they were facing a problem. These were the 3 questions, question number 1, 2 and 11, on which all 10 out of 10 said that they needed some help. That is, did you face problems while answering the questions asked by the parents before starting the Ponseti method about the number of casts to be needed? If you look at literature, literature is varied. Some say 5.3 casts, less than 4 casts, 5 casts, 6 casts. In this study, the number of casts was 4 to 8. But this is a major problematic area for the PGTs to answer at the start of the treatment itself. Similarly, the question about the need for tenotomy. We may say that it is just a tenotomy, it is a small operation, but for the patient and the parents, any operation is an operation. So these are the varied amount of percentages given about the necessity of a tenotomy, and it is a problem which they face while answering the parents. Third was the compliance of the foot abduction orthosis. Now look at this child. The foot has been corrected, he is on a FAO, but he is not happy with this FAO. But we know that if it doesn't end up wearing it, there is a higher chance of recurrence. 80% according to some studies, 5 times more risk of a recurrence according to other studies, and many studies are there saying the same thing. So what can be done about them? Advise the parents to avoid removing the brace if the infant cries, because if the infant learns that by crying the brace will be removed, the pattern will be difficult to correct. Also, assigning responsibility to the grandfather or the grandmother may be appropriate in some situations. Coming to the next 4 questions, which 7 out of 10 said and recognized as a problematic area. Did you face problem in locating the head of the talus? It is acceptable because it is a thing which is of training. The number of club foot you do, the more better you get doing it. This is how it has been described in literature. Very easy thing to do. The only thing is that you need to do it again and again. So this was not such a major problem faced by the PGTs. Third question about excessive pressure, casting, ulcer. The tendency to apply a constant pressure may lead to an ulcer. So one should press and release repetitively, and molding should be done properly. In our study also, 2% of the feet had superficial ulcers, but fortunately they recovered. What about the problem faced about tenotomy? Either a premature tenotomy or an inadequate tenotomy. The requisites of a tenotomy are the Pirani midfoot score should be 0 and the forefoot abduction should be 60 degrees. Any tenotomy done before that is premature tenotomy. The other thing was a pop is felt as a sharp edge releases the tendon. The tendon is not cut completely unless a pop is appreciated. The tenotomy maneuver should be repeated to ensure a complete tenotomy if there is no pop. In our study also, re-tenotomy was needed in 4% of the patients. The next question is calming the baby during casting. It is another difficult point. The mother is sometimes allowed to come inside the plaster room. Sometimes she was not allowed. Sometimes she was allowed to breastfeed, sometimes bottle feed. But there is one thing which helped in calming the baby the most number of times. And that is the magic toy for babies nowadays. That is the mobile phone. If you give them a mobile phone, the casting becomes much and much easier. And we also need to remember that we are talking about PGTs. So other than the baby, we also need to calm the PGT sometime during the casting. That the baby should also keep calm and the PGT who is applying the cast should also keep calm. Coming to the last part of this presentation, the last 4 questions, which only 4 out of 10 found a problematic area. One was, did you get worried about not starting the casting in the first week of life? Practically it is not possible, but ideally it should become as early as possible, probably in the first week. But practically it is not possible due to various numbers of reasons. Second was, did you face the problems while answering the question asked by the patients about the deformity seemingly increasing after the first cast? After the first cast, the deformity seems to be increasing, or the overcorrection of the deformity of the post-tenotomy cast. What happens is that the first cast is for correction of kivas. So it brings the forefoot in line with the hind foot so that both can be abducted together effectively. But it looks like the deformity has increased. Similarly, look at this one. The minimal scar of tenotomy, adequate correction present, modified foot arthrosis. So what was the problem? The problem was the shape of the cast. The post-tenotomy cast appears to be overcorrected into abduction. So these 2 problems, both of these are a matter of concern for the parents. They are going to ask the PGT and also for the PGT what to answer about that. Did you face problems while choosing between making the cast too bulky or of adequate strength? Now we tend to do over plaster. The plaster may be layered back and forth over the anterior knee only for strength, because a large amount of plaster in the popliteal fossa will make the cast removal more difficult. The PGTs tend to think that more the bulk is, more the strength of the cast. So they tend to overdo the casting. So these are the results. 10 out of 10 problem areas, 7 out of 10, 4 out of 10. Now in conclusion, I would just like to say that even in these days of information overload, where so much amount of information is present in the palm of your hands, every mobile of every PGT is loaded with presentations, is loaded with PDF files, is loaded with video links, YouTube, everything about the whole maneuver. Still problem areas are identified, should be focused training and discussion done on them, and there is a French aphorism which says that the more things change, the more they remain the same. So I'm going to leave you, since we are talking about postgraduate trainees and residents, this photograph of Dr. Ponseti when he was a resident himself at the center, with Dr. Arthur Steindler on the right side speaking, taken from CORR May 20, 2009. Thank you.
Yeah, Dr. Amit, please.
A few points would be repeated from Ajit's presentation. I think he is not there, and there are a few new people also, so it's okay. Distal tibia or the ankle, you have to always take an injury film. An axial cut of the CT scan at the joint level is very, very important, and to decide your approach, a 3D CT also is good enough. Get it right. Ankle is not a forgiving fracture. Your proximal tibia could be a forgiving fracture. Your knee replacements are forgiving. But an ankle is not a forgiving fracture. In the ankle, you have to get it right the first time whenever you do it. It should be a systematic approach. In any compound injury, what I feel is you have to stabilize the fracture first. Here we have applied an external fixator with or without a fibula fixation. I generally do a fibula fixation because I am the final surgeon. I know I am going to operate the patient again. Tanna sir, क्या डाला है? You're not feeling well? ठंडी लगते हैं? No, I was looking out for you in the first row only. पीछे जाके बैठे. So external fixator with or without fibula, and then after the soft tissues improve, do a definitive fixation. Three major fragments: the medial, the shaput, and the Folkmans. And you have to it is an open book basically when you open it. You have to go through, approach through the fracture lines. And a distal tibia fracture is different in a ankle fracture by the way that a distal tibia always has an anterior combination. Anterior combination is there, if you can see. So the windows are there, and the optimal approach is you have to decide by the CT scan. Look, this CT taken at this level, you will decide whether it's anteromedial, anterolateral, a direct lateral, posterolateral or posteromedial. Generally it is a posterolateral because you have to get your posterior malleolus in place, and as well as if you need, you have to go anteromedial or anterolateral. So these are the approaches. If you can see, this is the anteromedial. Tibialis anterior, everything is reflected laterally. Your anterolateral go up from the fourth metatarsal, and all your extensors reflected medially. It goes on the interosseous membrane. The posterolateral, simple. There are only two muscles, the peroneal and the flexor hallucis. And posteromedial comes from here between the flexor digitorum and the flexor hallucis. So these are the approaches. 7 centimeter gap is always has to be left because this is a paper, JOT, angiosomes they have described. And these are angiosomes which explain why surgical incisions can be left safely placed 7 centimeters away. I will not go into the details of the angiosomes. Fixation of the posterior fragments, this is the posterolateral approach. If you know, this is between the peroneal and the FHL. You can see the posterior fragment well. This is the anteromedial, which I told you, just medial to the tibialis anterior, reflect everything laterally. This is the anterolateral up above the fourth metatarsal base, and it goes and you reflect all the extensors medially. You can plate both the fibula and as well as the anterolateral plate from this. And the preferred could be a workhorse incision which is between the tendons of the tibialis anterior and the extensors. So that is the preferred. You go anteriorly and you can place your tibial plate very well. Convert a C type into a B type fracture. That's very important. You have to take care of your articular surfaces, articular depressions, impactions well. You know where you're placing your screws, initial wires. Look, this is the way you work through the fracture, deep to superficial. First go deep, reduce your fracture, reduce often your Folkmans to the medial fragment. Need a distraction, a direct visualization at the fracture site, and intra-articular direct visualization. Reduce the fibula to get the length, alignment and rotations. Use the talus, this is a very important statement, talus as a template for all small free pieces. And probably this is the only fracture where you require a bone graft subchondrally. Look, the CT scan shows you where the impaction is. This is very important. In this fracture, there is a lot of impaction. So you have to leave, there will be a void. And in that void, you have to fill in bone grafts. Once you do that, you reconstruct the correct length of the fibula, reconstruct the articular surface, cancellous or autografts, or allografts, whatever you are doing. Stabilize the medial side with the plate. And you have to put the plate where? On the compression side. Wherever there is compression, and wherever there is, if it's a valgus fracture, then you have to put a medial plate. If it's a varus fracture, an anterolateral plate. But generally, medial plate is the gold standard. You have to put. I've seen Professor Christian Kretek. Wherever in all his distal tibia, he puts a medial plate. I asked him, no, it's a gold standard. Medial plate I always put, and a fibula plate. So now look at this case. This was a compound fracture. 31st December injury. This was a typical case how he came. Tanna sir was describing seat belt injury. Seat belt he survived. He survived because of the airbags and everything, but his ankle had gone. Now we see these fractures a lot. This particular bone, I'll tell you, this bone was free and it was on table, this big bone. This was carrying its articular surface. And now what we did is CT scan, then I went ahead, put a external, I did a fibula plate. It was not done well probably, and this was it. I put that fragment back, put screws into it. 15 days later, it caught up with some infection. I went down again, I debrided it, put stimulant, and this was it. I removed the external fixator, and I kept the patient like this. It was this way. He didn't follow up. You know this case, Tanna sir. He didn't follow up. His father was an allopathic surgeon. So he went on doing the dressings. 5 months. He was just sending me clinical pictures and x-rays. This was 8 months. This was a year. Everything had healed, and that was the x-ray. And this is 9 years follow-up. He has developed some amount of arthritis. The father and son had performed that removal of 1 screw in the ankle. This is 9 years follow-up, and this is him. He's a young person, around 37, 40. He's walking well. He's doing all his job. But probably that external fixator and fibula plate was the only surgery I could do other than that debridement. This is another case wherein this was a distal tibia combination. We went ahead and put this middle plate and a fibula plate and came out. Fibula fixation should be reserved for cases where it may aid in reduction or provide additional stability. This is what is said, but I do plate the fibula always, because most of the times it is comminuted, and along with the tibia plating, a fibula plating gives me a good result. Difficult injuries with multiple treatment options. Poor planning can be devastating. Plan according to the fracture, plan according to the patient. A CT is a must, axial at the pilon and 3D for geometry. Wrinkle sign is important. Wait till the wrinkle sign comes. After a fixator, convert a C-type into B-type fracture. Femoral distractor has to be there on table. Fibula fixation aids in length alignment reduction. Staged protocol, support the compression side of the fracture. Bone grafting or fillers needed for the voids in the metaphysis. Thank you.
Thank you, Dr. Amit. So good presentation. Next speaker is Dr. Pradeep Chaudhary, Management of Fracture Dislocation of Talus.
Thank you again, Dr. Amulya Singh and the Gofcon team for inviting me. And Dr. Rohan has covered most of the part of the talus. Hopefully he has not discussed the classification, so I'll stress on that. So talus is 60% of the surface has got cartilage, and it is the only bone which has got no muscular insertions. And the majority of the talus is supplied with the artery of the tarsal canal. It's 2% of the all fractures and 6 to 8% of the foot fractures, and it associated with high complications rate. And the Taylor classification is mainly described by the Hawkins and is widely used, and it is also predictive of avascular necrosis rate. The first type is an undisplaced one, which is usually we don't get, is uncommon. Usually a talus fracture is a displaced fractures, and this is just undisplaced fracture of the neck of the talus, and AVN is less than 10% around. Type 2, which is the most common, where the subtalar joint is, fracture line goes up to the subtalar joint, and avascular rate is around 20 to 50%. Type 3 is where a subtalar and an ankle joint is dislocation along with the talar fracture, and it is high AVN rate of more than 80%. And another type 4 classification is described by Canali, where a subtalar and an ankle joint dislocation associated with a talonavical joint dislocation. So if you see, this is like this. If you see this type 1, where only a undisplaced fracture, here a subtalar dislocation, here subtalar and an ankle dislocation, here subtalar, ankle and a talonavicular type of dislocation is there. And it is a usually hyperdorsiflexion injuries, commonly seen in motor vehicle accident, as already described by Dr. Tanna sir. Pilon also talus, and then fall from the height. These are the injuries are there. X-ray, you require AP and lateral view, and of course you require a mortise view to see the congruity of the ankle and subtalar joint. You also require a canale view, where a 15-degree pronation, X-ray tube is 15 degree from the vertical like this, and you get a longitudinal view of the talus. And of course these days CT is a must. It is best study to determine degree of displacement, comminution and articular congruity. Goals of management: immediate reduction, anatomical reduction and stable fixation, union of the fracture and prevention of the complication. Urgent close reduction of the dislocation is usually done before a CT is done, so better to try a close reduction. And how do a close reduction? Adequate sedation, flex into relaxogastrocnemius, traction to the plantar flexure forefoot to realign head with the body, and valgus and varus. Maximum you can do 2 attempts only, not more than that. There are controversies regarding surgical timing, close reduction, surgical approach and fixation. Literature does not show clear consensus about beneficial effect of immediate open reduction with definitive fixation. The risk of AVN depend on the initial trauma with associated vascular damage. Definitive fixation should be delayed and should be performed by experienced surgeon. There is some limited evidence that delayed fixation may provide better outcome because of the soft tissue recovery and managed by experienced surgeon and opportunity for the surgical planning. So it is always better to do a early fixation but not the emergent in the midnight. Open fracture may be treated with the external fixator or with a debridement, and sometimes in close injury external fixator can be used to stabilize reduced talus when the soft tissue do not permit for open reduction and internal fixation. Anatomical reduction and rigid fixation articular talus fracture remain the mainstay of the treatment. Further surgical consideration like dictate that approach, implant use or fixation should be decided by fracture combination, concomitant body and soft tissue injuries or fracture pattern. These are the ways to decide what approach you will require, what implant you are going to use. 3 main approaches: anteromedial, direct, lateral and combined approach. Anteromedial approach with the TA and a medial to TA and an anterior compartment contained. It is mainly to see the posterior part of the talar body. Direct lateral approach, visualize the shoulder view of the screw position and we can see the neck actual position, the alignment. So now 2 incision approach is recommended in talus, visualizes medial and lateral neck to assess reduction. It benefits axis of the reduction and subtalar joint. Combined approach facilitate maximum exposure, and adjuvant oblique malleolar osteotomy may be required to expose the talar dome if indicated. But if you are using 2 approach, you may get away without doing a malleolar osteotomy. Implant choice is all depend on degree of combination and the bone quality, but it should be strong enough to withstand motion. Leg screw fixation confers maximum stability, but currently there are mini fragment plates are there on the lateral talus. Is recommended to avoid medial shortening and varus malunion. Few cases here a fracture dislocation talus with the there is already fracture of the medial malleolus was there, so it was only single approach was used and fixed with the screw. And this is 1 month post-op. This is with the type 2 Hawkins with the subtalar dislocation, managed with another associated with the medial approach. Intra-op fixed with this. This patient we lost in the follow-up and he came back with the 7 year with the good function. Another case with the talus neck fracture, managed with the CT scan. These are the recent cases, last 3-4 years, so we started doing CT. Those were around 5-7 year old cases. With the neck fracture, you can see that this is a CT scan. We used a medial approach and a direct lateral approach, fixed them with the 2 Hubbard screws. Another case with the fracture dislocation, and this is type 3 with the ankle dislocation also. Managed CT scan. And also associated with medial malleolar osteotomy. So we did a medial malleolus fixation, another medial approach and a direct lateral approach, fixed with a medial malleolar fixation and the fixation of the talus. So Hawkins signs shows at the 6 to 8 week, and sometimes it is asymptomatic, not majority of the cases it is a symptomatic one, and presence of subchondral lucency implies a revascularization, and this is like this. You include fracture of the talus are challenging to manage with high rate of complication. Advanced imaging with CT scans is recommended in all talar neck fractures. The Hawkins classification system predict the rate of osteonecrosis. Dual anteromedial and anterolateral surgical approach may be beneficial. Thank you very much for your patient hearing.
Thank you, sir. Next speaker is Dr. Samrat Mittal.
Thank you, sir. So I'm just going to present this case of a 42-year-old male. He presented to us 6 hours after this trauma. So, no other injuries. He had something in the chest and the abdomen, but all that was settled, and this was the after the emergency resuscitation in the emergency department, having this proximal tibia fracture and a distal tibia fracture. So we put the patient in a spanning X-fix, and because there was a distal tibia fracture, we couldn't put any pin in the tibia, and we did not want any implant in the tibia right now to decrease the risk of infection. So the other pin was in the femur, and this is the CT after the spanning. So if you will notice, the proximal tibia fracture is extra-articular, although it's very close to the joint, and the distal tibia fracture is intra-articular, both anteriorly and in the center of the joint, but not too displaced. Any ideas what to do, sir? Pradeep, sir. Nail plus plate, sir. So one nail, two plates. One plate at the top, one plate at the bottom, sir. Ilizarov can be done, sir. So that's a good option. I presented on nail plus plate yesterday, so sir, I think I agree with you. Only for a distal tibia fracture, I talked about nail and plate yesterday, so I think that's a very valid answer. Dr. Janki? Two plates, one for the proximal tibia, one for the distal tibia. So bicondylar plating for the proximal tibia, considering it is a bicondylar fracture not going into the joint, and a single plate for the distal tibia. I'll just come back to the X-rays. Yeah. So medial plate and a fibular plate. Perfect. So soft tissue condition wasn't very good, and I'm going to show you the slides, but not too bad. Yes, all this what we are talking is possible. So after waiting a week, we took the patient up, kept everything in the inventory, not Ilizarov, yes, but I agree, I am not great with Ilizarovs, but Ilizarov is a great answer for these injuries. So we went in, first thing I did is gave some traction, got a closed reduction for the ankle, and with these 3 or 4 cases, so first I got the length of the fibula right, put in a thin K-wire in that fibula, it has some varus, and then these cross K-wires in the ankle to get a good reduction of the ankle and to maintain that reduction. So with that I thought I have a good reduction of the ankle, and then I went on to the proximal tibia. I haven't opened anything as yet. So the first thing I did is I put in a clamp in the A to P direction to get the posterior sagging of the mid shaft of the tibia going back and try to bring that shaft up. After that, I put in a clamp mediolateral. You see that king tong periarticular. So I've used this king tong clamp trying to bring this fragment towards this fragment. And then I started off doing a suprapatellar nail. Passed on the nail into this area with the wires. I had to remove one of the wires because that was coming in the path of the nail. Kept this wire for the fibula in. And at the top, with the reduction that I had, I locked all the 4 interlocking screws of the nail, thinking that I have a good lock there. Still the distal part was not locked, so I put in some extra clamps to get in more compression and try to decrease that varus from the fibula. If you see, the clamp is not on the tibia here, it's on the fibula. So I'm just trying to decrease the varus, that light varus that was there here. Yes, I could have done a plating for the fibula to get that perfectly right, but the soft tissue condition wasn't too great. All this was still subsiding, and I was worried that all this is going to come off. So I did not do much of reaming, and this is the introp AP lateral and the ankle AP and lateral that I could get. Yes, I could have done augmentation with the plate, which would have been a great answer, but looking at the bad skin tissue condition, I did not. I just put in all the possible screws through the nail and 3 screws around the nail. I tested, so thank you Pradeep sir, so, and thank you for stressing that point. After every fixation that I do, no matter what part of in trauma, I always stress these patients for varus valgus flexion extension for both the joints, and I felt the reduction and the fixation wasn't too bad. Yes, it wasn't rock solid, and probably adding a plate wasn't a bad option, but I felt that this was okay and soft tissue condition was okay, and this is the immediate post-operative X-ray. I know, yes, there is some amount of varus here, but if you look at the tibia, did not look too bad to me, so I accepted this. And that's 3 months down the line, that's 6 months down the line, and I'm sorry I've used the wrong presentation. This is a 2-year follow-up also, but the fracture well united. So this was one of the cases where I used a nail for both extremes, the proximal tibia and the distal tibia.
Plated the fibula.
I could have, sir, yes.
So Samath, I think perfectly well done. The only thing I would do is that you put in the nail and then try to correct the varus.
Yeah.
So correct the varus and then put in the nail.
Yes, sir. So I think that's perfect. I should have done that. Thing was, I think why I did it wrong is because I accepted whatever was there, put the nail in, and because I had a very good proximal tibia reduction and fixation intra-op, I thought maybe I can improve. So I think better is the enemy of good. I was trying to improve what I had got and what I had accepted to start off with.
I think it was well done.
So 4 screws here. I removed. So this patient actually, so this is a story. So this patient wasn't a very well-paying patient, but he had influence from a lot of people. So in the follow-up after 6 weeks, this patient was lost to follow-up. He went to some other surgeon. That surgeon said that you need to remove these screws. So they removed these screws, and when he came back to me, I said, why? This is, I need more stability and someone is decreasing the stability. Thank you for noticing that. And so I almost told him, I'm not going to follow you up now. And then he was like, no, sir, mere se galti ho gayi. And at this point, I was like, there is another X-ray in between where this callus was not there. For the distal, for the prospect, if I think retrospectively, maybe I should have put a thicker wire, a fibular nail or a fibula plate.
Proximal, I'm talking about
proximal. No, I wouldn't have done anything.
You had a good hold
no.
With the screws.
Proximal, I was absolutely, I wouldn't have removed these screws for sure. If given a choice, I would go back and put these screws back in. Thank you.
So, Samarth, you had the 2 K wires in the ankle, and then you put the nail. So the whole reduction was decided by the K wire. Probably if you had taken out the K wire and corrected the wire after putting the fibula, you would have been able to do that.
Possibly.
K wires didn't allow you to correct anything at all.
Possibly, sir. Sir, actually, the reduction that I accepted was the one that I got. I maintained that reduction with the K wires, and that is what I accepted. But once I started nailing, वो ऐसा होता है ना कई बार यार बहुत खराब है और मैं करने जा रहा हूँ और करते करते आपको अच्छा होने लगता है, फिर आप और कोशिश करते हो और अच्छा करूँ. तो उस कोशिश में मुझे बाद में लगा कि यार ये अच्छा हो रहा है, तो why should I not improve upon it? Yes, at that point, like sir is saying, John sir is saying, I should have put the nail in after that. But it was an afterthought. What I had accepted was, I was happy at that point. Yeah, this is a very bad fracture. Most people will not even nail one of that single distal tibia fracture also people would not nail. That proximal tibia fracture people would also, many people would not nail. I am trying to do both with one device. I was very happy starting off. But intra वो greed बढ़ जाती है. So वो greed, the moment it increased, I tried to correct it with a clamp, and I did not want to lose anything. So I put them those. But you are absolutely fine. I should have removed those K wires. I should have taken the nail out, put it back in a better correction, and then I would have got a perfect reduction. Although the patient is completely asymptomatic. So the station of the nail, I think that is a perfect question from Dr. Amit. So the nail, the station of the nail is very, very fixed. It is more lateral. It cannot be in the center of the tibia. It is more lateral. If you try to put it in the center of the tibia, the whole construct will go into varus.
So especially for the proximal tibia, your entry has to be a little lateral to the spine. So that's well recognized. For the distal, it probably doesn't matter as much. Yeah, it should be centered in
the ankle, not the tibia.
Yeah, but that is, yeah, that's absolutely right.
समर्थ लो प्रोफाइल प्लेट डाला होता तो अच्छा था. लो प्रोफाइल प्लेट इज द डिस्टल पार्ट.
बहुत अच्छा.
वो बेचारे ने बोला तो सही, हमारा गलती हो गया.
बहुत अच्छा होता, बट पॉसिबिलिटी थी कि जो प्रदीप सर ने दिखाया वो भी हो सकता था, सर.
Yeah, you could end up with problems with the skin and that's.
So the skin, I showed you the skin was pretty bad, and जो प्रदीप सर ने दिखाया वो भी हो सकता था और मेरे वाला भी खराब हो सकता था. It could have been gone either way. I am lucky it went off well. That is why I presented. Thank you.
Thank you all the speakers and for the good discussion. You should go for the further session.
Speakers of this session, please come for the group photograph. रमित आजा. चलो अभी देख लूंगा मैं. हाँ. सेंटर में आ जाओ.
थोड़े के लिए करने का नहीं करने का, स्किन खराब है.
For the next session, I will have request Dr. Manoj Chaudhary, the past president of Bihar Orthopaedic Association, Dr. Kamrul Hoda sir, Dr. Raj Kumar, Dr. Sushil Kumar Singh to kindly come to the dais to chair this session. We have got Dr. D.P. Bhushan sir has left most probably, and Dr. Mutha is not here. We will start with Dr. Karun Jain. Dr. Karun Jain, please. Thank you.
Good morning everyone. So Samarth has already shown a very nice complicated case of suprapatellar nailing. So we'll go back again to the basics of suprapatellar nailing, and this is this is actually the motto of this, basics of suprapatellar nailing. So going back to the history, why SP nail came into the picture when infrapatellar nailing was doing so well. That was actually came into the picture for the proximal tibia fracture, where the deforming force was very prominent, and when you used to put the leg down, the apex angle deformity used to come, and it is very difficult to get the reduction. So because of this thought, suprapatellar nailing actually came into the picture. So whenever we used to do proximal tibia fracture, inadequate maintenance of the reduction, biggest problem, suboptimal reaming and poor placement of the nail. And to search answers of these questions, Tornata and Collins came with the nailing in the semi-extended position, and it was, the credit goes to Dean Colley, who actually invented suprapatellar approach. And this is one technique which has been adopted by all classes of trauma surgeons, and I am pretty sure that most of the trauma surgeons who are doing tibia nailing have shifted from infrapatellar nailing to suprapatellar nailing nowadays. And indication, see, when I made this slide maybe a year back, so I had to point down the indication, ye hai, ye hai, ye hai, ye hai. But now I think everything, whenever you have a trauma, whenever you have fracture of tibia, let it be proximal, midshaft, distal, all indications are there, which are there for infrapatellar, suprapatellar, you can replace easily. It's been almost 3 years, I have not done any infrapatellar nailing, I am doing only suprapatellar nailing. Thanks, because of Samarth has inspired me doing that. And relative contraindication, these are actually relative. Patellofemoral arthritis, now you can manage, a lot of articles have published because you can release the medial retinaculum. Patelectomy, again relative contraindication, many articles have been published. Intra-articular plateau fractures, well, because of the change of the multi-directional locking of the suprapatellar nail, now this is also not a contraindication at all. Lot of guys actually prefer using this suprapatellar nail for this kind of fractures also, because of the multi-directional locking of the suprapatellar nailing. So what are the pros? Actually, it's a very simple technique, semi-extended. Even if you don't have an expert assistant with you, you can get away with a good reduction, because the starting point is almost automated. Both coronal and sagittal trajectory can be seen very easily. Siam placement is very easy, reduction is easy, and fluoroscopy time is really less as compared to infrapatellar nailing. I am talking about the difficult cases, proximal tibia or distal tibia, when we compare fluoroscopy time. And learning why I have used, I think now lot of surgeons, if you do 20-25 cases, you can easily get away with the difficult cases also. And yes, it requires a specialized jig and equipment, that is for sure. You should not do it without a proper jig and instrument. So surgical technique wise, this is a classical proximal tibia fracture. Knee has capped into the 15 to 20 degree semi-extended position, and you mark patella tendon, then you go around 2 centimeter above, take midline quadriceps split 2 centimeter incision, you place your specialized jig. Well, the jig is very important because you should protect the intra-articular structure, whatever comes in the picture, especially cartilage of patella cartilage, because if you end up damaging the patella cartilage, you will have chondromalacia and patient will have lot of pain initial part of their ears. So center position we usually prefer. Theoretically आप कुछ भी बोलिए, कैसे भी बोलिए, but technically center position यदि achieve कर रहे हो तो that is good enough. And this is the jig. Most of the companies use it nowadays. Indian companies, international companies, they have this kind of jig. So once you pass the guide wire, if you are not satisfied, you can change the whole of the jig and you can get the center position both in AP and lateral position. So this is after that standard procedure. Do not remove your jig while doing the reaming. I have heard and I have read good few articles, they say ki jig ki zarurat nahi hai. No, this is not the right idea. Do not get convinced with this, because placing a jig is very simple and very protective mechanism. So this is the post-op image of this case, done nicely. Compare and damage the cartilage. Yes, you can damage if you don't use the proper steps, but long term, no pain difference after 1 year of the follow-up. When you talk about debris in the knee joint and you discuss about the infection which can happen because the debris, well, if you do a thorough irrigation, there is no risk of increased septic arthritis of the knee joint. So as I told earlier, less fluoroscopy time, less knee pain, better functional outcome, more accurate fixation. So recent changes, first is multi-directional locking, which I told in earlier slide. So now the proximal tibia tibial plateau fractures also comes under the umbrella of suprapatellar nailing. Then distal hole design. So when you have osteoporotic bone, distal there, initially we used to think कि चलो इसमें एक nail plate भी कर देते हैं. I think yesterday there was one presentation about that. But yes, now Samarth, now because we have nailing where you can lock the screws in the nail and you get three or four, I think 3 are there. So with that you can actually get away even if you get only 2 screws in AP and lateral direction, because these screws will not back out, which used to happen in infrapatellar nailing, because screws get locked in the nail. Then change in the Herzog band, it has given a very good classical fixation of the nail and smart proximal locking arm. Most of the jigs have the color coding is there, so you can just move the jig and you can get all the direction of the proximal tibial locking and allow surgeons to do it freely. So coming whenever you have a tight knee, you can easily release the medial reticulum and fix the, get the easy entry, fix the protective sleeve. Fixing is the very important thing. Once you get the right entry in AP and lateral, ask your assistant to hold the protective sleeve in the right direction so that you do not damage the cartilage. Maintaining the semi-extended position is very important. We use the bolsters, but if you don't have, you can use the 3-liter saline bottle also, keeping under the knee, that you get around 20 degree of flexion if you keep the saline bottle. So maintaining throughout from the starting to end in semi-extended position is the key. And before draping it, once you keep the leg in right position, please take proper Siam view from the contralateral side, AP and lateral, because if you struggle after you have washed, then it will be a little difficult task. So always take pre-operatively before washing, stand there, ask your assistant to take reduction whether it is fine or you can achieve or not. Again, I am emphasizing about this. If you want to just, one message to take away is keep protective sleeve. Do not, try to finish it कि मुझे 5 मिनट में, 10 मिनट में, 20 मिनट में खत्म करना है. एक protective sleeve will give you, lot of complication can be avoided with the use of protective sleeve. Do not take out protective sleeve, especially when you are reaming it. And poor entry site is the most common mistake which you can have. AP and lateral view, center position is the best answer. And this is the same advantage which we discuss in infrapatellar nailing also. If you want to have a big wide metaphyseal zone, then you can use polar screws, blocking screws or clamp. Yeah, so now I'll restart. So now the last part is rotation. We should always try to see the rotation, even though semi-extended position, there is very difficult chances to go wrong, but your assistant which is standing towards the foot end should always see about the rotation. And whenever, before you do the distal locking of the screws, you should always make sure that rotation is right, which can be easily missed with this kind of procedures. So this is one case of segmental fracture of tibia, and it was done standard suprapatellar nailing technique, and this is 6-month follow-up of this case. Another segmental fracture of the tibia. See, imagine this case when if you're doing with an infrapatellar technique, you'll require a lot of reduction, maintenance, and now it's become those difficult scenarios have turned to be a cakewalk with the invention of the suprapatellar nailing. It has been adopted by all of the surgeons, let it be a single specialty hospital or a big corporate hospitals, all are doing suprapatellar nailing. And this is a case of distal tibia fracture, osteoporotic wound. She was 80-year-old lady with the fibula fracture, so fibula plating was done, distal locking. So there was a discussion about whether we should plate this case or nail this case, but when we did nailing, we could get 2 distal locking screws. So with the help of this, this is after 2 months, and sorry I could not mark this, but this right side, the patient is after 3 months and patient is walking happily with this nailing, even though it looks like initially, whenever if you do not have suprapatellar nailing, you think of doing plating in this kind of cases. So semi-extended position, always use protective sleeve, polar screws for wide metaphysis, thorough joint wash, and counsel the patient about anterior knee pain, which can happen for first few days or a week. So these 5 points summarize my presentation. Suprapatellar nailing is very easily adoptive and effective technique. And with this I conclude my talk, and I request everybody to please join. There are 2 upcoming conferences coming up. One is Delhi Orthobiologics course, where we talk about everything in detail about regenerative medicine and regenerative orthopedics. And second is Periprosthetic Joint Infection Conference, annual conference, which will be held in Goa, 11th and 12th of July. So I would like to welcome you all, and thank you. Amulya sir.
आ गया सर, आ गया।
Thank you, sir. Thank you, Amul, sir. Now I'm presenting a case of failed fixation of intercondylar humerus. This 30-year-old male injured his right elbow, intercondylar fracture, and it was fixed somewhere else. Now I asked the house, is the construct is perfect? This is the 1 month after the X-ray, and it failed. It came to us with broken implant. What to do, sir? Sorry. No infection, perfectly all right. It was wandering here and there. Somebody asked him to do the physiotherapy, and the physiotherapy has done this devastating effect. Then he came to us after consulting 8 months after the injury. Sorry, this is the post-op movement. Sorry, I have to put this X-ray. What I did was this. Once I thought, we opened the fracture, intercondylar fragment was united, the lower end humerus was ununited. So I thought, I kept all the armamentarium in our basket. So I first put this posterior extra-articular plate. After fixing the posterior articular plate, I found that construct is not rigid. So I applied the medial plate. And after applying the medial plate, they are still not happy with the construct. But I cannot put the posterior plate because the posterior lateral plate cannot be put because of extra-articular posterior plate. So I bent this DCP and molded DCP and applied the DCP with bone graft. This is the lateral view. And this is the ऊपर नीचे हो गया सर स्लाइड उसमें yes sir posterior this is the posterior plate posterior extra-articular posterior lateral 4 sorry yeah sir I think it is 3 screws एक मिनट सर One, two, three, four, 5.
लेकिन छोटे रहते. These are all 4.5 otherwise, na?
Medial.
So
what part is
more
that?
Screws in the distal fragment.
Actually, first I applied the extra-articular plate, sir. Oh, because the intercondylar fragment was united, only the lower 1/3 was ununited. The Y segment was ununited, and the movement was occurring at the Y segment. This hang. So I applied the posterior plate. I thought it will be construct will be rigid enough, but on table construct on. Then I applied medial plate, and after applying medial plate, still not satisfied. But posterior lateral plate I cannot apply it because of this extra. Then I bent this DCP and applied this.
Did you do some compression there at the fracture site? Did you get some shortening at the fracture site?
Shortening was there, bone grafting, and slight compression was there since it is already 8 months old, sir. And this is the X-ray after physiotherapy. And this is the movement on the 15th of this March.
Can we go to previous X-ray, please?
Okay, sir. This one?
No. AP view.
Yes, sir.
So both the lateral and medial plates are at the same position.
Exactly,
Do
sir.
not
It should be
think
little
that
bit.
it is going
It
to
should be a
break-
different level, sir. If I have planned to apply the medial and lateral plate, then it should be a different level. But I didn't plan for that.
You already have a posterior plate there.
I already
the
have
stress-
posterior plate that is much higher,
But
sir.
the stress is there.
No, but you got a plate.
Okay.
Proximal plate, hai na?
This is third plate just to augment this construct only, sir. Yeah, stress rises.
Yes.
Dr. Peach, point is that when you have two plate, then it has to be a different level. Once
Huh.
already third plate is a different level, then there is no point.
No point, sir. Listen. Not at all, sir. Not at all, sir. Actually, I thought, though I have all the thing and environmentarium, I thought only the posterior plate will suffer. The construct was that then posterior and lateral, medial. Then, if while on a table, a little bit, though I thought it is a second surgery, don't take chance. Then I applied the lateral plate also, bending this DCP.
I think this is perfectly justifiable because he's seen and he's not happy, so he's added a plate. So that's
Yeah,
fair
sir.
enough. Yeah.
As sir said, over.
Don't take that too literally, but
मारने के बाद over कैसे मार सकते हैं?
And since this was the second surgery, the patient cannot afford the third surgery, sir.
The patient cannot afford. You also cannot afford.
Definitely, sir. Definitely, sir. Definitely, sir. Thank you, sir.
Thank you, sir. Thank you. Now,
Dr. John.
John sir will be speaking on plaque augmentation of nail. Better be safe than sorry.
So I'm talking about a topic which I rather not be talking about, but this is something which unfortunately has been, in fact, when I was given the topic, I said, no, I won't do this. And then I find that it's there on my list of topics that I have to do. So, it's a practice which we very rarely do. But I think I'm going to go into some of the literature involved in this and the reasons for doing it, which include the techniques and the fact that we are augmenting a nail fixation with a plate fixation. If you look at the plates, they have evolved over time, and so have the nails evolved over time, and you now have nails which have what you call an added lateral attachment washer, which can be combined, called a plate as well, so that becomes a combined technique. But what we are really talking about is this nail plate combination with Frank Liporacci has really popularized in the US, and it's gradually becoming more and more popular all through the world. So the rationale of this is that the nail is a diaphyseal fracture. The nails are better for diaphyseal fractures, while plates are probably good for metaphyseal fractures. In complex fractures, single implants are often insufficient, and therefore if you combine the two, you will get a better result. And this paper, now there have been multiple papers on these combinations which look at the use of these this combination of nail and plate, both for fresh fractures, complex fractures in delayed union and non-union, and revision cases. So this is something, and especially for periprosthetic fractures. So you have this nail with a slightly different angulation, 10-degree angulation, so that you can get the entry point slightly posterior, which the box of the total knee replacement makes you go a little posterior, and you can still get the correct position of the fracture rather than angulate the fracture. So the basic indications would be in an elderly patient who's osteoporotic, may have a complex fracture with a lot of comminution, and you want to get the patient up early. So these elderly patients are not able to what we call partially weight bear. So they end up doing full weight bearing, and you want a combination of implants which is good enough for them to be able to fully weight bear. And of course, in periprosthetic fractures, there are reasons for using an additional plate, and also in non-unions. So there's been a review article on this by Giannudis and Kontakis from Leeds, and they've looked at the nail plate combination in fractures of the distal femur in elderly, a new paradigm for optimum fixation and early mobilization. And they've quoted various studies,
What is important is if you look at distal femur fractures in the elderly, if you look at the 1-year mortality, it's close to 21%. And you have multiple fixation options. Although you have both the distal femur locking plates and the newer generation interlocking nails, the late nail plate combination combines the biomechanical properties of both. Okay, so you really but need further, so this was the conclusion of the study, that you still needed randomized trial and cost analysis to justify the use of this. So if you look at the biomechanics, the nail plate construct, if you looked at 24 osteoporotic femur models which were studied, they divided into 3 groups. One was the nail plate combination, and the other was just a nail and just a plate. And they found that in the nail plate combination, you increase the axial stiffness by 19% and the torsional stiffness by 59.4%. So if you look at plates on its own, they provide more axial stiffness, while nails improve the rotational stability. So this is from the AO, looking at the techniques for something like this. This was in a periprosthetic fracture, where a complex elderly patient with a complex distal femur fracture comminuted. So you can put in the nail here. You don't have an intra-articular problem, so you can put in a nail through a minimal incision through the patellar tendon, which is how you do the suprapatellar nail often. So you pass the nail, you put the nail in, and then you can, you've got your nail fixed, and then you can put your plate in on the lateral side. If you want to add a lateral attachment washer, you have to do that from the medial side in this situation. Okay, so that is another option that you have with the nail. So this is the plate, and you put in screws, you put in locking screws which are short if necessary, and you can put in cortical screws where you can get it across to the opposite side. So this is the sort of new standard for treatment of some of these complex situations. Unfortunately, this is something which we don't do very often, but recently we tried it. This was an elderly patient with multiple comorbidities. She had, so these were the CT scans. So if you see the 2D scans, you can see there's an intra-articular portion which is displaced. The 3D did not show any obvious intra-articular fracture, but if you saw the 2D scans carefully, you can see that there's a displaced intra-articular fracture. So she was put up for surgery. The day before, she was actually put up for the surgery when I was there, and the anesthetist called her off. She was admitted initially in the ICU, and the anesthetist said, no, she's not fit for surgery for, I think her diabetes was not under control, and they said it's not fit for surgery. So I convinced them that it's okay, the surgery part is not so difficult. You can get it done, because I was not going to be there for about a week. So a week later when I came back, she was still there and she still hadn't had a surgery. So we did this nail plate combination. We also put a screw into the hip joint to make sure that there's no hip fracture, and we thought we had done a great job. Unfortunately, this lady had multiple problems. She ended up in the ICU for 2 days due to hypoxia. She went home in 7 days when it was okay, but she came back with a discharging wound 2 days later. And she had obviously got frank infection. We ended up debriding it. We still have some discharge from the wound. We put it on VAC treatment, but we still haven't got over this infection completely. And it's a matter of time whether the infection gets controlled or we end up having to take out the implant. So this is going to be a disaster which we hadn't kind of bargained for. So take-home nail plate combination is increasingly being used. So as Dr. Tanna keeps saying, overkill is not a bad thing in surgery, but sometimes you can get infection and then it's a disaster. I think you have to be careful how you execute it. This particular lady had multiple comorbidities, but that's the reason for doing this, because you want to get them up early, but then your infection risk goes higher. And cost analysis is also an issue that you need to look at. Thank you.
Don't blame the doubled implant. It is innumerable comorbidities you mentioned about.
I know, she did. But the fact is it still ended up as a problem which I'm having to deal with still, unfortunately. Yeah. Yeah. Thank you very much.
You probably went out to avoid the surgery.
I would have loved to avoid having done the surgery, yes.
Any question? हाँ हो गया, लेकिन क्वेश्चन तो आ ही सकता है ना. We have enough time. Okay.
So you are not,
we are closing this session.
John, you are not convinced that for such a fracture the double implant is the treatment.
Thank you, sir. Thank you.
May I request all the speakers to kindly come on the stage for a group photograph of this session.
Dr. Karun, please. Dr. Piyush Mishra, Dr. John, sir.
आप लोग ज़्यादा इम्पोर्टेंट है.
We will be now starting with the session number 20. For that, may I request the chairpersons to kindly come on the stage. Dr. R. Kanodia sir, Dr. Sanjay Pandey sir, Dr. Captain Sanjeeva Kumar, Dr. Kumar Shashikant, Dr. Janki Sharan Badani, and Dr. Ashok Kumar Singh sir. Kindly come on the stage to chair the session.
All the faculties, moderators, chairpersons who have not been felicitated, they will be felicitated at the end of today's program in the valedictory function. Mr. Ashok Chaudhary, who couldn't come day for yesterday, he has just given me a call that he is coming today at 1 p.m. So हम लोग सबका एक साथ ही felicitation कराएंगे after the Dr. B.N. Singh oration. So I will request all the people who have already chaired the session, who have moderated, the faculties who have not been felicitated, वो रुके रहेंगे, एक साथ उनका felicitation होगा. Thank you.
So may I welcome Nasir Ali sir for his talk on management of non-union scaphoid.
Thanks Dr. Amul Kumasi and Gofcon team for inviting me. My talk is management of non-union scaphoid. Scaphoid is the largest carpal bone having maximum complications, having precarious blood supply, why non-union is very common in scaphoid? Because it is often missed. 40% of scaphoid are missed, and the place where I work in remote place at district level, almost 90% of scaphoid fractures are missed. Second, it is devoid of periosteum. It is intra-articular fracture, and increased fracture mobility, fracture instability, and impaired vascularity are the causes for the non-union. Management of non-union of scaphoid could be traditional bone grafting, vascularized bone grafting, and for the late cases where arthritis has settled in, we have to do salvage procedures. Coming to the cases, this is case 1, 2 years old non-union scaphoid, waist with cystic changes. I planned for the non-vascularized bone graft, did FCR approach, non-union site debrided till the bleeding healthy ends achieved. Tricortical graft taken from the iliac crest. This is intra picture, confirmation of the non-union site, the gap created after fracturing of the ends, is the graft put inside, 2 provisional K-wires, the intra picture of fixation, the post of X-ray, this is the follow of X-rays, and this is the functional outcome. This case second, 5 months old non-union waist scaphoid with cystic changes. We planned for dorsal approach. I was thinking I may need vascularized bone grafting. So I did the dorsal approach, tricortical graft taken from the iliac crest, humpback deformity corrected. This is the immediate post of X-ray. There was some complication. There was extrusion of the graft, but finally, in the end, fracture united, and this is the functional outcome. This is 6-month-old non-union scaphoid, proximal pole with evolving avian changes. So I planned for dorsal approach and vascularized pedicle bone graft 2-3 ICS RA. Dorsal approach was planned, and this is you can see the site of 2-3 ICS RA pedicle. I am taking the 2-3 pedicle graft with the help of loop. Non-union site debrided. This you can see here the bleeding, pulsatile bleeding of the pedicle graft. Fracture site debrided, provisionally fixed with the K wires, and the final fixation with the Herbert screw. Intra-op images, post-op X-ray, and these are the follow-up X-rays. Have the good functional outcome. This is a non-union scaphoid waist with cavitation. I again planned for dorsal approach, and the capsular based 4th AC pedicle graft was planned, and because there was no much humpback deformity, so I planned to take a cancerous graft from the distal radius. MRI images. This is a site from where I took capsularized base 4th ECA. The intra-op picture taking 4th ECA pedicle graft. You can see the bleeding of the pedicle, grafted, fracture fixed, intra-op picture. The site from where I took cancerous bone graft, wound closure, the immediate post of X-ray, follow-up X-rays, serial follow-up X-rays. This is 20 months post-op and the excellent functional outcome. This is non-union scaphoid waist with cystic changes with avian. I again planned for the dorsal approach and 1-2 ICS RA vascularized pedicle graft and the cortical cancerous graft from the iliac crest to correct the humpback deformity. MRI images. The site of 1-2 ICSA pedicle graft. This is a intra-op picture of nice pedicle with the help of loop. Non-union site curated, bleeding bone ends achieved. The joystick used to correct the deformity. You see the putting the wedge graft to correct the humpback deformity. This is bleeding of the pedicle. This is the final fixation intra-op CM images. Humpback deformity corrected, length restored, nice fixation, central placement of the screw. These are follow-up X-rays, immediate post of X-ray. These are few follow-up X-rays. Good union, excellent functional outcome. This is the case non-union with scaphoid with scaphoballetic changes. Articular cartilage of scaphoid was not healthy, so I planned to do salvage procedure, excision of the scaphoid, and before that I did neurectomy, denervation of PIN neurectomy and AIN neurectomy. Excision of scaphoid, correction of deformity, dorsiflexion deformity, denuding the cartilage to have a solid fusion. This is the final fixation of limited disc fusion, scaphoid removed and 4 cover fusion is done. These are the follow-up X-rays. This is the last case of salvage procedure of doing a proximal row carpectomy. This was a case of Kienbock's disease, but this is also used for salvaging in a non-union scaphoid with avian changes. The denervation of PIN, AIN was done and proximal row carpectomy was performed. These are the functional outcome, and thanks. For the all non-union cases, I am always prepared for the vascularized graft because I can do it. And the cases where there is no avian, one can go for the non-vascularized because I can do, though I am working at periphery district level, but I am acquainted with the doing vascularized bone graft under loop magnification. So all non-union cases, I use dorsal approach, and I do vascularized bone graft. There is only point against is it is recommended that for the humpback deformity it is better to go for the volar approach, but I have technique. We can use a Hintermann distractor like lamina spreader. You can over distract the non-union side and can reverse the corticocondylar graft, and in that way I am able to correct the humpback deformity.
Very good.
Yes.
And what about the, I have seen 2 Robotics
that was for the 4 corner fusion, sir. That was as a salvage procedure for the
nice.
complete avian changes. That was used for the as a salvage procedure.
Many thanks. Very good.
Dr. Ali, you have a number of cases. So, Dr. Ali.
Yes, sir.
Here, you have number of cases actually, and it seems like you have done everything with scaphoid.
Yes, sir.
So, you have that series, then it's a level of publication. It should go in Peer 1 Journal.
Yes, sir.
So, it should be actually. It's
I am
very,
doing
very
lot of cases, but I am working a center that is at district level. I have to.
That's much better even.
Yes,
so
yes.
You can produce a series of cases and get it published.
All the work management, even 70% anesthesia given by myself. In 70% cases, I give anesthesia myself. I have to manage my post-op cases, the whole hospital management, working at a district level. But it's good for the myself and for the other colleagues.
Get one of the trainees from PMCH to write it down.
Thank you, sir. Thank you very much, sir.
Hello. Next speaker is Dr. Prabhat Prakash, mini open PCL for bony avulsion.
So thank you, Maurya boss, for inviting me. Thank you, Maurya boss, for inviting me for the Gofcon 2026. So my topic is mini open fixation for PCL bony avulsion. So tibial avulsion of PCL are seen in young patients and often due to high energy trauma, and the surgical treatment is recommended for displaced avulsion fractures, that is the type 2 and type 3. The basis of this mini open approach is that the target area, that is the PCL insertion on tibia, is quite small, and so elaborate exposure is not required. So as per the literature review, literatures in nutshell says that by doing the orthoscopic PCL avulsion fixation, there is a high chance of orthofibrosis, and the open posterior approach versus orthoscopic fixation shows almost equal clinical and radiological results. And the Gavaskar, in their publication of the missed technique of the PCL avulsions, is conclude that it is safe, fast, and short learning curve for the
special fixation technique. So why need for this mini open fixation? It is easy to adapt. There is no special training required for the mini open fix learning curve. It is economical, simple instrumentation required, and we feel more confidence of reduction and stability during the mini open fixation. It is also used for the delayed presentation. There is no chance of compartment syndrome, and we allow early ROM. So the approach is we have to split the medial gastrocnemius as described by Zajri in 2009, and in India it is popularized by Jignesh Pandey as Vijayanand Lokhande. So there are some surgical landmarks we took before starting our mini open fixation procedure. The first horizontal line we have to draw over the popliteal flexion crease, and the second oblique line over the medial hamstring tendon. The third horizontal line over the tip of fibular head, and we have to took the PCL point over the third horizontal line by seeing the image pictures, and the connect the first point over the first horizontal line to the second point, and that is the oblique incision line. So this is the video presentation. We took the incision by making the first point over the PCL point obliquely, incising the soft tissue and removing the fat to see subcutaneous fat. Thereafter developing the plain subcutaneous way. Under the tunicate, we have to incise the gastrocnemius fossa with the help of the scissor. So develop the subcutaneous plane by the scissor. We try to create the space subcutaneous with help of the finger and try to develop the plane between the musculotendinous and muscular junction of the medial gastrocnemius. There is a vascular plane, and we try to incise it with the help of either the scissor or either the artery forceps. So this is the White's structures, and the muscle and the tendinous junction we have to incise it, because this is the avascular area where it go up to the capsule. So developing the plane between the tendinous part and the muscular plane, and palpating the capsule with the help of the fingertip, putting the humerus to create the space over the capsule, and thereafter try to feel the fracture piece. There are some small veins over the capsule, and we have to cauterize it. And after filling the piece of the fracture bone, we have to take direct incision over the piece of the fracture, so that we cannot damage the meniscus anyway. That is lie inside the joint. So now incising the capsule, we have to expose the piece of the PCL, and this is all about the exposure of the PCL through the mini incision. So there are some cases of representation. We have to fix this case with the 2 4 mm cancellous screw and 2 washers, and patient having the good movements. This is the second representation of the mini open fixation. We have to fix it with the 1 screw, and there is a good function of the patients. My post-op protocol is divided in 3 phases. That is, first phase up to the 6 weeks, second phase 6 to 12 weeks, and the third phase after the 12 weeks. In first phase, we start the initial static quadriceps and the hamstring exercises. We allow patient to wear extension brace or dynamic anterior drawer brace for the 3 weeks and non-weight wearing walking till 3 weeks. We allow partial weight wearing after 3 to 6 weeks, and in second phase we allow full weight wearing after the 6 weeks, and the RMM and the strengthening exercises allow. Third phase after the 12 weeks, we allow patient to return to pre-injury activity. So my follow-up was at the 3 weeks, 6 weeks, 12 weeks, 6 months and the 12 months. In conclusion, I want to say that the mini open approach for PCL avulsion is simple, easy to learn, less morbid, economical, less instrument dependent, and result is as good as orthoscopic surgery. Hence, it is way to go. Thank you all for patience hearing.
Thank you, Dr. Prakash. Next speaker is Dr. Ravi Chauhan, choosing the right frame.
Yes, sir. For comminuted cases, we usually use the spike washer along with the 4 mm screw.
Yes, Dr. Ravi Chauhan.
Good morning, everyone. So I will be speaking a bit on choosing the right frame. So we, as a surgeons, as well as the patient, is also comfortable with most of the times with the rail fixators. But our decision should not be based on our preference only. It should be guided by biology and biomechanics. So I will be discussing some of the points of that. I have nothing to disclose in my presentation. So these are the usual conditions like open fractures, bad skin conditions, post-infective scenarios, whether in the acute and the chronic situations, and the deformities, as well as the limb length discrepancies, segmental bone defects, where the internal fixations having a limited use and external fixation serves the best purpose in most of the cases. So, but the decision we need to divide between the Ilizarov and the LRS, what we should go for. So I will try to declutter that decision making. So we all know that the most desirable force whenever there are the bone fragments is the axial stress that we want. And our frame should be optimally stabilized, whether we are using the LRS or the Ilizarov. So when it comes to Ilizarov, because of its I-beam effect and its multiplanar fixations in circumferential spanning as well as the longitudinally spanning, this Ilizarov provides more optimal stability as compared to the LRS, which is usually a monoplanar fixator and eccentrically with disadvantage of eccentric loading and mainly based on the cantilever mechanism. So as compared to the LRS, biomechanically Ilizarov is more sound, more optimally stabilized fixator as compared to LRS. So, and regarding the advantage and disadvantage also, though Ilizarov has a disadvantage that it is more cumbersome and bit of skill learning curve is also steep as compared to LRS, but advantages is that it has a multiplanar fixation, good optimal stability as compared to LRS, and superficial infections also in Ilizarov are not that much. They are mainly basically pin tract infections are superficial, but in LRS, if the pin infections, they are more deep and more severe as compared to LRS. Though it is less cumbersome to the patient, though it is less technical, learning curve in LRS or the rail fixators is less as compared to Ilizarov. So by demonstrating some of the cases, I will be just highlighting some of the points. So it was a case of a 40-year-old male who had an RTA and compound fractures. So you can see that there lies the bone fragments. So surgeon went in removed the bone fragments, and initially he had applied the rail fix, just a universal fixator, and later on he removed these fragments and tried to get the bone transport in order to fill that segmental bone defects from the above. But over the period of time, you can see here that the regenerate quality was bad. It's an X-ray of 5 months after the corticotomy. So regenerate is quite bad, and also the distally also you can see that there is no such union, and the segmental bone defect was not filled, and the malalignment is significant, AP as well as sagittal views both. So, and this was the clinical picture. You can see the way he had applied the LRS. He had tried to apply the LRS and trying to do the thing which was not actually possible with the LRS. So Ilizarov could have been the better choice in this case. So and on the medial aspect, you see there is the skin grafting directly over the bone. So soft tissue conditions was also not that much good. So when the what went wrong here? Basically, definitely to the best of my mind is the implant selection. Ilizarov could have been the better choice as compared to LRS. So I went in, I removed the LRS fixator, basically applied the Ilizarov, aligned all the fragments into it and maintained the length. Later on, I did the acute accelerated docking over the proximal because the regenerate was not good, proximal site as well as the distal site. So once I docked the proximal and the distal site, in the later half, I just did the corticotomy in the mid-diaphyseal region and tried to gain the length of the limb as compared to the other limb. So this is after I had obtained the 6 centimeter of lengthening in the tibia, and now here you can see the alignment is good and the regenerate quality is also good. So this was the final X-ray, and in a month or so I will remove this fixator as well. So here you can see that I had obtained the proximal union as well as the distal union, and the length is well achieved by 6 centimeter lengthening, and regenerate quality and the alignment is also good. And these were the functional images for a nice flexion, nice extension. There is nothing like functional deficit as well. So these are the cases where the Ilizarov serves the better purpose as compared to LRS. Similarly, this was the case where the skin condition is bad, and here we can say that we can use the LRS, but LRS has more a disadvantage when it comes to the fixation as well as the skin conditions. So in this I require a lengthening of around 6 centimeters. So definitely I went in and put the Ilizarov for the lengthening and did the corticotomy at the mid-diaphyseal region. This was the another case where the patient operated proximal tibia fracture which was extending up to the mid shaft and had a bicondylar plating, but in the post-op period, immediate post-op period, it got infected. So I just removed the plate, both the plates, did the debridement, initially put on the vac for the initial infection management. Later on, just applied the Ilizarov for the stability and used the gastrocnemius flap for the soft tissue coverage. So in this you can see the proximal fragment alignment is well maintained, and over the period of time the infection got subsided, clinically the skin condition got better, and patient is now walking from the almost the next week the fixator was applied, and this is the latest X-ray of that patient. Now in a month or so I will remove this fixator and the patient is doing well. So these are the cases where the Ilizarov definitely serves well. This was another post-infective scenario in the proximal tibia. Here you can see the skin condition, how bad it is, and so and malalignment with non-union is there. So here I had applied the Ilizarov, did the take the fibular graft, placed it proximally in order to get the bone stock for the union, and these were the successive follow-up X-rays, and this was after the frame removal with united proximal segment and well aligned in its alignment. And sometimes also in the mid-diaphyseal cases, as it was the post-infective scenario non-union, where the LRS can serve the purpose, but in the non-union cases, I find Ilizarov serves biologically as well as the biomechanically the best purpose as compared to LRS because of its I-beam effect, and the all wire frames serves the best purpose. So this was the X-ray, this was the non-union site, and here after the frame removal, the well united, well aligned. These are some of the cases where the deformities are the very periarticular. So definitely the LRS can't serve the purpose. In this case, you can see the periarticular deformity was there. So here I use the 6-axis correction system in order to gain the deformity correction. So here the depth fix I had applied, and this was the basically digital planning of that deformity correction. and this was after the correction was achieved, and this was after the frame removal, and you can see the deformity is well corrected, union was well achieved, and the clinical picture as well. So these were the cases where the Ilizarov serves the best purpose, but it's not like that LRS is not of use, especially in the femur lengthenings and the femur cases where Ilizarov is more cumbersome. So whenever possible, especially I prefer in femur cases LRS, or the latest advancement over the LRS is the alpha fixator. It was the femur lengthening case where I had used the alpha fixator, and over the period of time I gained the lengthening. These are the another cases where the alpha fixator or the monolateral fixator serves the best purpose as the infected non-unions of the femur, as well as the acute fractures of the tibia as well. So LRS is not less, but we need to know that where to use these LRS as compared to the Ilizarov. So to conclude, rail fixator and Ilizarov, they are not the competitors, they are complementary to each other, but our selection should be tailored based approach. Our selection should be based on the biomechanics and the biology. It should not be based on the surgeon's preference. Thank you. And in last, I would like to invite you all to the Pediatric Orthopedic Trauma Symposium that we every year we organize. This is the third time we are organizing it on 30th and 31st of May. It's a 2-day completely dedicated program for pediatric fractures only. So I invite you all for this. Thank you. Thank you, Amulya sir, for the invitation. Thank you.
Thank you, Dr. Chauhan. Now I call upon Dr. Brigadier Chetan Sood for a speech on robotics in TKA.
Good afternoon, everybody. I'll be talking about this, my experience, a very short one with robotics. Before I start, I would like to, these are my credentials, and the case is not about, it's about against mechanical alignment. I still do the mechanical surgeries, but now since robotic has come in a big way, especially when being manufactured in India, so there is a case for other things, which is alternative alignments. My disclosure, I'm a paid consultant with Humeral Life Sciences, though this talk doesn't have anything to do with the Humeral products. So before we go to the alignment strategies that are available today, they were always available, but now they are more possible. So I'll just talk about a few slides about the role of robotics. So what you see on the green side is the computer assist surgery or navigation, and this was in vogue for the last 8 years until 2023, when this entire thing has now been, not even a single company is now manufacturing navigation, because the robotics have come in. So the entire navigation industry is closed, and it's now robotics. And what you see on the blue side is the various type of robots which are available, and that's why the possibility of alternate alignments are more possible. So robots are not only new in us, only the medical science is very late to adopt. Robots are there everywhere in every industry, every service industry, name it. And robots were not new even now. So the first robotic orthopedic robot was in 1992, and it was designed for the hip. And in Army, where I was not posted at this center, but in 2005 we had one robot called the RoboDoc, which did about 15 surgeries, but then after we had to abort because it had too many complications, it was too complicated. But now it has, over a period, it has all developed, and these are the contemporary various type of robots which are now available, and new things are possible, which I'll bring out in my talk. There are 6 countries which produce robots, and the latest edition is 2024, where Humeral Life Sciences has added something called Made in India Robo, and that has democratized the usage of robots, and these things are possible because the costs have come down drastically. So just the last slide about robots, then we go over the main topic, is that if you look at the shift from autonomous, the earlier RoboDoc was an autonomous one, but we went back to a semi-autonomous because the technology was not good enough. And now we have again continued with higher autonomous, and this is the first time that the new ones are again autonomous. So I come to the main topic. If I talk about mechanical alignment versus alignments, it's like I have a small pawn against the large data which is available, the last evidence is available, but still I'll try to make a course. So alignment strategies which are available right now were always available. These are the various alignment strategies. So if you look at the slide here, and The various alignments, these are all possible without robo or technology. But you get more precision if you have to, for execution. So these were all there. So I will not dispute that these were never possible. They were always possible. When it comes to, so my case is that, is there a case? Yes, there is a case in my opinion. And conventional total knee replacement, if you see, many of you must have used the bicondylar knee, but this one is about 50 years back when the initial knees came. This was just on one, that is the coronal plane alignment, right? So there was no talk about sagittal or any rotational, just the coronal plane. So two techniques, measured dissection, gap balancing, and the bases were very clear. The technology at that time, the metallurgy at that time, the understanding of that time was simple. Have equal mediolateral load distribution and increase the longevity of the implant so that the wear is less. That's the purpose of mechanical alignment, right? And the amount of literature that is available, very good results we've all had. I still do. In fact, I do most of it like that. Unless it is robotic, we do offer alternate alignments. But if it's, I don't think there is any case for doing mechanical alignment robotically. So there are certain limitations of conventional. Because of the mechanics and metallurgy, these limitations were there. But now with robotics, I don't think they are any more applicable. So there is a case. So we were only doing a correction in the coronal plane. And just about the new generation had some possibility of changing the slope of the tibia, but nothing on the femur side. So bone cuts are dictated by the alignment on this instrumentation. And so we had to peel off the entire medial side or lateral side depending on what valgus you have. It's not the ligaments dictating the bone cuts. So otherwise, bone cuts dictated the ligament release. And of course, any variation in the anatomy was always the same. Okay? And what it really meant is that it actually used to alter the soft tissue envelope. It right now does. And there's no provision of talking about joint level, obliquity, or anything to do with the level or obliquity. So this used to cause this, or even now causes a change in the muscle balance. So my question is that is mechanical alignment is a solution? Yes, it has been a solution for the last 40 years, maybe 50. But then it creates something which we all know is a kinematic conflict, and that the soft tissue itself just changes and the native anatomy is altered. I'll bring it out. So is the alternative alignment is a solution where we preserve the soft tissue, the native joint line, and of course something which we talk about now is the quadriceps alignment angle. So we all are familiar with this, that 20% of our knees, the literature worldwide, any amount of implants, cementation techniques, implant design, anything has not changed. This thing, that is 20% of the knees are very unhappy. So what is it? Is it the soft tissue? Is it the implant? We've gone all through all the conferences, patellofemoral joint, pain management, counseling, or is it the alignments? Now we are enabled to think about the alignment part. And this paper itself, 2012, this created this is a very large study which was done and which said that it is the scoring systems are also biased, and they're biased towards the mechanical alignment. So what I look at mechanical alignment is that whatever knee you get, you may get a varus knee, a straight knee, or a valgus knee. We were giving them the straight knee at the end, right? It is like fitting this top into whatever the phenotype of a, this is a very famous black top, Mary's black top. So they all are happy with this top, but how they feel, the fit is quite different. And something which is not addressed is the constitutional varus. The constitutional varus is something which is, as you can see, it's very prominent in men, 32% and 17% of the women, more in the Asian populations. And what I've listed down the sports and high performance individuals, something which is governed by the Hoover-Volkmann law, that if you have constitutional varus and if you are a sportsman or a high performance individual, the varus will increase. So last year in Sikot, I had gone for the meeting. This is the Real Madrid team, not here now. This is when they won the World Cup. So this is the Real Madrid team in their studio there. And if you look at they're all elite sportsmen, right? And none of them have a straight knee. Okay. And these people, if we put them back into the straight knee, I think they'll be the most unhappy, right? So that's my case. And what about joint line congruity in apex? Stance phase and swing phase. So stance phase, joint reaction forces. If they are built, your muscles are built with an oblique line and you put them straight, they will change, and that's why we have to manage. People will say everything is great on the X-ray, but I don't feel it the same knee. And similarly for the swing phase. And this has been brought out. So we are talking about it now because this has come to light now. And this is where this article by McDessie, which talk about the coronal plane alignment. I'll take about 2 minutes, sir. Coronal plane alignment. So this study was done in the European population, but Indian population has more of this type of knee. That is the varus knee. That's the Indian population. Is almost close to 40% and 39% in the Caucasian population. So these two things have now become very fit. So the great thing about this article is the arithmetic. We always were looking at the mechanical HKA, but it's the arithmetic HKA, which is the difference with the LDFA and the MPTA. And the arithmetic HKA does not change. So you can know what was the phenotype of the knee before the arthritis was developed. So that's again the same article by McDessie, which talks about, if you see, this is a healthy population and the arthritic population. So for the first, this article kind of describes that the phenotype of the knee does not change, but provided we take care of the LDFA and MPFA, and not much change when the person becomes arthritic. So you can actually restore now the knee back to the pre-arthritic condition, right? The same oblique line. That's what has come in light now. So we are talking about it because technology has enabled it, and a predictable execution plan is possible now with robotics. And what has changed? What has changed for me is our patients have changed now. They are high perform. They want to go cycling. They want to play golf. They want to, somebody wanted to do hang gliding also. They want to do motorcycling. So the patient profiles have changed. So most of our patients in our country, which were now, up till now, after knee replacement becoming household ambulators, are no more like that. They want to be active, right? So in a snapshot, I'll be finishing, sir. In a snapshot, I can just show you these are the various alignments which are possible, but the ones on the right are the ones which are only possible with technology. So I would like to just summarize that robotic knee replacement, many times the patient thinks it is for precision. It is not about precision or putting the implant or reducing the outliers, because we already are at very good outliers, very less than 2 degrees of outliers. It's not about precision. It's about something that humans cannot do, right? That's what the robots can do. And that's something which brings out the concept of functional alignment. So, my last slide, sir, which is a dynamic process. As you don't have to do soft tissue releases, you have to minimize the soft tissue cuts. You can plan the patellofemoral joint, and what you can easily manage is, without any releases or minimize the bone, you will have a functional where you get a 360 degree of soft tissue tension. And this is only achievable with robotics, right? So my final take is that many of the forums ask me that will the robots replace the surgeons? So I don't think so. We are somewhere here, where we are here, somewhere here, where we are highly autonomy. The full autonomy is not there in robots. But I think there is, on the surgeon side, the established trust, the realistic exploitation, the communication that you have, the norms and the regulations are available. On robotic side, there is a higher distrust, higher expectation, higher costs. So robotics are still far away from us. I don't think so. We are getting to that stage where robotics will be, surgeons will be replaced. But I do feel that they are this time here to stay. Like they came back in 2005, but they went away. But now they are here to stay. I expect about 30 to 40% of the practice, but most of the surgeons now I know, I train for Humeral also, for robotic surgery. Most of them convert 90% of the patients to robotic surgery. Okay, but I think the robotics stream is going on, and these large machines are going to be replaced by very handy robotic tools now, okay, which are handheld. And I think the practice will kind of taper off in 5 to 10 years. This demand is driven by patients in our country. Most of the patients are coming and asking for robotics, even though I tell them there is no point, you will only spend some money, but most of them are asking, and the younger generations are leading this generation. Most of the, like we have trained about 45 robotic surgeons in the last 1 year, and all of them were like less than 50 years of age. With this, I would close my talk, and I'll be happy to answer any questions.
Thank you, sir. If any question is there, then we can take on. Because the last
one question: if you're so convinced about robotics, why do you tell your patients there's no point doing robotics? So if you're convinced about it, you should tell them yes, it's a better thing.
Sir, I think, sir, please use the mic. As I said, sir, that most patients will come with the thing that if the robot does it, its life is going to be longer and it will be more precise. But I have to tell them that your joint is going to look a little oblique there, And as of now, I am also not yet convinced. So that a 3-degree varus is, if I put it in more of 3-degree varus, the implant survival. Though there are a lot of meta-analyses which have come, but to me, sir, I'm just putting a restricted thing. I'm not going fully kinematic or mechanical at all. Sir.
No, I just since you said you were so convinced about it,
yeah.
Yet you said that you tell patients that it's no point.
Many times they're already aligned, so they have a horizontal joint line.
May I call all the speakers on stage because the last speaker is not there. So for the question and answer session. Yeah. Yes, sir. So if anyone have some doubts, you can ask right now. And to start with, sir, so for the Ravi Chauhan, sir, according to what I have understood is that for deformity correction for tibia is better to use Ilizarov, and for the femur it is LRS. Is that, sir, true?
No, not for deformity correction, because LRS is a monolateral fixator. Yeah. If there is a multiplanar deformity in femur, even you can't use the LRS. So LRS is preferred for femur. I also prefer for femur because of the less cumbersome part. Because applying Ilizarov in femur is a bit cumbersome, more technically demanding for the initial learners. So that's why we prefer LRS. But LRS with provided its limitations. Because if we are dealing with a very small distal femur fragment, we can't use the LRS there. If we are dealing with a multiplanar deformity, we can't deal with the LRS. Even the uniplanar deformities is very difficult. It requires a very high kind of expertise to correct the deformity with LRS. That's why.
So what should be the ideal thing for femurs?
Ilizarov for deformity correction. But if there is a union, non-union, mid-diaphyseal non-unions, or even the distal with a good segment, bony stalk is good, LRS serves a better purpose because it is less cumbersome in femur, easy to apply in the femur. But in tibia, Ilizarov can also serve the better purpose. So LRS will also serve. In tibia, both ways you can go. But in femur, provided the bone quality and the involvement, I prefer LRS only when it is less cumbersome. That's all.
Okay. One more thing, sir. For the Ilizarov, usually what we used to do for the open fracture or infected non-union cases. So in those cases, we have doubt about the antibiotics because whenever we send for the culture, usually it is like multi-organism is there and it is resistant to most of the antibiotics. So after applying the Ilizarov and removing the fragment, what should be the ideal treatment for this antibiotic, and how you monitor
Same as the open fractures and the normal internal fixators. If principles of infection and the antibiotic use is no different in Ilizarov as well. You require a good debridement, soft tissue as well as the bony debridement there also, followed by the culture and as well as the biopsy from the part if we are dealing with the chronic osteomyelitis, and even in the dealing in the acute acute infection, then definitely a good period of the IV antibiotics followed by the oral antibiotics. It goes same by the
and monitoring with CRP and
yeah, exactly.
Okay.
The principles are same almost.
Okay. So, yeah, please.
अवनीत आ जाओ, इसके बाद तुम्ही को कराना है एक फोटोग्राफर अपना आइए अवनीत आओ ना ज्वाइन कर
For next session, I would like to invite Dr. A.K. Mano sir, Dr. Anil Kumar sir, Dr. Arun Kumar sir, Dr. Rajat Charan sir, and Dr. Praveen Kumar sir. Please come on stage and chair the session. Our guest lecture speaker, Dr. Naveen Thakkar, sir. Please come. Thank you, sir.
Good morning to everybody. We are going to discuss together invisible medial instability in distal femur fractures. Distal femur fracture has been discussed throughout last 3 days in detail. So we'll be sharing, contributing and learning together, and your inputs will be valuable. So this is the routine story we see in the distal femur. The surgeon has fixed it very well. Gradually, because of the stress and strain, it gets in little bit varus, you see, typically. There is not much combination, but still it is a crumpled bone, so it goes into the varus, it gets united. What was the problem? The audience many times says that there is a length of the plate was the problem. Dr. Janki, you are right, na? Length of the plate is the problem. It's a short plate, right? So, short plate is the problem. That has been everybody saying in every audience. Now let us see, again there is a long plate. Very long plate, ideal fixations, leaving one another. Let us see what is happening on the stress and strain. On the stress and strain and on cyclic loading, it gets united, but it is malunited. This is not possible in a locking plate, but it happens. The implant gets bent, and if it does not got united, it would be a failure here, fatigue failure. That is the problem. So what was wrong here? Long plate. Though it was a long plate, there was a problem. Another case where surgeon has given a long plate and the graft, but still it is failing. What is the problem? Long plate, short plate, what is the problem? Non-structural graft here, you said same case. In a crumpled bone, in an elderly patient, is it preventable? When there is no much combination, but is the elderly osteoporotic, that creates the problem. By minimally invasive way, there is a one possibility when there is this osteoporotic bone and the bone is crumpled because of the quality of the bone here. It is crumpled, so it is going to collapse. This is the possibility where you can put two flexible nails from the medial side to get some support on the medial side without opening, without disturbing the biology on the medial side. This is one of the possibility biomechanically, where these two flexible nails with a small incision gives the support on the medial side like a spring on this side. It is a flexible fixation, it is under stress. That's why it's the recoil gives the medial fixation, and on cyclic loading it gives the micro motion also. This is at the 12 weeks. This is at the 58 weeks. You can see the required stability for that particular case. There was no gap. It was a combination. And whatever required stability was there, two implants. One is a relative stability, no compression, and another is also relative stability. So there is no absolute stability, there is no relative stability, it is something in between, absolute stability. You can see the result, small scar here and the flexible nails inside, and that has given a very good result. The thought process behind this, cyclic loading, the force is coming on the medial side. Either you have a implant on the medial side, the medial plate in such cases, where you feel that there is a stress and strain is much more. Or you can have a flexible thing where callus can happen. The problem with the locking plate is callus is happening only on one side. That is the study. Other side the callus was not happening. That's why literature says the 32% failure rate with the locking plate. Another case, 16 weeks. Dr. Janki, what will you do? Now you are a surgeon. Patient has come to you, previously operated by some surgeon, and this is the 16 weeks. Young patient, no comorbidity, no problem. No diabetes, no hypertension, nothing. But surgeon has fixed with this sword plate. What will you do now? Stability is compromised. Okay. What will you do? You will change the plate, long plate? Amulya ji. Even X-ray is not showing.
It is not showing. We have to stabilize on the medial side. Now the choice is that you already have a very short plate on the lateral side. Either you have to reconstruct everything, take out everything, or maybe apply one-tenth from the medial side.
Exactly. What will you do? It is your patient. What will you do? You will change the plate and long plate. Then what?
Long plate from the lateral side and with a medial stability and graft.
You know, I know. Yeah, you are right, absolutely right. Everything is right. You are right.
I have to change everything now.
Every change. So, just fibula and the medial plate without changing, because this was a stable one. So, surgeon did the medial plate and the bone grafting and the fibula, and the required stability for that particular patient, for required invisible medial instability, that stability was provided. And then the mechanotransduction started, the cellular response started, mitochondrial level responses started, osteocytes started generating, and at the 12 weeks it started uniting on the medial side. So required stability is given, and you can see the function. The same case which I have shown previously, the long plate, non-structural graft. There is no place for the non-structural graft with such a combination. It was a long plate. Still there is a medial invisible instability. The long plate is not only the solution. You have to check for the stability. Again, the more problem, it was broken and it was a cold welding with the titanium plate. So that was another problem area. So we put this fibula and the medial plate to support it. What will happen? Amulya sir.
You have already done the correction. Fibula is there already, and I think you have already put the cancellous bone graft.
Yeah.
So we do expect a good union after this.
This is at the 12 weeks.
The fibula is not getting incorporated as such.
Right. What will happen now? What do you expect?
Chances of failures. If the patient goes on weight bearing for a long time, the chances of fracture, breakage of the implant will be there.
Breakage of the implant is a possibility. You are right. But typically in such cases where you have done the non-union case, you have to wait for 6 months. Always warn the patient that the bone formation will be seen on the X-ray. It will take at least 6 months. And you can see that mechanotransduction has already started. Cellular level changes have started because you have changed the mechanical environment. The surgeon has changed the mechanical environment. That's why it has changed the cellular environment. The cellular in the canaliculi, Harvesian canal, the pressures are changed. So calcium channels are opened up and permeability is changed. So new bone formation and angiogenesis has started. And you can see that the same thing, stress and strain pattern has changed. Stress and strain has now come to 2 to 10%, but we don't know on table whether it is 2 to 10% or not. That is the problem with the surgeon. So you have to wait. And you can see now gradually this position, and now the complete bone formation has happened. But it takes time. The surgeon can modulate the mechanical signals to the cells and osteocytes. So surgeon has the ability, by changing the mechanical environment, can change the biological environment also. And this is one relative stability with the another relative stability. We are taught that in the non-union we have to do the compression, but there is no compression. Still that comes under that stress and strain and the cyclic load. So that has given the cell signal starting, and it has given a very good result. You can see the previous incision, and this is a modified Schwarzbachler approach. Previous MIPO and this and the fibula here, and it has given a very good function. So there is a possibility that you have to think about the medial instability, invisible instability. Many times we feel that we have made it stable, but still it is not stable. So what is the message? The message is long plate or a short plate? No, it is not a long plate or short plate. Whatever the implant system you use nail and plate or plate and plate or a flexible nail, whatever the instability is there required, that you have to create, and that invisible medial instability has to be taken care of. As we are doing taking care of the lateral wall instability in the proximal femur, required stability has to be done. The next question comes, how far I can go medially for the medial plate? That is the question many people have asked. This is a very good paper. They have divided femur into this region where you can go up to here medial plate. If you are a good dissector, there is no problem with the biology. It is safe till this region, it is a safe. There is no problem with the vascularity. This is the paper. They have done the study and they have divided this femur, total femoral length, and you can go up to here. Again the question is, I have put the medial plate, but it is not working. It is not only the medial plate, it is the length and the plane of the plate, because the stress and strain in different fracture planes are different. So you have to support exactly the plane where the stress and strain is more than 10%. Pirene has given us 2 to 10%, but we do not know one zone has a more than 10% and one zone of the fracture has 2 to 10%. The one zone shows the callus and the other zone does not show the callus, because both have a different stress and strain. Another, the patient was not ready. This is also one of the possibility of lost implant, intramedullary plate as a strut, where screws can go from here to here, and that can give a good result when the patient is not ready for the bone graft and bone graft morbidity. This is the clinical picture of the result. So we know this rigidity of construct, strain, and the micro motion, working length, strain. We have learned this theory lot of, but on practically on table, we do not know exactly how to get the exact stress and strain for that particular case and particular quality of the bone. We have learned yesterday rigidity of construct, plate screw density, length of the fracture zone and length of the plate. That has to be taken care of 100%. They tried for the distal femur another implant, that is the axial diaphyseal fixation, that is the far cortical locking screws, which gives the micro motion. Here you can see it gives the micro motion. Here this is the study done in the SIP, where the callus happened if it is not rigid on the opposite side also. You can see that in that video that there is a micro motion appearing at this level and also continuously on vertical side. You will see in that video, now it will come. Here vertical movement starts. You can see that on dynamic loading it moves like this, micro motion. But this is also failing. They have studied this, coming with the new things. This is the problem of the interfragmentary strain theory of Pirene. It is all or none, either absolute or a relative stability, but there is a zone in between where continuous cyclic loading is there and this cellular activity stops, where the job of the surgeon comes of the mechanotransduction and open up these cellular channels with the mitochondrial level. So surgeon has a problem to balance between the rigidity and optimum interfragmentary movement. Optimum word is good, but we do not know on the table whether I am optimum or not. That is the problem. So new plate they have devised now. There is a slit here which gives the flexibility, and surgeon has no choice. He has to put the screw here. So alternate holes only. It is not given all holes. Still it is under study. What could be the future? Smart implants, stress and strain measuring implant, which can give you on table what will be the result on the cyclic loading. Till that time, we have to intervene early in the follow-up, and we have to go by the nature. The bamboos are stable, still they are flexible. Stability gives the growth, the flexibility gives the growth. of the newborn formation. Thank you very much. I must say, IO team, Dr. Lalit Maini, Dr. Govardhan, we have devised the theme for young orthopedic surgeons, fellowships and training for all, bone and joint in safe hands, and the task for the brainstorming and action. And there is very good response from all over the India. Presidential task force are the multi-centric, multi-generation, result-oriented, designed to tackle the most critical issues of all the members. And let me give you the news. The IOAC has passed that we'll join with the Supreme Court here for the Consumer Protection Act. Out of the 7 problems, the first longest problem is the Consumer Protection Act. So this PIL, the Indian Orthopaedic Association, is joining with the other associations. We invite you at IOCON, Ahmedabad, Gujarat. Thank you very much.
Thank you very much, Naveen Thakkar sir, for your nice guest lecture. Now another guest lecture is by Dr. Carlota Alsona.
Wonderful. Am I properly audible now? Great. Thank you very much for being here today. Thank you very much for welcoming. Thank you especially to Dr. Maurya there and to all the organizers. It is really a pleasure for me to be here with you today. I know it is one of the last sessions after a very packed schedule over these past 3 days. And I don't want this to be boring. I don't want this to be making you sleep or crave lunch. So I want to bring some new insights. My name is Dr. Carlota Alonso. I am an MBBS specialized in emergency medicine from Spain, and I am currently based in India. And I am working in the future of upskilling and training of the healthcare professionals. Doctors as well, but not only doctors, also nurses, paramedics, and leaders. Because India, as other countries in the world, is facing one of the most important issues today, which is a lack of workforce. We read in the papers all the time that we need more and more doctors to face the demands, and this is especially important and challenging in India. But what happens with the skilling? What happens with the training? And I think that you leaders are gathered here today precisely because you can take the lead. You are the ones who have to ensure that we not only train more and more numbers of doctors, but that we train them properly to follow your lead and to follow your standards. So I am going to maybe challenge you a bit today, and I am going to ask you for a big favor. I really would like you to please scan the QR code which is on the screen. And I really, really appreciate it, because I know sometimes we want our audience to interact, and sometimes we're a bit hesitant, we're a bit reluctant. Thank you so much for the organizers as well to make it possible that I'm using online slides in the last minute. Okay, so I'm seeing we have 8 people online, 9 people. Come on, this is a very big room. Please join. Just log in, scan the QR, try to join. 13, 15. Great, this is wonderful. Now we have over 20 people, 23. So I think we can start. I'll show the QR code again later. And this is wonderful. I really, really appreciate it. Now, why am I sharing the QR code with you? Let's share for those last ones. I'm sharing the QR code with you because I want to ask you three very important questions. And I am not a teacher. You are seniors, you are leaders, you are CEOs of important hospitals, you are the leaders of societies and important associations. This is not to test your knowledge. This is because I really want to get to know what you think, and I want to make you critically reflect on what is happening today. So I'll ask a very, very simple question. If you look on your phones now, you can submit your answer. Now, have you used your phones to interact with any other of the previous sessions that we've had over this past 3 days? It's very simple. Yes or no, if you've interacted with someone using a presentation over these past days. Just very quickly. So, I see some of people have, most of you haven't. And this is exactly the answer I was expecting. And it is for a reason. I'll disclose now. But now, be very, very honest. And without the person sitting next to you realizing, yes, tell me from the bottom of your heart, have you used your phone to scroll on Instagram, to respond to a WhatsApp message, to answer a call for your clinic? Have you been distracted by your phone? And I say, yes, I have. So just be very honest and share about you. Now, there is a massive yes in this answer. And this is also normal. This is also what I was expecting. And now I'll ask the third question, which is, why are you all gathered here today? Why have you come for this marvelous conference? Is it because you want to learn? Is it because of the food? I heard the food in Bihar is very good. So I was also motivated. I was also willing to come. Now, number 3, was it because of the musical evening? Because people were telling me these singers were not only famous in Patna, they were famous all across Bihar. Or was it because, see, you're a junior and your senior told you, you have to come to the conference, you have to show up, you have to click the pictures? Very honestly. Okay, so most of the answers is that you're here to learn. Now, this really worries me. And this worries me for a reason. Because you are here to learn, but the percentage of interactive sessions that we've had, the previous one was very interactive, sir. I really appreciate it. But others have not been so interactive. And there is very strong scientific evidence that shows that if we want learning to actually be engaging, to actually be productive, to actually have an impact, we have to interact. Passive learning is not as impactful as active learning. So one of the things that I wonder is, why are we doing conferences in the same way we were doing conferences 10 or 20 years back? And this is the same thing I see, not only in Bihar, across India, across Europe, across Latin America. So it makes me think. And to be very honest, I think this happens because you are the best. You are the best. And I think that is why we're doing conferences in the same way we've been doing it before, but why we're also just doing passive learning. And now you might tell me, okay, but Carlota, this is contradictory. Are you implying we could do something better, but at the same time you're telling us that we are the best? And yes, this is contradictory, but this is right. Because all of you here today, you are the best in the country or even abroad in orthopedic surgery. Now, if we really want to make impact, if we really want to lead, if we want to make Patna and Bihar living orthopedic upskilling and training everywhere, we have not only to be the best orthopedic surgeons, but we have to interact with the best educators, with the best technologists, and with the best policymakers. Because otherwise, we will not be willing to improve, to demonstrate, and to actually create that impact that we are looking for. Now, what really strikes me is that clinical excellence alone is no longer a warranty of professional relevance. I see people nodding, and that's very right, because if you are the best at what you are doing, but you don't share, if you don't teach, then we are not going to be able to make orthopedic surgery to improve and to survive. And I would say that if junior doctors ask me today, what is the one biggest mistake that I would be making in my career, it is assuming that clinical excellence alone is enough. Because today we are facing a very challenging era where unless we are updated in the skills that the 21st century demands, we are not going to be able to offer our patients the best of what they deserve. And I think we all did medicine because we want the best for our patients. We don't want the spotlight. We want the best care. And we have to bear in mind that today, knowledge expires every approximately 2.5 months. That means today you've been sharing some of the most relevant cases in orthopedic surgery, but in 2.5 months, they are not going to be at the forefront. So I think we have to drive acceleration in every healthcare discipline, focusing our insights across 5 pillars. Now, these pillars include robotics, and I was really, really pleased to be hearing about robotics today, about AI imaging, about biologics, about regenerative medicine, and about digital surgery plan. Now, when I am asked about what 3 big mistakes are doctors making and why are we not reinforcing those 5 key strengths, I would say, again, mistake number 1 is believing expertise equals performance. Unless we are constantly updating and upskilling, we are not going to be top level. And that is why for you it is so important to be here today, to learn, not for the musical evening. Number 2 is ignoring technologies outside our specialties. Now, how many of us feel that technology is challenging for us? Because I've been using a smartphone since I was a teen, and still I feel technology is very challenging for me. So for my seniors, it is even more challenging. I think it is something natural, and the first thing we have to do is name it, acknowledge it, and then try to solve it. And then challenge number 3, or mistake number 3, is thinking that medicine is only about procedures. It is not. It is about talking, it is about sharing, it is about implementing, and it is about thinking out of the box. So I think we have to shift the traditional paradigm to a future paradigm where we focus on augmented surgical ecosystems, on cross-disciplinary integration, and continuous adaptation and tech fluency. And not only that, I think we have to focus on the 5 pillars of digital blueprint today, which are, in the first place, technological literacy. I'll try to divide them in 2 fields: technological literacy, data interpretation, and interdisciplinary thinking. What I was telling you, making you not only speak with surgeons, but also speak with engineers, also speak with data experts, also speak with communication experts who can bring the best of all of the worlds together. And furthermore, we have to sustain relevance through continuous learning and leadership. And for me, leadership comes not only by sharing the most relevant cases or the biggest data sets or speaking at very relevant conferences like today. Leadership starts in the hospital, starts with your patients, starts with your nursing team, and starts with the way you take one step forward out of the box in a path that might be challenging, might be scary, but is actually going to drive the biggest impact. And I think we are in a very advantaged situation because I am talking to you in India. I am not talking in Spain. And India has so many advantages in comparison to other countries, apart from having wonderful people, of course. But I think India has the largest volume of patients in the world. I've seen you today making references to Europe data sets. Now, the richness of India is that the population and the demography is so diverse that you have so many different clinical data sets that you can use to model so many patient outcomes. Number 2, you have one of the world's youngest and most ambitious workforce. So in a moment where the world is lacking numbers, where the world is lacking workforce, you can be the source to provide not only the workforce that India needs, but also to provide the workforce that the world needs. And third, you are not only adopting technology fast, India is making the world adopt technology fast. India is one of the world leaders in terms of technology. So you are at a great advantage at the moment. So this is why I think that adaptation is an infinite biological loop. But India has to be very aware of the advantages that they have as a country so that we can move forward and we can be the reference and the example that we can lead, that will make others look up to India as leading not only in technology, not only AI, but also in healthcare and education, which I think will be the biggest struggles of tomorrow. Like our fellow speaker was saying before, doctors are always going to be needed. This is not about AI or robotics replacing doctors. This is about doctors who understand AI, who understand technology, and who understand interdisciplinarity, replacing those doctors who don't. And I was thinking about how to end my talk today. And I don't want this to be the end of my talk. I want this to be the beginning, because I am saying that we have so much potential only in this room. Imagine what Patna has, imagine what Bihar has, imagine what India has. That I want this to be the beginning. I want this to be the beginning of something else. So I want you to think. So kindly go on your phones again and just drop in 2 or 3 words what you think you could do tomorrow to start something that could potentially create impact. Now, this brainstorming or these ideas could be having a specific workforce in this topic and teaching undergrads, or it could be trying to catch up with my engineer friend and see what he can bring into orthopedic surgery. Or it could be trying to make a network of doctors across Ireland, Spain, and India who would be able to give us a different insight into what we should be doing next. So I would be very grateful if you share your ideas. And see, I'm seeing some of your answers: to learn, to improve, to try to do, interdisciplinarity. And I am someone who is not just pulled by words. I am really driven by actions. So what I want to do is to invite you here today to scan this QR code, to create a new workforce, a new group where we can exchange ideas. We can start taking small steps, and then maybe next year here in Patna, Bihar, we can celebrate what these ideas translated into in the real world. So thank you very much. Thank you all of you for your participation. Thank you, Dr. Maurya, sir. Thank you very much. Thank you very much.
Thank you. We'll conclude the session.
Sure.
Thank you. Thank you so much, Dr. Carlotto, for expressing everything what we as orthopedician, not as an orthopedician, in future we do want to. Thank you, Chairperson, sir. Can you have your seat? So starting with the next session. Hi, a group photo. Can we have, sir, please, sir, for a group photo. Dr. Carlotto, can you come forward for a photograph? Now going towards the last session of this prestigious Gofcon 2026, Dr. B.N. Singh Oration. We have got 5 chairpersons for this. May I request Dr. Padma Shri R.N. Singh sir to kindly come to the dais. May I request Samshul, please escort Dr. Padam Shri, Dr. R.N. Singh sir to the dais. May I request Padam Shri, Dr. Shanti Roy ma'am. May I request Omer, who has come all the way from Ireland, to kindly escort Padam Shri, Dr. Shanti Roy to the dais, please. Udhar se, Omer. Yeah. Thank you so much. Thank you so much. May I request Padam Shri, Dr. J.K. Singh sir, to kindly come to the dais, the renowned oncologist. We have got doctors from different fraternity at present. Padam Shri Dr. R.N. Singh, renowned orthopedic surgeon. Then we have got Padam Shri Dr. Shanti Roy, renowned gynecologist. Padam Shri Dr. J.K. Singh, renowned oncologist. May I request Dr. Padam Shri Dr. Vijay Prakash sir to kindly come to the dais. Renowned gastroenterologist. Yes, sir. And may I request Padam Shri Dr. Hemant Kumar sir to kindly come to the dais, renowned nephrologist. Now we are here to hear something from a man who is not an orthopedic surgeon, of course, but he is a person to whom we should listen to, a senior person, and he is none other than Dr. S.K. Tyagi sir from Meerut. Dr. S.K. Tyagi, I have kept your seat beside Padma Shri Dr. Vijay Prakash because only he is going to introduce you. First we will have...
Say yes, anything please. You know about me.
Sir, please, sir, have a seat, then we'll start. First introduction. About late Dr. Vijay Narayan Singh sir, a very senior orthopedic surgeon who inspired so many of the young generation. Always he was a smiling face. और उनके ऑनर में प्रतिवर्ष गॉफकॉन में डॉक्टर विजय नारायण सिंह ओरेशन होता है. Madam, you are here. I welcome you all. I welcome everybody who has come from the Gynecological Society, Post-Menopause, Patna Menopause Society, all our orthopedic friends, everybody. And to introduce about her own father, Dr. Archana is here, who is there at All India Institute of Medical Sciences, New Delhi. Even we have a faculty from All India Institute of Medical Sciences, Dr. Samarth is here. But first, Dr. Archana, I want that you should tell about your own father.
Respected chairpersons and esteemed audience, I'm really honored and grateful to have the opportunity of presenting and introducing the oration. My father, Dr. Vijay Narayan Singh, was a towering personality, and his commitment and knowledge of orthopedics was immense. His dedication to his profession was inspiring. He was born in the village of Badhaiya on 22nd June 1945, and after completing his schooling from Patna Collegiate, he did his MBBS from Rajendra Medical College and subsequently his MS in orthopedics from the Prince of Wales Medical College, which is now known as Patna Medical College. Then he joined the provincial government service in the same year. In 1975, he proceeded to the UK for further surgical training, and after completing the fellowship of the Royal College of Surgeons and his MCH from Liverpool University, he returned to India in 1985. For a while, he served as a senior consultant orthopedics in Guru Gobind Singh Hospital, Patna, and after taking voluntary retirement in 1995, he was actively engaged in private practice. He was a life member of Indian Medical Association, Bihar Orthopedics Association, the Indian Orthopedic Association, Association of the Surgeons of India, the World Orthopedic Concern, Indian Society for Study of Pain, Indian Foot Society, Bombay Orthopaedic Society, and Asia Pacific Orthopaedic Association. He was also an active member of SICOT and the British Orthopaedic Association since 1985. Apart from the memberships of professional bodies, Dr. B.N. Singh was a member of Rotary International, the past president of Rotary Patna Midtown, Paul Harris Fellow, former member and chairman of Polio Plus Committee, the GSE Committee, and Help to the Handicapped. He presented scientific papers in many national and international conferences, and during his presidentship of the Bihar Orthopaedic Association in 2003, along with Dr. Amul Kumar Singh as secretary, the association was awarded the prestigious Dr. A.K. Gupta Trophy of the Indian Orthopaedic Association after a long gap of 26 years. He was conferred the Lifetime Achievement Award on 22nd February 2020 by the Bihar Orthopaedic Association. He was an active and noted member of the Rotary International Polio Plus Committee representing Bihar and Jharkhand for 7 years, and he saw the end of polio in Bihar in September 2010. My dad loved listening to music and traveling. No matter how late he came home after work, he took time to recharge himself listening to old melodies. Raj Kapoor was a particular favorite. He traveled more than 40 countries across the globe and loved to experiment with local cuisines wherever he went. His wife, my mom, is here in the audience, Dr. Usha Sharma. She's a gynecologist, and I am his elder daughter, Dr. Archana Singh. I'm a professor at AIIMS. And my sister, his younger daughter, is an investment consultant in New York. He has 3 grandsons, namely Arunab, Avichal, and Adam. Dad left for his heavenly abode on 18th June 2020. For the large majority in the pre-internet era, there were very few role models to emulate in the professional and personal sphere. I can proudly say that in my dad, Dr. Bijay Narayan Singh, who lived his life with unfaltering professional and personal integrity, we had one at home. He will always be fondly remembered by his family and the entire orthopedic fraternity. And as the new ones join the fraternity, it's good to remember those who came before us and on whose shoulders we stand. Thank you very much for your patient listening.
Thank you so much, Dr. Archana. Especially for every oration, right from the first time, whenever we started it, she has always traveled from New Delhi to Patna for this oration, which is not only for her family, basically for every member of Bihar Orthopaedic Association. This oration is dedicated. And for this, we have invited Dr. S.K. Tyagi, sir. 6 months back only, personally, I was sharing a stage at Visakhapatnam, Vizag, that I heard a man who was talking something from his heart. I listened to him. Each and every word I was listening very patiently. Next day morning, when we were sitting at the breakfast table, I couldn't resist. मैंने बोला कि सर मैं चाहता हूँ पटना में आपको देखना, आपको एक मंच पे. And within seconds, I got a positive reply. Amulya, I'm going to come. I know in Patna, Dr. Vijay Prakash, Dr. B.K. Agarwal, and he kept on naming some of the big stalwarts of Patna. And he is here. So I don't want to introduce him. I will request Padma Shri Dr. Vijay Prakash to kindly introduce him.
Thanks, Dr. Amulya, for having called me here and having made me to chair such an important session. I really feel proud about it. Dr. Tyagi is a practicing gastroenterologist from Meerut. I know him for more than 40 years. I did my residency under him when he was registrar. So, but we don't communicate very frequently nowadays because of our own busy schedule. So when I just asked him, how should I introduce you? So he said, first thing he said, that you can introduce me, that I do everything except doctory. I am a dramatist, I write articles, and I interview eminent personalities, and he named a lot of them, of which one was P.V. Sindhu. And second thing he said, that I remember one thing about you, that you are my resident and you wanted your first holiday from residency to come back to Patna to play Holi. And I allowed you leave, and when you came back, I couldn't recognize you, and you said you had played Holi with your Sali, and they smeared you all over. So those were the two things he just reminded me. The topic on which he is going to talk today is non-verbal communication. As much as I know him, he is an excellent communicator and he is a very witty person. And a communicator like him has been given a topic like non-verbal communication. That reminds me of an old film, Saath Hindustani, in which Amitabh Bachchan, who has the best dialogue delivery, was given the role of a dumb person. But I am sure Dr. Tyagi will do justice with non-verbal communication also. With those words, I invite Dr. Tyagi. Dr. Tyagi, please.
Sir, before you come to this mic, I will request Padma Shri Dr. Aryan Singh, sir, kindly come to the center, please, sir, to felicitate. I will request everybody, all those people who are sitting here, the Padma Shri, our respected Padma Shri, sir, to present Dr. Tyagi, sir, with a shawl from our side. I will request sir to keep standing there for some time. Before I present, the Global Orthopaedic Forum is privileged to present the Global Excellence Award 2026 to Dr. Satyendra Tyagi of Meerut for delivering the Singh Oration at Gofcon 2026 on the 29th March at Hotel Maurya, Patna. We stand here today to recognize a luminary in the field of medicine, Dr. S.K. Tyagi, Senior Consultant Gastroenterologist from Meerut. It is a rare and prestigious occasion when the worlds of orthopedics and gastroenterology converge, and there is no individual better suited to bridge this gap than Dr. Tyagi. You are one of the first gastroenterologists in North India to start private practice in 1979 after his MBBS from AFMC and MD from PGI Chandigarh in 1977. So before I met you, I never knew that you are my senior for AFMC. So, but much more senior, sir. And you are practicing in Meerut and you are well recognized for epidemiological work in the field of HCV. You have been a member of National Advisory Board of INASL for Hepatitis C and Member Advisory Board for Asia Africa for HCV. You have spent decades at the forefront of digestive health, earning a reputation not just as a skilled clinician, but as a visionary in medical education and patient advocacy. Your clinical acumen in managing complex gastrointestinal disorders has made you a cornerstone of the medical community in North India. In 2019 to 21, you had several international publications. It was a career highlight when you were invited by the Oxford Group to deliver an oration. You have been active as faculty at several conferences in India each year. You are passionate about traveling and photography and films. You have traveled to 96 countries and have just returned from a trip to Antarctica. Not limited to academics, you have done a role in Bollywood film in 2024 and have interviewed live personalities like P.V. Sindhu, Sharmila Tagore and Shiv Khera. You are in the process of publishing your collection of short stories. In the spirit of Gofcon 2026, we honor Dr. Tyagi for your profound insights as a healer who looks beyond his own specialization to understand the holistic needs of the patient, which represents the true pinnacle of the medical profession. The Dr. Singh Oration is reserved for those who demonstrate exceptional leadership and a commitment to the advancement of medical science. By delivering this oration, Dr. Tyagi continues the legacy of excellence and intellectual rigor that this forum represents. The Global Orthopaedic Forum is proud to present this citation to Dr. S.K. Tyagi. We salute your dedication, your spirit of inquiry, and your unwavering commitments to the healing touch. Presented this day, March 29, 2026 at Hotel Maurya, Patna. I would request all the Padam Shris to kindly present this citation from Yes, sir. Over to Dr. S.K. Tyagi, sir.
Well, let me at the very beginning express how humble and small I feel delivering this very prestigious lecture in front of those who've achieved much more than I could ever have hoped for in their own fields. However, what is really important, and before I begin, let me tell you what Vijay said. He said that I gave him leave for Holi. Actually, I didn't want to give him leave. He wanted 5 days of leave from PGI Chandigarh, which had given me 1.5 days for my marriage. And here is this gentleman who wanted 5 days of leave to go and play Holi. I first said no. Non-verbal communication, his face dropped. His chin reached his knees. And I knew that if I don't say yes, he's going to start crying. So I gave him 2 days leave. He extended it to 4. When he came back, I thought I'm going to be extremely angry. This was emergency posting. But when I saw his face, I didn't know whether it's the same resident that I had sent home. And he came and I said, what happened? He said, sir, हमारे बिहार में ऐसे ही होली खेली जाती है. And that was the end. And I never asked him as to why he was late for work. Well, we just heard the previous lecture, a wonderful talk which told us all how much we have within our country, how much we've advanced. A previous lecture told us how we've started to develop robotics. It also told us the young population that we have providing health care, how we have adopted technology almost better than most other countries have. And yet, friends, why is it that while technology has improved, competence is on the high, then why has medical profession lost public faith? Because it has. The president of the Orthopaedic Society said, we want to get rid of the Consumer Protection Act. Obviously, that's hurting us. And that's hurting us because more and more people are getting litigant. This cutting a collage from the newspaper says the same thing. Pandit Jawaharlal Nehru said the impact of cinema was greater than the influence of newspapers and all the books put together. And Amitabh Bachchan said the Indian cinema has virtually become a parallel culture. What does the Indian cinema tell us about the medical profession? I have done a bit of a publication on this, the changing portrayal of doctors in Indian cinema from 1940 to 2022. And well, when we began in films like, and I've seen these films because these were my time of films, the doctor was somebody who was looked up to. Even if they did wrong as an Aarti, they ultimately came out to be superhumans, to be excellent human beings. Gradually, as you see, the films changed. And by the time that this century came, you started having things like Kabir Singh, One Day, Ankur Arora, murder case. And when you come to OTT platform, you've had Satyamev Jayate, you've had Human, you've had Dr. Arora, you've had the pill, you've had Gram Chikitsale, in which they tell you that an educated, a qualified doctor is so much poorer in communication than the village doctor who actually everybody throngs to. So where did we falter? We didn't falter in our competence. We are good doctors. The question is, are we great healers? And well, the medical school curriculum, which we've all gone through, teaches us technical skills. The technical skills are content, competence, and citation. That is, you read and you write, you publish, you document. Competence obviously is a given. If you've done an MD, you are expected, you've done an orthopedic MS, you are expected to be competent. Content, obviously, you've attended these conferences, you've read books, everything. And yet our perception in the public is dropping. And there's no doubt about it, it is. The reason is we do not concentrate on soft skills, that is, the human skills are skipped. What are they? They are compassion, care, and communication. There are no lectures in any medical school that teach you compassion, that teach you how to actually care for the patient, not treat the patient. I'm talking about caring about the patient. And it does not tell you anything about communication. These soft skills, as they are called, are totally lacking. And it is the lack of these soft skills, despite our advancing into excellent, competent doctors, is failing us. So the 3 C's are compassion and empathy, which is actually the heart of medicine. Care, which is how the medicine is delivered. And of course, communication, which is the bridge of medicine between you and the patient. Coming very briefly to compassion, don't confuse sympathy with empathy. Sympathy is you are telling the patient, I understand you have pain, मैं समझता हूँ आपको दर्द है. But empathy is actually feeling that pain. So the 4 elements that we forget about empathy, we sympathize with the patient, but the empathy is that we have to see the world through their eyes. What are they expecting? What are they suffering through? What are they going through? We don't have to be judgmental. You are psychological. अब तो दर्द नहीं होना चाहिए. थोड़ा tolerate करिए. That's judgmental. We have to find not just solutions, but we have to be in agreement with the patient to reach those solutions. That is empathy. And we have to understand not the patient's pain, but the patient's feeling. That, gentlemen, is empathy, not sympathy. I'll just read out this beautiful thing about empathy, what little things we are missing. I walked up to this patient in terminal in his illness. Today he was worse, obviously living out the last of his hours on this earth. With great effort, he moved his hands as if in slow motion, fumbling with his buttons, exposing his wicker basket chest, inviting me to proceed with the daily ritual of auscultating his chest. Here was a dying patient wanting his doctor to auscultate his chest. This ritual was as vital to me as it was to him. It was not about examination, but about the message that I care. With the whole genome exposed at our feet, we seem to have no need for these rituals. You have the complete data, the complete X-rays, the CT scans, the MRIs, all the reports of 30-odd pages before you. What is the need? You have an ECG that tells you what his pulse is. What is the need to hold on to his wrist? Nothing at all. The need is that when you touch him, you convey to him that I care. And that simple gesture is an expression of empathy, a soft skill that we are losing. Very briefly about care. Care is actually compassion in action. It's not treatment, it's healing. And I'll tell you the difference. Healing actually comes from the word heal, which is to make whole. and the word health, which means being whole. And it has been defined, as you all know, that health is a well-being and not merely the absence of disease. Most of us concentrate on creating a patient, making the patient nirog, if I may use the word, which is rog se mukt. Keval bimari ke anupasthiti is not healing the patient. Being swasth is being healing the patient. And that is Jeevan Shaili. So you could have removed a tumor from the patient's knee, but the patient's limp or the patient's amputated right leg is what needs further management, because he is going to be incomplete. He is going to feel that he is not himself till we address that issue. And that is making the patient swasth. Of course, I am using an extreme analogy, but say, for example, in our own physicians have much more of this, that we treat the patient, your chikungunya is all right, but his pain is lasting for 6 months, and we keep on ignoring it. So that is what we need. We need to show care to the patient, and not just that. The incision we close in the theater is only the first wound, mind you. There are several wounds that are left to be healed further. Realizing those wounds is important. The patient does not tell you those wounds. I was conducting a group discussion, a panel discussion, in which there were 4 doctors, head of department from All India Institute, head of department from PGI Chandigarh, head of department from Kerala, and the head of department from Chennai Medical College. This was in the Colitis and Crohn's Disease Society. There were 4 other people who were the patients. And when I talked to them, one of the patients said this. There was a huge discussion then. Every doctor in the hall felt bad because the patient said, "It's a long corridor to walk alone, sir, and I am merely a number arrested for life behind that barcode." What he said was, everybody called me by room number 432. Nobody called me by name. I was referred to as a number. I was a person. I was a human being. I was there undergoing therapy. And here you had reduced me to a number. The patient said this in front of the head of department, who actually had treated, and the patient was now all right. The class 4, the patient went on to say, the class 4 who wheeled me spoke to me more than my consultant. What a shame. Sometimes we look at our competence, we look at the end result, we don't see the path leading to that result. And it is that path leading to that result is what is more important to the patient than anything else. Last month, I have no shame in telling you this, end of last month I was diagnosed as colorectal carcinoma. I was taken in by my friends, I was operated upon, endoscopically everything was done fine. I was perfect. 2 days I was to go home. What do I remember most? I remember most is that I was discharged at 11 a.m. and the TPA had not prepared the papers till 9 p.m. So you see, today when we treat a patient, it's not just completing his therapy. It's an overall experience that he has with you. And be it the TPA, be it the ward boy, be it the guard at the lift, you are the ones who are responsible for all that, because the patient is under your care till the time he is swasth. Not treated, swasth. So this is what he had drawn, the patient had drawn, a barcode behind which he lies all the time. And now I come to communication. I was listening when the previous speakers were talking. There was a lot of verbal communication going on at the back. So much so that the verbal communication in front could hardly be heard. When you are quiet, you listen, and when you listen is when you understand. So if you keep talking amongst yourself, there's no way you are going to understand anything. And communication is a two-way street. How you communicate with the patient And more importantly, on which I'm going to give more time, is how the patient communicates with you, which you don't look at. We've had some great talks today, good talks, and we've had some great talks. So there have been good talks in the last 2 days, but some have been great talks. And the good talks informed us through their great content. But the great talks resonated through the delivery, through the way they talked. So it's not always the content, it is how you are communicating. The pause before creates the attention, and the pause after creates the meaning of the sentence to be soaked in. And I got Martin Luther King's photograph here because I think one of the best lectures that I have heard ever in my life is his "I have a dream." And if each one of us hears it and just puts ourselves onto that and say, we have a dream, as the previous speaker said, how many of you have a dream to do something? This would be beautiful. And the patients don't just hear us, they feel our words. When we talk hurriedly, it expresses indifference. No patient wants to be felt that he is indifferent. He's come, he has paid, he wants time. Don't hurry up in your conversation. A moment of silence speaks about compassion. When you tell him you need an amputation, when you tell somebody that your father's got CA pancreas, pause. That silence speaks. That silence speaks of compassion. That silence speaks, I understand what you're going through. I'm not going to hurry you up in your response. So the verbal communication is not just talking, it's active listening also. It's an empathy in validation. It's information exchange, exchanging information, and it's shared decision making. When we talk to our patients, it should not just be telling them, it should not be a monologue, it should be a dialogue, and a dialogue means dia. The two sides speaking. We hardly, I know some, we hardly let our patients speak. And now I come to non-verbal communication, the power of quiet. I know it's an odd sentence because the word normally is silence, but I'm using the word the power of quiet. The patient's silence speaks. The history lies in what is said, but lot more in what is unsaid. And we as doctors must learn to listen not to the words that are being spoken by the patient, but to his silence. And I'll tell you in the next few how silence speaks. The silence is not merely the absence of speech. It's a powerful communicative tool that can decodify fear, confusion, uncertainty, and the quiet need for comfort and emotional support. When the patient is quiet, this is what he is demanding. Are we giving that to him? We are giving a prescription. Silence carries emotion that language cannot hold. Let me be sure of that. So how do you learn to identify or to talk or to see what the patient is saying without the patient speaking? Stanford University, Yale University, Harvard have now started an art appreciation course for medical students because paintings don't speak. The students, medical graduates, are taken to the art museum. They discuss various art forms which are there. They talk about facial expressions, about hands, body posture. It sort of primes them up to see their patient as a painting when the patient is walking in. And there's enough data now that these people who've undergone this course in art appreciation tend to be more empathetic. They have a greater connect with the patient. And above all, with this communication, there have been far lesser litigation in the patients who have gone through that. So the Yale University, these two paintings I have seen myself, one of the loudest paintings. I think you can't say that you can't hear the scream of this painting on your left. It's by Munch, it's in Norway, in his own museum. The painting is called The Scream. The protagonist, the painting, is screaming, and you should be able to hear that scream. Hussein's painting, which is there behind my chair, and I ask my patients when I tell them, are you depressed? I'm asking you, why are you not looking happy? And they deny it. I say, listen, I can see it on your face. Can you not see the pain on this horse's face, the wide mouth, the loud scream that this horse is doing? Each one of us should be able to hear that. If we can't hear that, we are missing out on something our patients are trying to tell us. We have to start to identify all this. Then the body posture. Well, this is Grant Wood's American Gothic on the left-hand side, and this is a patient of mine, and I have her permission. 8 months of pain abdomen, all investigations normal. This is a typical posture that a stoic, the absence of any external emotion. These people will not tell you what they are feeling. You have to get it out of them, because it is only after conversing with her for almost 10 to 15 minutes, I realized that she has very high ambitions which she is unable to fulfill. And because of her failures of not being able to, she is hiding behind the curtain of pain abdomen. It took a lot of time, but here is it. Then we have Raja Ravi Verma's 2 paintings. Can you see the beautiful face on top? Innocence. We have to start recognizing. I'm not saying it's going to be useful to you in your next patient, but you have to start recognizing people's faces. Because the person who's standing before you, who's sitting before you, is not merely a bundle of illnesses. He's a human being. We have to identify our patients as human beings. And so that is innocence. And down below, Raja Ravi Verma's another painting, so flirtatious. Here is this lady with open hair, slightly wet, the pallu falling down which she is holding, a fruit, a nibu in her hand. Now you should be able to, he's not written this, but if you look at it, you will realize how flirtatious it is. So you have to start to identify people when they come, not in judgment, but this is non-verbal communication. The patient's body language, the patient's appearance conveys to you many more things than you do. And then you have Amrita Shergill's on the very end. This is her own painting of herself at the age of 14 years. Defiant, judgmental, almost angry at everybody else. And this was what her life was. She'd married twice. She had given up a lot of people. She had gone against her husband. She had remarried her husband. And a lot of things happened with Amrita Shergill. And so this is the face of somebody who's judgmental, who's partly angry. You have, of course, the face which are sad. These are the patients who are not able to hide what they are feeling. So history is not just heard. History is social and a mental ill-being, which you should be able to recognize by seeing the patient. This is Frida Kahlo's own self-portrait. She had polio on one leg, married 4 times, left all 4, remarried one of her husbands. So there's a lot that goes on which reflects on a person's face. This face is not happy. It may not be angry, it may not be crying, but it's not a happy face. And that is the non-verbal communication that we should all try to listen to. Eyes, of course, speak. Eyes speak the loudest. You see these eyes, they're all from paintings, from various. You can see fear, hate, hope, tiredness, sadness, disappointment. There's a difference between sadness and disappointment. So all these paintings, if you see, if you learn to identify a patient's eyes, look at the eyes and try to see whether you can get something more from your patient's history than anything else, is the mastering of non-verbal communication. Of course, 2 beautiful paintings. I consider them, this one is almost of contentment, that is Mona Lisa, and the other one is a girl with a pearl. The painting's name is A Girl with a Pearl earring. Both of them beautiful, both of them mysterious. You can't tell what's happening. You'll have to explore further into somebody who comes with this expression to get to know more about these little smiles. Even the girl with the pearl has a smile. You're not able to see it. But the eyes have a little bit of a smile which we should be able to see it. Hands, of course. Anxious hands. These are anxious hands. You can see all the top three are anxious hands. When your patient is sitting with these hands, the patient is anxious. Don't mistake it for anything else. Look at their hands. And the relaxed hand postures are at the bottom. So these are two very simple ways to realize and to see the non-verbal things the patient's body is telling us. A beautiful painting called Blood Transfusion. This is from the good old days in tuberculosis, where for a short period of time, goat's blood used to be transfused. And this is a painting where the goat's blood is being transfused. I don't even think you saw that there's a goat where the blood is being transfused. So you see, we don't observe too many things. We just see, we let it pass, but that's actually wrong. But is the patient in pain? How do you say that the patient is in pain? Please look at the hand. Look how the hand is gripping the side of the bed. That is pain. So look at small things that the patient might be telling you that the patient is in pain. This is too complex. I'm not going to get into it. If I had more time, I'd go. This is the massacre of innocents, in which there are innumerable expressions that are there. Then there's this, again, an expression of pain. Then this whole painting, of course, there is the liver of Prometheus, who actually, by Zeus is a Greek god, was very angry because Prometheus gave away the secret of fire to the world. And therefore he was punished. Every day the vulture would come and eat his liver, and each day the liver would grow, and each day the vulture would come and eat again. But where is the pain? The pain, if you see, is in the foot. If you see the foot which is bent, the toe is extended, that is the expression of pain. So you have to actually see many things before we go further ahead. Here are two paintings, self-portrait with red geranium by Dick Kett, and looks a simple painting. Of course, he is a bit emaciated. He had cyanotic heart disease. And why do I say he had cyanotic heart disease? I don't know how many of you have observed it. At least the physicians should have observed it. You can see the clubbed fingers. And he actually had cyanotic heart disease. So you have to observe paintings very closely. The other painting, of course, I have expanded it at the bottom. There's a person who's lying on the road with congenital club foot. And I don't think from far you can see, but his toes, there are 7 toes. A typical trisomy 13, which if we observed, we would have seen it. So observe your patient. It's going to tell you a lot many more things. Non-verbal communication, there's no better example than Joseph Bell, who was a famous physician who actually Arthur Conan Doyle worked under and then made the character of Sherlock Holmes. And this is a little short story that comes which says, Sherlock Holmes is SH. What sort of crossing did you have on the ferry from Burnt Island? The lady said, it was good. And what did you do with the other child? I left her with my sister. Did you take the shortcut through the Thrall? Thrall is a garden. To get here to the infirmary? Yes, I did. And do you work in the linoleum factory? That was the conversation Sherlock Holmes has with the patient. And Dr. Watson, who is his assistant, asked, how did you ask that? And he said, when she said good morning, I noticed her Fife accent. The red clay on her shoes showed that she had come through the botanical gardens, which has red clay. And the coat she carries is too large for the child she had in her hand. So obviously she had another child which she left somewhere. And finally, the dermatitis on her hand is typically seen in those working in the linoleum factory. So you see how much you can. The most important thing, ladies and gentlemen, we offer our patients is not our knowledge, but it is ourselves. So let's offer the whole of ourselves to the patient. Listen to the wind, it talks. Listen to the heart, it knows. Listen to the silence, it speaks. Compassion, not just competence. Patience, not just protocol. Empathy, not just sympathy. Dialogue, not just monologue, is what we should do. And finally, we are too busy. In class 4, Radiant Reader, my book in English, I don't know any of you have read, had this poem called The Leisure by W.H. Davis, which said, "What is life if full of care? We have no time to stand and stare, no time to stand beneath the boughs and stare as long as sheep or cows." So don't hurry up. Take your time. There's a lot that can be heard. There's a lot that can be said without speaking a word. I've spoken for over half an hour, but all this to tell you, silence speaks just as loudly. Thank you very much.
Can I have a standing ovation for Dr. S.K. Tyagi, sir? Perfect example of non-verbal communication. We are enriched by your wisdom of knowledge, sir. Sir, Padma Shri Dr. Vijay Prakash, sir. एक चेयर ऊपर और भेज दीजिएगा, प्लीज. पद्मश्री डॉक्टर हेमंत सर, मैं आपको रिक्वेस्ट करूंगा अभी आ जाएं. And in this August gathering, I welcome माननीय मंत्री अशोक चौधरी जी का, जो कि बहुत ही व्यस्त थे, उसके बाद भी समय निकाल के हमारे बीच में आए हैं. कार्यक्रम अब समाप्ति की ओर है. May I request our chief guest, Mr. Ashok Chaudhary sir, to kindly felicitate our chairperson sir first, Padma Shri Dr. R.N. Singh sir.
Padma Shri Dr. J.K. Singh sir. Padma Shri Dr. Vijay Prakash. And Padma Shri Dr. Hemant Kumar sir. Yeah. Padma Shri Dr. Hemant Kumar sir. Some felicitation of the guests, sir, जो लोग आए हुए हैं, sir. Dr. R.R. Kanaujiya, sir. Is he here? Dr. R.R. Kanaujiya. Sir, आप आ जाइए sir, stage पे sir. आ जाइए, आपका sir मोमेंटो मिलना है sir. आइए sir. Sir को लेके समशुल. Dr. R.R. Kanaujiya, sir, please. लेके आ जाओ. डॉक्टर कमरुल होदा, डॉक्टर कमरुल होदा, उसके बाद डॉक्टर मनोज चौधरी सर,
है सर,
शमशुल सर को, डॉक्टर कमरुल होदा सर प्लीज, डॉक्टर मनोज चौधरी सर हैं, Dr. Carlotto, she has come all the way from Spain. Dr. Carlotto, please. Dr. Abhineet. Dr. Abhineet के बाद Dr. Sudhir Kumar Singh. Dr. Sudhir Kumar Singh, then Dr. Amardeep Narayan, सुशील डॉक्टर सुधीर का है, सुधीर, इसके बाद डॉक्टर अमरदीप नारायण, देन डॉक्टर अर्नब सिन्हा, डॉक्टर सुधीर कुमार सिंह, डॉक्टर अर्नब सिन्हा, डॉक्टर राजकुमार, अमरदीप का आएगा, अरुण आपका भी आएगा, डॉक्टर राजकुमार, डॉक्टर अर्नब सिन्हा पहले, सुशील आपका गया, डॉक्टर सुशील कुमार सिंह प्लीज, सुशील है, डॉक्टर सुशील कुमार सिंह, डॉक्टर अर्नब सिन्हा, डॉक्टर अर्नब का है ना, डॉक्टर अर्नब सिन्हा के बाद डॉक्टर राजकुमार, डॉक्टर राजकुमार, आर यू हियर? डॉक्टर कैप्टन संजीव कुमार, डॉक्टर राजकुमार प्लीज, डॉक्टर जानकी बदानी, डॉक्टर संजीव कुमार प्लीज, या डॉक्टर संजीव कुमार, उसके बाद डॉक्टर जानकी बदानी. आई विल टेक 5 minutes ऑफ योर्स, क्योंकि ये डॉक्टर्स को जिन्होंने बहुत कुछ किया इस कॉन्फ्रेंस में, डॉक्टर जानकी बदानी, देन डॉक्टर नासिर अली फ्रॉम बेतिया, बस तुरंत हो जा रहा है, तुरंत से खत्म करो, डॉक्टर नासिर अली, डॉक्टर प्रभात प्रकाश फ्रॉम मोतिहारी, डॉक्टर प्रभात प्लीज, डॉक्टर जानकी, डॉक्टर नासिर प्लीज, उसके बाद डॉक्टर प्रभात प्रकाश, उसके बाद डॉक्टर ए के मानव सर, डॉक्टर ए के मानव सर नहीं है, डॉक्टर अनिल कुमार पटना, डॉक्टर अनिल सर, डॉक्टर रजत चरण, डॉक्टर प्रवीण कुमार दरभंगा, बदानी, डॉक्टर जानकी बदानी का, डॉक्टर प्रभात प्रकाश, डॉक्टर प्रभात प्रकाश, डॉक्टर जानकी बदानी, डॉक्टर रजत चरण नहीं है, डॉक्टर प्रवीण कुमार दरभंगा, डॉक्टर गौरी शंकर नहीं है, कुछ नाम और भी है वहां पे, एक नाम वहां पे डॉक्टर अरुण कुमार का था, एक बिहार शरीफ का, किसका है? डॉक्टर प्रवीण, हाँ प्लीज प्लीज, अरुण कुमार बिहार शरीफ है ना, दो, अच्छा बस हो ही गया सर, 1 मिनट इनसे बुलवा के हो जाता, अच्छा ठीक ठीक, लंच की तैयार है सर, हाँ अरुण का, डॉक्टर शमशुल होदा, डॉक्टर अरुण कुमार फ्रॉम बिहार शरीफ, अरुण, हाँ, डॉक्टर शमशुल होदा, डॉक्टर शमशुल होदा, शमशुल होदा, और अब मैं रिक्वेस्ट करूंगा पद्मश्री डॉक्टर विजय प्रकाश सर से और डॉक्टर हेमंत कुमार सर से, डॉक्टर शांति रॉय मैम, हमारे माननीय मुख्य अतिथि का सम्मानित करें। डॉक्टर अशोक चौधरी सर का एक शॉल, मोमेंटो प्लीज। मैडम आप भी आ जाइए। हेमंत सर बुके वहां दीजिए। Sir, may I request you for your some kind words, sir?
Good afternoon, everybody. मैं sitting on dais, पद्मश्री डॉक्टर शांति राय, पद्मश्री डॉक्टर विजय प्रकाश, पद्मश्री डॉक्टर हेमंत जी, हम लोगों के अभिभावक आर.एन. सिंह साहब अभी उतर गए हैं, ही वॉज ऑल्सो पद्मश्री। तो मैं समझता हूँ कि मैं लकी हूँ कि आज जितने पद्मश्री होल्डर्स हैं बिहार के, सब यहाँ पर बैठे हैं और हम उनके बीच हैं। ये सब तो हमारे सीनियर हैं, इनके जैसे यहाँ पर बैठे हैं। हमारे डॉक्टर हिमांशु भी बैठे हैं, ही इज़ अ वेरी डियर फ्रेंड ऑफ माइन, शांति राय जी के लड़के। तो हम तो इनके सामने एक बेटे की तरह हैं। और जितने डॉक्टर्स यहाँ पे बैठे हैं, ज़्यादातर डॉक्टरों को मैं पर्सनली जानता हूँ, क्योंकि मैं पटना में पढ़ा हूँ, पटना ही में रहा हूँ। आई नो पर्सनली एवरीबडी। और स्पेशल हम थैंक्स देते हैं अमूल्या जी को। He wanted me to come on 27th, but I got confused कि it is on 28th. So when he messaged me, I was in Kamakhya, so I told him कि I can't come. I will come back on 28th morning only. Unfortunately, I missed that 27th evening program, but fortunate enough that today he has called me up in the morning and said, हम बोले कि नहीं, हम पक्का compensation के लिए हम आएंगे ही आएंगे. Amulya ji is 2 generations I known to him. My father and his father, mother, they were quite close. Now ही इज़ लाइक माई एल्डर ब्रदर। हमको कभी भी कुछ प्रॉब्लम होता है तो इन्हीं को फ़ोन करते, पैर हाथ में जब भी नट बोल्ट की ज़रूरत होती है तो आई ऑलवेज यूज़ टू कॉल हिम। और मेरे जान पहचान में भी किसी का होता है तो हम इन्हीं को फ़ोन करते हैं। सो विश यू ऑल द बेस्ट। पूरे जगह से, पूरे बिहार से और दूसरे जगह से भी, कंट्री से भी हमारे लोग आए हैं। एंड अमूल्या जी इज़ क्वाइट सोशल इन दीज काइंड ऑफ एक्टिविटीज़। आई गिव हिम ऑल माई गुड विशेज़ टू हिम। यहाँ पर मंजू गीता मिश्रा जी भी बैठी थी, ऑल जितेंद्र भैया भी आए हुए हैं। एवरीबडी इज़ क्वाइट नोन टू मी फ्रॉम बिफोर। और पूरा का पूरा जो मेडिकल फेटर्निटी का जो टॉप ब्रास है वो यहाँ पर बैठा हुआ है। आई एम लकी दैट आई एम पार्ट ऑफ इट। थैंक यू वेरी मच।
थैंक यू सर। मैं इनवाइट डॉक्टर नवीन ठक्कर सर, हमारे इंडियन ऑर्थोपेडिक एसोसिएशन के प्रेसिडेंट हैं, जो अहमदाबाद से आए हुए हैं, टू हैव अ फोटोग्राफ। एंड इवन डॉक्टर उमैर सर, प्लीज प्लीज। उमैर हैज कम ऑल द वे फ्रॉम आयरलैंड। ये हमारे Thank you, thank you. Lunch is ready. Please have lunch. Thank you so much. मैडम सब लोग लंच के लिए, मैम कौटिल्य हॉल में लंच है मैम, प्लीज। हाँ चलिए ना।
ये हाँ सर का वही बोल रहे हैं, आप लंच के लिए चलिए सर। इसको कोई रखेगा, कौन रखेगा?
इसके साइज के साथ पीछे, हाँ 2-3 ले लीजिएगा। ये आ रहा है नीचे का पूरा। थैंक यू।
आ रहा है। एक और